Sunday morning for Jai Mehta, Ahmedabad may be second home. So most of the times, or you had already been yesterday also for some other purpose, but you and Maulik both are inquire little bit about TYAcon or AYA and TYAcon. Dr. Chitalkar is the president, vice president at present and founder member of TYAcon, and this is the 14th national conference. So thank you, Dr. Chitalkar sir, for providing us a platform. We had wonderful yesterday whole day scientific program as well as on Friday there is some survivors program also. And today's our topic or today's our conference has been for the bone and soft tissue sarcoma as well as oncofertility. And then last topic for the survivor speak. So if we start in the first session, I'm inviting Dr. Maulik Bhansaria, radiation oncologist at SIMS Hospital, and Dr. Nahus Sailani, medical oncologist at Zydus Hospital. Please, sir. You both are one by one inviting the speaker. Over to you, sir.
Sir, thanks a lot. It's a very nice and fine Sunday morning. Yes, it's a weekend on Sunday morning, so we have very less of presence, unfortunately. It's
Even immediate and prompt reply also. Yes. For one case, he is already out, but he is in Ahmedabad. But by just on Monday, he replies me again for final reports of, especially for sarcoma.
Opportunity is very important for us as a clinician, and thanks a lot, sir, for the
Thank you, everyone. And really, Ahmedabad is like a second home, what Bhavesh Bhai said. And I'm so thankful to Dr. Chitalkar and Bhavesh Bhai for having me here. And this is such an interesting concept, which I completely kind of, profess ignorance. I wasn't aware of this, and something about this is going on for 14, 15 years. Is quite amazing. I'll try to do justice to it. And a lot of it is, part of the treatment related thing. So please correct me if I'm wrong. I'm going slightly out of my kind of comfort zone in talking of the treatment part. But so the AYA sarcomas, while sarcomas in adults, not a very huge numbers, they do form a lot, kind of a huge proportion for say pediatric cancers, about 6 to 15%, and about 11% for the AYA cancers. Rhabdomyosarcomas more common in children younger than 7 years, so more of the pediatric age group. But there's a nice another incidence peak during adolescence where you get the alveolar rhabdomyosarcomas. And I'm going to allude to why molecular testing is very important for alveolar rhabdomyosarcomas. Ewing sarcomas, the extra-osseous type, more common in children and young adults, but the osseous type has a nice peak incidence in the adolescent age group. So a lot of focus thing for this particular meeting that we are talking on. The synovial sarcomas also very common in this particular age groups. MPNSTs, malignant peripheral nerve sheath tumors, epithelioid sarcomas, alveolar soft part sarcomas are rare sarcomas, but having said rare, but they are more common in this particular age group. Fibrohistiocytic sarcomas are across the spectrum, but they have a fair share in the AYA population as well. So these sarcomas in this particular age group have distinct biology, clinical features, and very strangely, they have a prognosis which is typically inferior to their counterparts in the pediatric age groups. They tend to present with symptoms at an advanced stage, a higher stage, and therefore is kind of reported to contribute to this worse outcomes. Also, very interesting is this is the age group where the genetic predisposition syndromes are associated with this tumors here. So the Lee-Frohman syndromes, the NF1, RB1, and so on and so forth. Now, what is the significance of age in the diagnosis of sarcomas? The childhood tumors, the pediatric ones, typically are what we as pathologists call them as round cell tumors, primarily treated by chemotherapy or radiation therapy. Usually, surgery is deferred for post-LACT or for residual disease versus adult tumors, which actually require surgical excision, and they may or may not merit adjuvant treatment in form of radiation plus or minus chemotherapy. The pediatric tumors have very specific management protocols vis-a-vis the adult or the AYA group sarcomas, which would just need some kind of a surgical approach. So importantly for childhood tumors, the prognosis depends on the type and then the stage, but for the adult tumors, it's mainly on the grade and then the stage. So there's a dichotomy here and which needs to be assessed by the pathologist. Just going to run you through some cases just to get an understanding of how it will make a difference if you did a thorough investigation. This is an 11-year-old male who had acute abdomen. There were some enlarged iliac lymph nodes, and an EB core biopsy was done. And there are not many pathologists here. Actually, I think there are no pathologists here. So you'll have to believe what I say. This is what we call a malignant round cell tumor, and it's marking with the markers of myogenic differentiation, desmin, myogenin, and myod1. So essentially, the diagnosis here, and I'm not showing you the negative ones, it's rhabdomyosarcoma. Question is this 11-year-old? Is this an embryonal rhabdomyosarcoma or is it the solid variant of alveolar rhabdomyosarcoma? Why is that important? It's important because you need to document something called a fusion. There's a PAX-FOXO1 fusion, which you need to document for all rhabdomyosarcoma cases. And I'll tell you why. So, although historically, as pathologists, we've been doing this alveolar subtype and embryonal purely on what the histology looks like, that's not so now. It all depends on the PAX5, PAX3, or PAX7 FOXO1 fusion because that determines the risk stratification, therapeutic protocol assignment, and prognosis. And it's the prognosis for these fusion positive alveolar rhabdomyosarcomas is significantly worse versus the fusion negative ones. And the fusion positive ones, therefore, require more aggressive therapy than the fusion negative counterparts. And this is something that you need to now understand is that this is a rhabdomyosarcoma, alveolar subtype, embryonal. The ones which are fusion positive is uniformly poor prognosis. But importantly, biologically, the embryonal variants and the fusion negative alveolar variants essentially are the same as far as the treatment goes and the biology goes. So what was hitherto kind of being subdivided on the histological appearance, the molecular underpinning has actually changed the complete biology of this disease. And it's just mandatory. You ought to just do it. If you got an rhabdomyosarcoma, you should be asking for this particular fusion in that. This is the molecular analysis that we did. It did show up MAX3 FOXO1 fusion. So this was the solid variant of alveolar rhabdomyosarcoma. It was straddling that age group where you weren't sure what it was. Nevertheless, it helped in the diagnosis, but also in the further treatment because, as I said, it requires more aggressive treatment. And these are studies, an Italian study which mentions about rhabdomyosarcoma differences in the adolescent versus the pediatric age group, and the adolescent age group tends to have unfavorable features like the alveolar subtype, nodal infiltrates, METZ diagnosis, and generally they have a worse outcome as compared to the pediatric age group. So this is round cell tumor, Ewing sarcoma. I'll just skip through some of these, and it's a highly aggressive type of tumor originating in the bone or soft tissues, but again, the osseous type mainly in the AYA such group. The age at diagnosis is inversely associated with the prognosis of these sarcomas, and they tend to have inferior survival compared to the pediatric patients, even when they are treated with a similar regimen. So that's kind of a paradox, and that's something that we need to discuss how to go about it. This was a very interesting case, and if you can just look at it, it looks very similar to what I showed you. This is looking like a Ewing sarcoma. This is in the neck of a 21-year-old male. This is actually a poorly differentiated synovial sarcoma. It was diagnosed as Ewing, started on that therapy, didn't do too well, and therefore sent for a consult opinion. It has probably the mid-2 positivity, what we call negative for something which is very specific for Ewing, NKX 2.2. This is the fusion SS18, SSX, which you now have antibodies to do it on IHCs. You can do it in one day and kind of obviate the need to do by FISH or RT-PCR. Important to know because Ewing would have been should be treated with chemotherapy and synovial sarcoma by surgery. So this is something that the pitfalls that one comes across. This is a conventional synovial sarcoma. I'm just going to skip that in to save time. Again, as I emphasize that neoadjuvant chemotherapy in adult patients with synovial sarcoma has not shown any survival benefit so far. So surgery remains the treatment of choice for synovial sarcoma. This is an alveolar soft part sarcoma, very typical, easy to kind of diagnose for histology, but it's a tumor which is focusedly seen between 15 and 35 years of age. It has a high propensity to metastasize and has a poor overall survival. Treatment of choice remains surgery, and you can actually give some anti-angiogenic tyrosine kinase inhibitors such as sunitinib. They might be useful. Malignant peripheral nerve sheath tumors associated with NF1 in this particular AYA group, 25 to 50% of the cases. The other ones are radiation associated or sporadic in nature. And when you tend to have this NF1, the response is poor to chemotherapy and the outcomes are even inferior. Myxoid liposarcoma is an uncommon liposarcoma, but if you do get that variant and they are associated with this first DDIT3 chimeric gene fusion, they're very sensitive to trabectedin and to radiation. It's very exquisitely sensitive. It's important to identify this subgroup and not mistake it, for example, different kind of a liposarcoma that you tend to get it in the thighs of adult patients. So this is myxoid liposarcoma. Again, there is an antibody called DDIT3, so you can obviate doing the FISH or the NGS for this. You can get this answer very quickly. There's also this epithelioid sarcoma, which is not so uncommon, but it's common in this age group. You have the classic distal type, acral type, and the proximal type tumors, and these look like carcinomas, also show you markers of epithelial differentiation, but they are actually sarcomas. They also metastasize to lymph nodes. This was an interesting case, a scrotal mass, which was referred to me, and this was a 36-year-old. It was variably called as a high-grade sarcoma, kind of a leiomyosarcoma sarcoma. But look at this morphology; it's got a very rhabdoid look to it. I'm sorry. It marks with epithelial markers cytokeratin and EMA, but also something that we is a vascular marker for CD34. This was actually epithelioid sarcoma. It also shows loss of INI1 expression, which clinched the diagnosis. And this is very interesting. Also, just a trivia here, epithelioid sarcomas express CA125. They're one of those tumors in males also. You might want to do a CA125 to actually monitor the progress of these tumors, and that's something unique to them. So what are the issues? I'll just find out quickly is that soft tissue sarcomas are not so uncommon in this age group. And improving survival, having said that, improving survival has been challenging in the past few decades because of treatment related and age related factors. The treatment related factors being under treatment compared with the intensive pediatric protocols. Sarcomas in this group also encompass the tail end of predominantly pediatric sarcomas such as rhabdomyosarcomas and of both embryonal and alveolar types. And there are some things like Ewing sarcoma, osteosarcomas, synovial sarcomas. So it's a challenge, to treat this particular sarcoma in this age group. Take-home messages from me for this particular thing is that for soft tissue sarcoma, is age is the first thing to ask, because you need to know how to kind of diagnose. Is it a round cell tumor? Is it a kind of a spindle cell tumor? Because round cell sarcomas are exquisitely chemosensitive, but you do need IHC for them. You can't get away by not doing an IHC for round cell tumor. Not so for spindle cell sarcoma. It really doesn't matter if you didn't do a kind of a exact what should I say, namkaran for it, if you don't have a name. But grade, it's very important to grade, because a treating physician needs to know if it's low grade or a high grade, if the margins are clear or not. That's the most important information that you need to give. Molecular classification is gaining traction, and targeted therapy more and more so for these tumors as well. And so what's the way ahead? Differences in outcomes between children and young adults with the same histologic sarcoma diagnosis are partly due to kind of the treatment associated factors, as I said. And are we right in treating with the same protocol in pediatric and not? I don't know. That's something that we need to discuss. And maybe there's increased collaboration and crosstalk required between solid pediatric oncology and adult sarcoma specialists. Maybe that will bridge the gap and make it useful for us to take this forward. So thank you very much. Your talk finished too early for our curiosity. I am. The timer was kind of counting down, so I just quickly.
So, it was a very difficult topic to cover within 10 minutes, but very nicely covered and very nicely highlighted. Sarcoma is basically even in adults. It's about pediatrics at the same time. But no, adults and pediatric older cases, we have seen that pathologists are very good at diagnosis and other things, but all histopathologists are not giving very specific diagnosis in sarcoma. So many of the times we have to get it reviewed. So the expertise at the level of pathology level, routine pathologist level should also be increased. We as a clinician should try to highlight and understand the in-depth of the aspects from the pathologist by human. And one thing very rightly said, sir, that the protocols for adult and pediatric are more or less very thin line blood protocols we are using. So we have to be very specific in that. And as molecular as we are very restricted.
Thank you. Thank you very much.
Thank you, sir. Now I would like to request Dr. Maulik to give moment to Dr. Jay.
अभिजीत सर
Dr. Sir.
Good morning, everyone. Dr. Abhijit Solanke is not there. On his list, Dr. Dhruv Patel will be the doctor. Thank you.
Good morning, everyone. Thank you for giving us the opportunity. Unfortunately, Abhijit sir is not available, and I'll have to cover his topic. So it was giving a surgeon's domain from the part of bone and soft tissue sarcomas in teenage and young adults. So we are a team from GCRI, Orthopedic Oncology, and our team is Dr. Abhijit sir, and we are Dhruv Patel and Nandlal Barwani. We are students. There is a fellowship in GCRI in Orthopedic Oncology. So the challenges we face in this young adults are the usually very large tumors. The osteosarcomas are usually very large. There is a lack of awareness, and patients present to us at a very late stage. Referrals are delayed, and we work at a government cancer center where there are always issues of funding and logistics. But we'll try to cover as much as part we can cover from the surgeon's domain in part of sarcomas. The most of the patients we see are less than 25, especially the EVINs and the osteos. So let's see from surgical point of view how we can help. The first we start with a biopsy, and we are using this virtual reality for two purposes in biopsy, where we can help with the new orthopedic surgeons and the surgical oncologists train how to take bone biopsies, and even we give this video to our patients to see. So there is less of a trauma to them, as a lot of patients have what is even is a biopsy, and will the disease increase after biopsy? There is an increase in pain after biopsy. So we just to show them, we see what is going to happen in the surgery, and there's a virtual reality. We give them a HoloLens kind of a thing, which they can see what the process is. Initially, painting dripping is done, local anesthesia is given. Sometimes, majority of the patients we give a short general anesthesia, and these are steps of incision, genital biopsy of a region of the calcareum. Usually, while teaching, we are also running a program with BJ Medical College UG students, where we have a group of 100 students, where we are comparing the results. That one group of students was given oral talk, one was shown a video, and the other was shown a virtual reality with the help of HoloLens. that is a Microsoft HoloLens, and teaching was done, and a survey is being carried out how comfortable they are doing the procedure at the periphery centers. So again, for us as surgeons, we have to go beyond and treat the patients. A majority of the patients of EVs or osteo are around 10 to 12 years of age, where even after resection, going 3 centimeters beyond the tumor, and reconstruction and growth is an issue. So we try to give them a expandable growing megaprosthesis in young children, where their height of the limb can be increased in a stepwise manner with this expanding mechanism. And there is a wormhole mechanism where every 6 months or 1 year we can increase the limb with a very small single incision just by rotating the screw. The size of the implant increases. This is an indigenous implant we had used in this patient, customized specifically for the patient. This is a case of a 11-year-old female proximal tibia Ewing sarcoma, which we had done, and expansion can be seen. You can see the golden part expanding and closing. So Ewing's pelvis, that is also a case of study, and usually what radiotherapy is actually helpful, but the meta-analysis that we have been doing that says that surgery plus RT is the way to go for a Ewing's pelvis. And this is the result. Even after removing the pelvis, we can give excellent results to the patient, where you can see the patient walking with a limb and good movements also. There is good knee flexion, good ankle flexion. The sciatic nerve was saved in this case. And you can see the patient walking with a limb without even a pelvis. So now we reach to the topic of 3D printed and augmented reality. This is the point of precision oncology, which is the most ongoing topic. This was a case of a scapula Ewing sarcoma, which we had used a 3D printed scapula to replace the scapula after excision, and we also used augmented reality in this case. So now you can see the PACS, the radiography inside the OT. You can superimpose the whole imaging on the patient during the surgery and feel like a handman. So this was the radiology. This was the segmentation, 3D segmentation that we had done for this case. Took the dimensions of the opposite scapula, reduced the dimensions of the new scapula that we 3D printed. We minimize the dimensions 20% so that there is no reconstruction and soft tissue issues while covering it. And now we wear a HoloLens inside the surgery, and you can control just everything like this. You can see the radiology. Sorry, this was a very fast forward thing and it will be difficult to. The chest wall can be superimposed on the patient himself. Even the scapula, the print we had done, we had 3D printed it, and again the CT scan of the implant was superimposed here. And so while excision, it is very easy for us to excise the part which we had planned pre-operatively. Even post-operative, intraoperatively, we can see the vessels and the veins and nerves which we had 3D printed. You can see the PACS here. Now coming to soft tissue sarcomas, this was a case of a synovial sarcoma, 15-year-old male boy in the popliteal region. This is a post-NACT case and it was just starting to fungate. So we had planned the excision. On planning, we got to see the nerves and the vessels are can be salvaged, but reconstruction was still an issue. So we went ahead with excision. This is a method we had devised to prevent spillage intraoperatively. Any fungating mass will have spillage intraoperatively, and so we just keep a gauze piece and cover it with IO bands. So there is no intraoperative spillage of the lesion. This is the skin incision capped and the flaps were raised. Eventually, dissection starts with dissection of the common peroneal nerve and the tibial nerve and the vessels. So you can see the CPN being isolated here, and we were able to get a good margin with a good base of resection. This was a tendon which was with the specimen which we had to sacrifice. But eventually there was a big, this is a vessel sealing device which we use to minimize blood loss. So you can cut the muscles without any blood loss, as the vessels are sealed intramuscularly, and that reduces the blood loss by quite a lot. Eventually we went ahead and did a skin graft of the patient. So complications. While doing this, we also treat with lots of complications and weird cases come in front of us. So this was a case of an exposed infected megavirus. The patient was going around with this type of humerus in the last 6 months. And we were also surprised to see this patient in the OPD. We can just pull out the implant like this inside the OPD itself, but we didn't do that and went with a two-stage reconstruction of this patient. Soft tissue reconstruction was an issue here, but the vessels, nerves, the distal neurology of this patient was intact, and so we went ahead with a two-stage reconstruction in this patient. And this is the intraoperative video. You can just, sorry. You can just pull the implant out. It's very easy. But reconstruction is not. We had to go. This is the shoulder joint, elbow joint, which was preserved, and we did a nail cement spacer for this patient. The shoulder capsule was built with a ET bond and a proline mesh. And this is a post-operative X-ray. You can see excellent movement at the wrist joint and the elbow joint post-operatively, and we were able to close this implant. And the last and not the least, but lot of patients present to us and have to undergo amputation. But it's the spirit of the patients that keep them alive, and it is very important to keep them alive psychologically and keep them motivated. Even we have to do some amputations, but we give them artificial myoelectric hand to this patient. Just a lamp there. This is a rotation plasty case of a rotation plasty, where the distal femoral osteosarcoma case, we went with the resection and did a rotation plasty. Patients are usually very difficult to convince for this surgery, but this kind of videos, we try to make them meet with the old patients which we have operated. Seeing them walk, this gives them a lot of confidence, and we are able to deliver good results with this kind of surgeries. It's kind of a modified amputation where we try to salvage the distal part. Just the sciatic nerve has to be preserved, and you can see excellent functions in this. Thank you. So life is a challenge, and the soft tissue sarcoma, we need to fight as a team. We need radiation oncologist, pathologist. In fact, nowadays I have started to communicate a lot with the pathologist, and there are difficult cases. In fact, we start to learn how to see the slides, and it gives a better impression to the patients also, and better outcomes to the patients. Thank you.
Dr. Jai Mehta also.
Yes, sir. Sure, sir. Sure, sir.
Physical pathology.
Sure, sir. Sure.
He's always helped.
Thank you, Doctor.
Yes, sir.
Yes, sir.
One is the 3D printed scapula that you showed. Is there a benchmark? How much you said 20% you reduce the damage?
So it's a patented product from Dr. Abhijit Salunke. So usually 20% is used because 30-40% will be very small scapula and the growing child, which usually it is EVs are it was a young patient. And if we keep it at 100% size, then the closure, because a lot of soft tissue and muscles is also removed with the scapula itself. So by taking the margin, there will be no skin closure, will be very difficult, it will be tight. So we had kept it at 20%. Sir.
My point is the other side, the scapula is of a normal size.
Yes, sir.
And here you reduced it, but so how
So actually the scapula, with the scapula, the shoulder rotator cuff is also removed. So abduction of the patient will not be coming, but it will give a better countering to the patient and a better psychosocial feel. When you tell a patient your scapula is being removed and you are not reconstructing it, and versus we are giving you a 3D scapula, the psychology of the patient is at a different level, and this is what we have observed. So functionally not much. The contouring of the shoulder is better in it, not functionally well.
And at that age, youngsters are very
And-
about their body image also.
Actually, yeah, and one thing, there is scapulothoracic movement at the shoulder joint. That is preserved. The shoulder joint movement is not preserved, but the scapulothoracic movement is preserved in these patients. So a little bit better functioning. Thank you, sir.
You covered this topic very nicely, starting from the biopsy, which is very basic, and up to the very advanced surgeries and use of processes and meta processes. You have also covered how in your department you are doing or using the latest technologies, AIs, and all these things to the betterment of the patient. So it is not only the cutting of the tumor, but also rehab is very important part because all is very nice. Thank you.
One unique question. All our implants are MRI safe.
Not really, sir. All this scapula implant was of titanium. It was MRI safe, but not all mega processes are MRI safe. You need to use a titanium for that.
Because I think, sir, we need to advise patients, or then they will ask you questions.
Sir, usually at our institute, the problem is a financial constraint.
Yeah.
So titanium implants cannot be covered with the help of PMJ Yojana that we majority of the patients undergo. So due to financial constraints, we explain them, but again, you cannot do half cash, half PMJ. You need to go with what we have available, and we try to give the best results with whatever supplies we have.
But at least you have to tell the
Yes,
patient.
yes, we do explain.
For MRI.
Yes, we do explain.
MRI.
Yes, we do explain it to them, sir. Pre-op counseling is very important for the types of implants that we use: Indian, foreign, rotating hinge, fixed hinge. There is a lot of implants available in the market, and pre-op counseling is a must.
But suppose that patient will come in follow-up in private hospital. Is there any file or where?
Yes, sir. There are stickers with the implants that we have given. Each implant that we use have usually have 5 to 6 stickers, and all the information from the size, company, everything has been mentioned in it. The patient has it. Yes, ma'am.
That age are very aware of their body imaging. So how long does the counseling takes for them to be normal or to be called normal, as they will think, okay, they are fine, they can move in
Ma'am,
society.
for the first 2 years, 3 monthly follow-up is a compulsory. We need to do CT scans and bone scans. CT scans we do 3 monthly, bone scans 6 monthly, and minimum annual follow-ups till 10 years is a must for this sarcoma patients we do.
No, that's a follow-up, the doctor. I'm talking about the psychological point of view. That, because the children are very, very aware of their body imaging, and they feel very shy going into the normal schools and things like that.
For this, ma'am, we have started, especially this happens in the amputees. So from day one, we start the mirror therapy for them. Physiotherapy and mirror therapy is a must. We advise them to stand in front of the mirror, look at their image. So slowly, they start getting they start adopting to it, and we try to give them process as soon as possible. As soon as the stump is developed, prosthesis. And ma'am, I tell you, you won't even get to know if a patient is amputated if he is walking in front of you. Such good processes are available right now. Ashwin sir would like to add.
Answer your question, madam. Honestly speaking, we don't have that robust system for psychological support, but yeah, individually we try and make them talk to the previous patients. We have some sarcoma support group where annually with such meetings, they talk to each other. While they are under treatment, we try and make them talk to the previous patients who are cured, who are now pursuing a good career, like engineer or something. And that is how we try and mitigate the damage that is being done. But honestly, we don't have that much robust system. But yeah, we are trying at our level to.
Ma'am, for the in government sir.
Get the process, so they know that they are not.
Honestly, not.
No.
We have it's not like the patient who is under the chemotherapy, who is going to go undergo a surgery, and they will live in this meeting. No, it's not like that. But yeah, when they are under the treatment, we try and individually, like, we will give them a reference of some other patient. We'll make sure that they talk. Because sometimes they may not be able to ask some
We cancel it.
Yeah,
Because of time. Can the doctor only tell us about triage?
That
But
the
the
initial
sheer load,
stage.
sheer load of these hospitals are so much that it's not possible for us to mitigate it completely. We are trying at an individual or at some small body. And sir, to answer that MRI safe, so basically, even if you put an SS implant, after a year, you can do the MRI. It's not they are not safe. It is just that if you have to image that specific area, the quality of that image, even with Mars sequences in MRI, will not be good. If you use titanium and you do the MRI, you will have a better image.
Better image.
Physically with SS also, you can do the MRI. That's not that it will just come out. If there is an external fixator, means outside the body, then it's not safe. But any process which is inside, it's safe. But compatibility is
The quality of the imaging is actually, sir, not that good in that cases. And
Yes,
Thank you.
and just to add to Madam's question, and I completely agree with you. Uh, More of the pre-surgical counseling is for convincing the parents. Children counseling, actually, I've seen because I was part of GCRI. It starts after surgery, when the trauma or the damage kind of already has been done. But unfortunately, these children who are 10, 12, 15 years of age, they are not that mentally developed. They are not coming from that strata to understand the thing. But yes, eventually a child adapts to the environment. They are natural fighters. So most of them, they do recover within weeks. This is the time it is taken by like the stories are lost, they are kind of falling into the next class. So it is a mental trauma which takes 2 years at least to catch up, but eventually they come up.
So there is support that, we do the advocacy for those children in the schools that, okay, if they have missed 2 years, is there any special classes that they can attend? Or there are like online things?
So usually schools don't do supervision, they are all supported. If it is up to 6 months of them. I don't think yeah, then the any school is going to support it.
That we had discussed on the Friday also, there is a school teacher, and they told that generally in that type of school children, we already tell them to upgrade or from fourth standard to fifth standard, even if
So
we
if the standard is being less, like the second standard where it doesn't make much difference, then they do catch up. But usually these children who are at 10, 12 years of age, they are not in first, second, third standard.
As per discussion on Friday, till 8th standard they are promoted.
Yes.
After 8th, they have to repeat. Yes.
Thank you, Dr. Dhruv. Thanks a lot. I will request Dr. Nahush to give monitor to Dr. Dhruv. So for next talk, I would like to call my professor. He need no introduction, Dr. Rajesh Pandita.
So in teenage and young adolescent, soft tissue sarcoma, especially like synovial sarcoma and pleomorphic sarcoma, we treat like adult sarcoma. And for rhabdomyosarcoma, chemotherapy protocols, we use pediatric protocols. And the most common sarcomas in these age groups are bone tumor. And among them, the most common is osteosarcoma and the second most common is Ewing sarcoma. So I will be discussing systemic therapy of these two common sarcoma, osteosarcoma and Ewing sarcoma. And we know that we last 2-3 days we have discussed the challenges during these development years, and this age group is differ from pediatric and this age group is differ from adult, and even the malignancies in these age groups are different. And we in this age group the most common malignant 35 to 39 year, the cancer incidence is the highest. And in earlier age the common malignancies are lymphoma and leukemia. And in 35 to 39 year, the common malignancies are breast, tongue, thyroid, and testes. So if you see the young person's bone tumor, the primary bone cancers demonstrated wide clinical heterogeneity, and this accounts approximately 5% of all malignancy. Among them, in adults, the most common is chondrosarcoma, but in early teenage and young adolescent group, the commoner malignancy are osteosarcoma and Ewing sarcoma. So these outcomes can be in young person's bone tumor. There are multiple issues because of there is a lack of clinical trial specific to AYA age group. There is lack of guidance on transition of care. There is lack of dedicated AYA oncology centers, and there is no standardized tool to assess health-related quality of life in this age group. So first, I will discuss the systemic therapy of Ewing sarcoma. Ewing sarcoma is an aggressive sarcoma of bone and soft tissue occurring at any age, but peak incidence occurs in adolescent and young adults. These are small round cells arising in the bone and soft tissue. It is second most frequent bone sarcoma after osteosarcoma in patients with younger than age 20 years. It is named after James Ewing. He in 1931 in Times magazine, he was named as a cancerman Ewing. He founded oncology as a medical subspecialty, and he was the first director of MSKCC Cancer Center. If we see the demographics, it is in first decade around 15 to 20% of Ewing sarcoma occurs, and in second decade 75 to 80% of the Ewing sarcoma occurs, and after third decade it is very rare. If we see the localization, around 50% are axial and 50% are appendicular. The most common site is pelvis, and in appendicular skeleton, the most common site is femur. If we see the metastasis at presentation, it is present in localized form in 75% of the cases, and around 25% it is metastatic at presentation. Around 15 to 20% of Ewing sarcomas are extraskeletal at diagnosis, and the common site of extraskeletal Ewing sarcomas are chest wall, paravertebral muscle, buttocks, and retroperitoneal space. There are various prognostic factors for Ewing sarcoma. Among them, the commoner are minimum residual disease, response to therapy, age, serum LDH, tumor volume, stage, and site, whether it is axial or appendicular. If we see the evolution of systemic therapy in Ewing sarcoma, in 1920 it was first named by Courtman, named after Ewing, and the 5-year survival was almost 0%. And in 1960, this wake chemotherapy was used, and in 1980s, etoposide and ifosfamide was added. Role of bone marrow stem cell transplant was also evaluated, and in 2000, the role of PET scan was evaluated. The survival from 0% to 75% what we have achieved in a localized Ewing sarcoma in this century, in the last century. And unfortunately, in this century, we have not done much in soft tissue sarcomas or bone tumors. If we see the pathology, these tumors have membrane localization of CD99. NKX2 is also potential IC marker, and it can morphologically mimics to other round cell tumors and round cell sarcomas. This tumor is especially characterized by special translocation, that is translocation 1122, and there is a type 1 fusion which is seen in 60% of the patient with exon 7 and exon 6 with EWS and FLE, and in type 2 translocation it is exon 7 in EWS and exon 5 in FLI gene. There are rarer other translocation like 2122, 722, 1722, and 222. These are also seen, but the second most common is translocation 2122. Circulating tumor RNA in patients of Ewing sarcoma are prognostic factors. If we are finding out the ctRNA in the peripheral blood, then the chance of recurrences are high. Management depends whether it is a localized disease or localized high-risk disease or metastatic Ewing sarcoma. And the first phase 3 trial was ISS-1 trial. Here they compared VACD versus WAC regimen, and local control in VACD arm was 96% compared to 60% in WAC arm, and VACD became the standard of care. Then came ISS-2, where they evaluated the role of escalated dose of doxorubicin and VCD compared to conventional dose, here EFS was 75% compared to 56%. Then came intergroup 0091 trial. Here they evaluated the role of ifosfamide and etoposide, and what they find out that using WAC-IE gives better treatment option, and there is a chance of 69% survival compared to 54%. Then came dose compression of WAC-IE 2 weekly versus 3 weekly, and here the survival was 73% versus 65%. Role of autologous stem cell transplant was also evaluated, but unfortunately, there was not much benefit even in metastatic and locally advanced Ewing sarcoma. The role of whole lung irradiation was evaluated, and NCCN and ESMO recommends it in lung only metastasis. Patients who have only lung only metastasis, then we can give lung bath with 12 to 20 gray. Recurrent Ewing sarcomas have a dismal prognosis, and recurrent and metastatic both have dismal prognosis, and the prognosis depend whether the recurrence is earlier or late. Earlier recurrence have worse prognosis compared to late recurrences, and intent becomes palliative only. So to WAC-IE regimen was adopted as standard therapy, and interval compression with WAC-IE is a new standard of care. And in metastatic Ewing sarcoma, the survival is 5-year survival is only 20%, and intent is palliative. Next common sarcoma is osteosarcoma. Here, this is most common malignant bone tumor of childhood and adolescent age group. And we use here polychemotherapy with a different agent, with a different modes of action, with minimum overlapping toxicity, with maximum dose intensity. Various drugs used are methotrexate, doxorubicin, cisplatin, cyclophosphamide. Earlier, people used nitrogen mustard, mitomycin, and vincristine. The first randomized trial in adjuvant setting came in 1981. Here they used various chemotherapy regimen like doxorubicin and high-dose methotrexate. And here they find out that 5-year DFS was 55 versus 20%, and 5-year overall survival was 80% versus 48%. Then came the concept of neoadjuvant chemotherapy, and hypothesis was made like that if we give neoadjuvant chemotherapy, we might improve the limb salvage rate, or it take care of micrometastasis. And initially, it used to give time for better planning of the surgery. Then POG trial, they compare head-to-head neoadjuvant chemotherapy versus adjuvant chemotherapy, and what they find out that there was similar event-free survival and there was similar overall survival. So neoadjuvant chemotherapy does not improve survival. But if we give neoadjuvant chemotherapy and we look for the necrosis, it is a prognostic factor. So patients who had good necrosis had higher chance of 5-year survival compared to those patients who had poorer necrosis. Then based on necrosis, they tried to escalate the dose with chemotherapy like ifosfamide and etoposide in Euromos 1, but unfortunately, there was no benefit of addition of ifosfamide and etoposide in patients who had poorer necrosis. Then in India, and especially in countries where giving methotrexate is a challenge, high-dose methotrexate is a challenge, then the role of methotrexate free regimen was evaluated, and the study from Tata, that is OGS 12 protocol, was done. And here they gave 4 cycles of neoadjuvant chemotherapy with cisplatin doxorubicin or ifosfamide doxorubicin, and surgery was done. And what they find out that at the median follow-up 34 months, 5-year event-free survival and overall survival was 56% and 75%, which was acceptable. So in many centers in India, people use OGS 12 protocol also. So to conclude, adjuvant chemotherapy in osteosarcoma improved both disease-free survival and overall survival. There was no relapse-free survival benefit between neoadjuvant and adjuvant chemotherapy. Necrosis is a strong predictive and prognostic factor post neoadjuvant chemotherapy, but tailoring the treatment based on necrosis, there is no advantage of it. And high-dose methotrexate has given survival advantage, but administrating this regimen in rural sector is challenging. That's why many setups use OGS protocol. And AYA bone tumor or even in soft tissue sarcoma, there is a long way to go. I think in last 1 decade or 2 decade, nothing much has happened in a systemic therapy in this particular tumors. And like what we are seeing in the lung cancer and bone breast cancer, here a lot has to be done. Thank you.
So, thanks a lot for the very nice talk, Dr. Manish. As you rightly highlighted, and as we really practice that in osteo and healing center, we start with neoadjuvant therapy. So a question to you also and to the ortho also, uh, which patient subtype you would directly like to operate?
So, sir, in osteosarcoma, like those patients who are low-grade osteosarcoma, paraosteal osteosarcomas, there is no role of chemotherapy. So those patients should undergo upfront surgery. Otherwise, most of the patients we give neoadjuvant chemotherapy. Though in osteosarcoma, there is no benefit of neoadjuvant chemotherapy in terms of event-free survival or overall survival.
But this request of the chair to further highlight on this low grade RS and
So what we, what Dr. Rajesh says is, you say that, this partial osteosarcomas are a different subtype, they're very low grade. In fact, it's even difficult to make a diagnosis unless, and for most bone tumors, you need to have the radiology colleague actually backing you up. It's a very different kind of a sarcoma. It's so well differentiated, you can't even make out it's an osteosarcoma. So those are the subtypes that may not respond to chemotherapy, and therefore doing a surgical resection makes sense in that. Next question about the UV part, maybe you can answer that.
So, Ewings, we are giving neoadjuvant chemotherapy to all patients.
Absolutely.
And one question, since it came up to you again, we know that the teaching is that we should send the image also to the pathologist. What is the current state in the AI?
Not sure for the AI part, but I mean, I don't report any brain tumors or bone tumors unless I have the TYAcon pages and I get my radiology colleagues to review it for me. So one should resist from doing it. It's very dangerous. But sometimes I have refused cases. I said I will not report unless I get pages to see.
And second question, like how comfortable you are giving interval compressed chemotherapy? Like how many of your patients they do tolerate well the interval compressed chemotherapy,
Sir.
especially the healing one?
So giving interval compression is a challenge, especially in rural setting. If patient is coming from rural background and far away. So I advise to my students also, if you can't give, don't push everyone for compressed chemotherapy. If some patient die of febrile neutropenia and sepsis, then Ewings are out. What we are getting AFS and OS, it will be equal. So if patient is motivated, family is motivated, then we are giving dose compressed chemotherapy.
In my practice, at least I think 50% of the patient they do develop difficult cytopenias to take care of, and eventually, like we start up with the interval compressed for 2-3 months. Initial 3 months is okay, but eventually they'll end up with the 3 weekly regimen. So thank you. That's from my side.
So, I will request Dr. Maulik to give a memento to Dr. Rajesh Paidal. Thank you, Rajesh sir. Our next speaker is Dr. Jifmi Josh. She's there. She will be talking about role of radiation advances in sarcoma of the young people.
Good morning, one and all. I'll be speaking about the radiation advances in sarcomas. So I prepared the talk thinking that's 20 minutes, so I'll try to rush through my slides and finish it off in 10 minutes. So if we have to talk about radiation advances, unfortunately, unlike chemotherapy, we don't have such rapid advances. But of course, we have advances in the last 5 to 10 years. So I will be dividing my talk into two segments. The first is reducing side effects in children and young adults. So, and the ways how to do it and understanding it. And the other would be better survival. So, towards understanding the side effects. So we need to know, of course, radiotherapy is one of the pillars of oncology management, and it's been utilized since the early 20th century. And it is essentially the use of X-rays or particles from an external treatment unit, which is focused onto the area that has to be treated, that is essentially the tumor or the tumor bed. So why is the first in children? It's essentially because the blue line and the orange small interrupted line that you see is that of, is this a marker? So the blue line and this line would be toxicity, and this is for survival outcomes. So this is there in everybody, as in even in adults. And the more the radio resistant the tumor is, this gap gets closer, and hence you have a higher probability of getting uh, acute and long-term toxicities. However, in children, what we also have is this line that signifies developmental toxicities, which happen very much early and very much early on the dose, as in we have it depends on the organ, it happens in 10 to 20 gray, while most of the radio sensitive tumors also require around 30 to 40 gray. So that is why there is a huge fuss in the use of radiation in children. So Quantec, I'm not sure if how many are aware about this. It is the use of, I mean, the dose constraints of using radiation in the clinic, yeah, and it's mostly coned down to those that we need in adults. So we did realize, I mean, a decade before that these dose constraints couldn't be used in children or extrapolated in children, essentially because they are different. They cannot just be considered a smaller variation of adults, because their tissues are different. They have a mosaic of tissue, and the spatio-temporal distribution, as in it changes within the age group, also within multiple age groups. Like it wouldn't be similar in a 5-year-old compared to a 10-year-old. So there is a mosaic of tissues, and we need different ways of handling it. So sorry, so despite there being functional reserve in adults as well as in children, the functional reserve, in addition to other factors in the adult, pediatric differs with various factors, which I've enlisted here, especially about the developmental dynamics and the regenerative potential. And it varies between organs. So definitely the effects of radiation in the cellular and subcellular level is similar in adults and children, but the way the body reacts is different in children. So of course, there was this huge movement that happened, that is the pediatric normal tissue effects in the clinic, that's called the PENTEC. And they went on to have a systemic analysis about the dose constraints, what we could gather from the published literature. So to begin with, only they did realize that there would be various challenges. So the main that I would want to emphasize is that there would be a lot of lack of information, and even if there is information, there wouldn't be uniform standard of reporting of toxicities as well as dose constraints. The next being, there would be paucity of data coming from those planned with the CT era. I hope you understand. So there has been a technological advancement in radiotherapy. Initially, we used to plan on X-rays or clinical marking. So then by the 1990s or 1980s, you may say, we switched towards using CT scans to plan radiation. So then you had better clarity, better delineation, better conformity. So if there is paucity of data, then the dose constraints that we achieve wouldn't be very realistic. And the other thing is that the long-term adverse effects data should be sorted out. The therapy and technique also advanced over these many decades. So despite knowing all these hurdles, then why even embark in such a journey? So it is still relevant because most of the population, the pediatric population with cancers, are still in the developing nation. So they would be still using primitive techniques. So it would help them. We would know what we have done in the past, and this would help us predict the future better, and also have mitigation strategies in a better way. So reasonably, you have accurate estimates. So in that way, we had a dose constraint for the cardiac. The main point is that anything less than 10 gray doesn't increase the risk pretty much. And 100 milligram of anthracycline was equivalent to 10 gray of mean dose to the heart. As in the CNS, we have that 18 gray of whole brain radiation led to a subsequent decrease in the IQ, that is less than 85%. And in the vertebra, we found that around 15 to 20 gray would lead to growth perturbations. So what do we do for that? We try to smear the vertebra with a uniform dose of 15 to 20 gray. Even if we have to give a higher dose to the tumor, we would try to smear the vertebra with 15 to 20 gray. So that way we avoid asymmetric growth perturbations and have a symmetric growth perturbation. So there would be decrease in the height, but you would still avoid scoliosis and kyphosis, which is quite cosmetically bad in outcomes. So in the breast, even with 0 gray, they found that there would be a 15% hypoplasia. That is essentially because there would be other therapies also. There would be hormonal factors, there would be surgical and chemotherapeutic factors also that would lead to hypoplasia. But around 5 gray, around 5 gray would cause 95% breast hypoplasia probability if there is 5 gray. I'm sorry. So the reproductive system, any dose close to 2 gray would lead to acute ovarian failure as well as oligospermia. And this would also depend on the cumulative cyclophosphamide effective dose. So higher the dose, lesser the radiation is required to cause that same acute ovarian failure. So with second malignancies, what you have is that meningiomas is the highest that is documented. That is essentially because the data on second malignancies is more with CNS tumors, irradiation CNS tumors. So you do get sarcomas as well, and it is the younger the patient is when they receive radiation, the higher the possibility of having second malignancies. So with this, they concluded that there is a high functional consequence and there are no absolute cutoffs as such, but it's essentially a continuum. So we went on to have our data from our institute, and we did have similar constraints that we found in our patients, essentially for skin toxicity, for oral cavity toxicities like acute mucositis and dental caries. And it is yet to be published. So moving on to technique. So as I mentioned, so this is 2D RT in which anything between the two jaws gets treated. Moving on to 3D CRT, you had some more conformity. And with IMRT, intensity model radiotherapy, you had pretty much sculpting. But still there was quite a bit of tissue that received low dose radiation, and that would predict your SMNs, second malignancies that you would have. So moving on to the era of proton therapy, we essentially have a benefit because there is an SOBP that you have with protons. So the tumor falls within this. And yes, so there is very less entry dose and there is nil exit dose. So you try to save a lot of tissue. So this is one of the patients in which we've compared the proton and photon plan, and you can see the sculpting of the 95, 98% dose, though they look a little similar, the low dose is very different between proton and photon. So the acute toxicities are there, but they are manageable. So the data on pediatric chordoma is good. It is around 5 to 10% better than that reported in photon. RMS, it's pretty similar, photon and proton data. In Ewing sarcoma, especially when there is dose escalation, there is a benefit of 5 to 10% with the use of proton therapy, and the toxicities are better. So it is very difficult to develop level 1 evidence with proton therapy in children. It's essentially because there's a lot of ethical concerns. When you're very much aware that there is a difference in dosimetry, it's difficult to ethically have a clearance for that trial to effectively give photon when proton also could be given. So we already spoke about this. So still, you cannot give it to all patients there because there is a prohibitive cost for proton therapy. So you need to justify who to give it for. So what the choice for proton therapy is essentially for chordomas. In extracranial tumors, it's chordomas, RMS, and Ewing's majorly because they are the ones that require high dose. So there are consensus statements and model policies in which they advise sarcomas and skull-based tumors to be considered for protons rather than photons. So we need to use fertility preservation strategies. So most of the strategies within the prepubertal age is very, I mean, it's in essentially research. But in post-puberty, you need to use. So I just take 1 or 2 minutes. No, that's fine. So post-puberty, you need to use sperm cryopreservation. In females, you can use embryo or oocyte preservation. During RT, what happens is If the testicles are within the field, you need to use gonadal shielding or ways in which you can mitigate or reduce the dose that is delivered to the gonads. And for ovary, what you can have is you do have procedures called transposition surgeries where the ovary is lifted and placed away from the field. But it has to be used with caution because in pelvic tumors, if the tumor is large, there is a limit to which they can move the ovaries also. So there's no point in just performing the surgery. It has to be beneficial. So if it's a small tumor where ovarian oophorectomy can help, then definitely it has to be used. But in large tumors, it cannot go very far away from the pelvis. So if any which ways the ovary is going to receive radiation, then probably you need to counsel the patient and take them up for radiation and not perform an extra procedure, which is not going to help much. So, do we have dose de-escalation studies? So, there is this small study from MSKCC, the prospective study in which they've tried to reduce dose in neuroblastoma from 21 to 18 gray. There is yet another study, it's pretty old but still practiced. So, in rhabdomyosarcoma, you have various dose ranges. They try to bring down the dose when there is good margins versus positive margins versus gross disease. And they found that the control is similar and dose escalation. So moving on to increasing the survival outcomes. So this is a publication from our institute, which was a randomized control trial, prospective randomized trial control trial, where we compared dose escalation versus standard radiation, and we did find a difference in 5-year local control. So, but we did know that there is a benefit, but all patients do not require them because there is a harm of using dose escalation also. So we need to select our cases. Which cases do we essentially select? They are the ones with evidence that the ones that have an index tumor volume of more than 8 centimeter or 200 millimeters, the ones that have less than good response, as in partial response, less than 50% reduction. So these are the patients who we select for dose escalation. If they have a good response, then we probably wouldn't consider dose escalation. So in that way, this is an endorsed study which we are trying to embark on, in which we would develop a nomogram in which we could select patients who require a dose escalation. So in parameningeal RMS also there is some data to use dose escalation to have lesser local controls, but in general RMS there is a randomized control trial just published this year in September, which shows there is no benefit of doing dose escalation. But yes, FOXO translocation, if we speak about that, is very important because when it was positive, the local failure rate was quite high. So hypofractionated radiotherapy is used in the palliative setting, which will increase the control slightly. We do have a trial in our institute, which is going on, in which we want to explore it in radical settings as well. So we would be having our data soon. So take home messages is that those constraints have to be followed. If cannot be followed, we do not give radiation because there is a lot of dose to the organ, but we need to inform the patient and know for ourselves how to expect the toxicities and mitigate them. Proton therapy is to be used in skull-based tumors and sarcomas, unresectable sarcomas, where we need to save critical structures. Dose de-escalation strategies should be used with caution. Fertility preservation should be used when required, and dose escalation hyperfractionation should be used in select scenarios to increase the survival outcomes. With that, I would like to inform you that we finished 2 years of proton therapy in our institute, and the results are quite overwhelming. We just finished a practicum day before and yesterday. And we do have a radiation masterclass in which we delve deep into how to do radiation and how to mitigate the side effects with radiation. Last year we did have the first one, and this year we hopefully would have it in the next month. So I invite all of you would join in. Thank you. Thank you for your valuable time, and apologies to the chairperson and the listeners for the extra time.
Thank you very much. I want to highlight 2 points here. One is the infrastructure of the radiotherapy in all over the world. We have 12 to 15 LINACs in our city, and there are many countries who have only 1 or 2 LINACs in the entire country. So there is a very much heterogeneity, like the medical oncology says they cannot give full dose chemotherapy in certain areas because of the toxicities. So there are very much heterogeneity in the infrastructure of the radiation. Another point is uh, side effects of the radiation, acute and late side effects. So we have much little concern about the acute side effects in the pediatric group. They are very much taken care, but we are concerned about the late side effects. And usually these side effects are occur after years. So when we are counseling the patients, this is very much tricky part. Like madam says, in surgery or post surgery, where the you are seeing the child with no limb, you can tell this has happened and this is the solution or some kind of counseling. But when we are talking about them, if we give radiation, there might be a possibility of another cancer after 20, 50 years. So to explain this is very much difficult.
I just want to validate that yes, there is definitely a chance for second malignancies, but we also need to look at how it compares with the general incidence of malignancies. Because the longer you live, you are prone to have cancers, even if you had treatment or you did not have treatment. Again, there is no denying that there is zero possible. I mean, it's not that it's zero possibility SMNs with radiation. There is a slight increase, but it's not so large that we need to say no, radiation shouldn't be given in patients. So where it is justified, it is justified. So if it is increasing local control, if it's increasing the survival, it has to be given.
I think I'm just validating what she's saying that basically, otherwise, see, what is the incidence of second primary? 2.6%, and those escalation goes to 5.8%. So that, but however, when you're giving a, I mean, obviously the lifespan is improving. And even with 12.6 gray for acute lymphoblastic leukemia,
Yes.
the incidence of 20% cerebral SMNs are known 20 years down the line, but that's 20 years down. So, but in the meantime, you are controlling the leukemia build.
So we understand that this risk is very much low or remotely, but to complete that conversion or consulting, we
Exactly, we need to inform them. We need to.
And counseling, well, it matters from region to region. Talking of a community cancer center in rural Madhya Pradesh, I think this is one of the least troubled concerns. Because
I agree. It has to be looked at the family, the background from which they come. Because if it's an uneducated family, you start off with there is a possibility of SMN. They won't even do their blood test. They would leave for good or bad, whatever. Thank you.
At the same time, if you are sitting in a private hospital giving olaparib
Yes.
and patient develops AML, it's a nightmare for
Just
you.
fine.
And I have faced that. I have faced that. So far, I have not used olaparib in like thousands of the patients, but two of my patients have developed AML, and it's a nightmare for me. You are treating it like one disease. You are giving excellent. You are giving BRCA mutation. Then you are saying that there is a BRCA mutation. I am giving you olaparib, and you are giving a gift of AML within 2 years. So it's a nightmare for a clinician, as you rightly highlighted, sir. Which setup you are working, you have to see that if it is a rural setup, patient will definitely run away. Will not take even the first line treatment, it will run, he or she will run away. So we have to be very cautious. Which setup we are setting in, we have to behave accordingly.
Thank you. Thank you so much.
Ma'am, just a minute. I will request Dr. Naun to give a comment or two.
Yes, sir. Yes, sir. Thank you, sir. Thank you. Thank you. Thank you. Thank you.
Now I will request Dr. Chitalkar sir to give a moment to our chairperson.
Yes, sir. Thank you, sir. Thank you. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Thank you.
Thank you, Chairperson. Now we're moving ahead with the next panel discussion. The moderation will be done by Dr. Prakash Chitalkar sir. I will invite the panelist. You invite the panelist.
Before I invite the panelists, let me make some announcements. Firstly, We want, there's a stall of the TYAcon. We are whole last 1.5 day we are talking about children and young adults, adolescent and young adults. I'm sure there'll be some interest evinced, and I would like you to become members. This is now decade and a half that we are trying to do this program in different parts of the country, and I think the young doctors from Gujarat must become members so that we can take this forward. There are multiple thoughts in our mind how to improve the care of young people's cancer, and all of us together can do it definitely. So you need to become members, and you'll have newsletters, you'll have opportunity to participate in some clinical trials, some teaching programs, and awareness, scientific awareness programs. So please go to the stall, become members of TYAcon, and take the movement forward. Having said that, sarcomas in young adults has been a topic close to us for the reason that compared to acute lymphoblastic leukemia, even acute myeloid leukemia, somehow this is a little poor cousin, but not such a poor cousin. The osteosarcoma and the Ewing sarcoma and all the remaining, they continue to be rarer tumors, but we expect that the results will be similar, especially in a undifferentiated tumor like Ewing sarcoma, because it's like an embryonal tumor. They're quite similar to a hematological malignancy. And somewhere it comes to your mind that it should become the next ALL. And what is it that's stopping it from becoming the next ALL? So we got issues, and that is the reason why we're discussing in the panel discussion. So I'll call upon Dr. Jay Mehta, who's president of the Mumbai, and the go-to person literally for much of oncopathology. Then Dr. Rajesh Patidar, professor of medical oncology in SAMES Indore. Dr. Jimmy Jose, sorry. She's the associate professor of radiation oncology in ACTREC Tata Memorial, and part of this prestigious proton therapy. Only the second one and the first one in the government sector. Congratulations for all the achievements. And I mean, when I started putting this program together, first person I thought was Dr. Siddharth Leshkar and Dr. Nehal Khanna, and then she introduced me to you. So thank you. And Dr. Devendra Nayak, he's the professor of ortho-oncology in SAMES Indore, and Dr. Ashwin Prajapati, Ahmedabad, is orthopedic oncology, right? So please. So today we, yeah, so this is the tiger that we almost have conquered in osteosarcoma. That is why, because with OGS 12, and now you know that we got a very reasonable overall survival, 75% in osteosarcomas, and all entirely indigenous protocol. But when you come to Ewings, there are problems. And what are they? Size more than 100 cc or 200 cc, a single diameter more than 8 centimeters, site axial or extremity, tissue, whether osseous or extraosseous, and very molecular. Some FOXO4, FOXO1, FOXO2, FOXO3, FOXO4, the rarer EWS mutations. But Dr. Jay, can we begin with what is your, I mean, what do you think biologically, how does a FOXO 1, 2, 3 tumors behave?
Those are for the randomized sarcoma.
Yeah,
The Ewing's are
yeah.
the EWS fusion protein.
Yeah, so I'm coming to that. So a lot of times we get a soft tissue tumor, which is reported as a ultimately Ewing's, because if it FL11, and then it shows also a FOXO1, then what happens? In a, like typically in a axial area like the inguinal region.
I don't know. FOXO1
Should not come in.
randomized shouldn't be there in this one. These are the EWS Fly1 or the other
Yeah.
kind of fusions along with that.
Yeah.
Some of these ground cell sarcomas may not necessarily be the Ewings. They are the Ewing family tumors, so
Yeah.
they may be GCOR or CCNV3 or SIG ducts and all, which morphologically look the same, but they have a different fusion partner. Perhaps that accounts for some of these tumors not responding to what we perceive them as the classical or the conventional Ewing sarcoma. So probably doing the molecular analysis would help. Again, it's the financial kind of constraints which hamper it, and the lack of availability in every probably city of the country.
So, Dr. Rajesh, would you treat undifferentiated tumor in a soft tissue in a young person differently from Ewing's?
I would like to send the molecular testing and to
Yeah.
find out what exact histology it is. And if I'm not able to find it out, then yeah, I'll treat it like soft tissue sarcoma.
Yeah. So what will be the protocol?
So
It'll,
undifferentiated sarcomas, not having are treated like undifferentiated sarcoma,
Yeah.
adult. So we give adjuvant, if it is extremity sarcoma, then surgery is the first.
Yeah.
And after that, we give chemotherapy and radiation also to be considered, especially if it is high risk tumor. So adjuvant radiation has better evidence than adjuvant chemotherapy in extremities of this.
do you agree, ma'am?
I pretty much agree with what you said, because we need to know how, if you have to know the treatment, then you need to know what the histology is.
Yeah.
So before we arrange sarcomas, we essentially treat them like living sarcoma, we call them living like sarcomas. And we would consider the same doses as we consider in livings.
Yeah.
But if we do not morphologically be, I mean, having the same histology as living sarcoma, then we need to treat them as non-term cell sarcomas, and for radiotherapy per se, we need to give a higher dose in adjuvant setting as well as in definite setting.
Yeah. So what is the extent of dose escalation that you can do in a tumor like this, which is got dimensionally it looks like high volume, actually it looks like high risk.
So, eating like, are we talking about eating like sarcoma?
Yeah,
or
eating like
sarcoma?
Eating like sarcoma.
Or eating sarcoma?
Eating like, let's say.
So, what my experience, and it may be anecdotal, but though the literature says that deeper sarcomas don't respond as well as like living sarcomas, I've seen a couple of them which has had good response with chemotherapy. So then delivering this high dose radiation isn't much of a problem.
Yeah.
Even if it doesn't respond, we have left with no other option. Surgery is not going to happen. Then if it's unresectable for whatever reasons, for cosmetic reasons or because it's in living nerve structures or anything, we need to give the full dose, and we need to inform the patient because we are giving this full dose and what we are expecting, what toxicities we expect in the patient because of this high dose.
Yeah.
And we need to proceed with treatment.
Yeah. So
And that is why I was saying we try to mitigate or even prevent these side effects with using better techniques. Definitely IMRT in this era,
Yeah.
and if possible, then IMRT.
Yeah. So in osteosarcoma, there's prognostic factors like any chemotherapy, as Dr. Rajesh very elegantly brought out. Chemotherapy helps, that we know, but neoadjuvant chemotherapy not necessarily prolongs survival unless the necrosis is excellent. So then, like histology itself, what is Dr. Jay? What is the histological feature of osteosarcoma which actually is prognostic? I mean, that is more like an educational question.
Nothing really for a high-grade osteosarcoma unless the ones which are really low-grade, as Dr. Rajesh mentioned, something which is simply made on paraosteum or something. So no, there's nothing else. Otherwise, it's just a very vicious looking.
So it doesn't matter whether it's small cell, telangiectatic, etc.
It's supposed to be kind of slightly worse than telangiectatic variants, but they all respond. I don't think there's much difference in the treatment response.
Yeah.
They are, I guess, they are less
Yeah.
sensitive to chemotherapy. That's it.
Yeah, and the leaf hominy type of osteosarcoma and RB genes type of osteosarcoma, they're prognostically a little inferior. But any insights into it now? Are they coming or molecular? Not much.
Unless you do that, it's difficult because not many people actually do any molecular analysis for osteosarcoma. So one will find it difficult unless you already know that the patient has a P53 mutation and it has developed, then you're more wiser. But otherwise, since you wouldn't do it, you wouldn't come to know.
Yeah, so we'll quickly go through some cases. The 21-year-old male he presented to us in December 2019 with a painful back mass between his scapulae, and there was no paraparesis, neurologically perfectly normal. There was a mass in the dorsal vertebra 1 and 2, about 6 centimeters, and the volume was as little as 38 cc. And the histology was Ewing to the CD99 positive. At that time, we did not do any FISH for EWS FLI1. PET CT non-metastatic, so induction chemotherapy with VSC or IFOS etoposide alternating into 4 cycles, and then received radiation 54 gray to the dorsal vertebral site, completed 17 cycles of VSC alternating with IFOS etoposide, and the etoposide dose at that time we capped at 3000 milligram per meter square total for this patient. And then he was well, continued to be free of disease and returned to his job, etc. And then, uh, what is the it's a axial Ewing sarcoma, a small volume. What is the approach, MDT approach? Uh, Dr. Devender, please, sir. He's come to you, and in the MDT, we're discussing a new small volume spinal and paraspinal Ewing sarcoma. Usually, in our setup, there is no work of surgery in such a kind of small. So, what would be their role, if ever, in a spinal osteosarcoma? Yeah.
So sir, I think first thing what we need to do is add an orthopedic oncologist in this MDT.
Yeah. I mean,
So,
you're already there. That's,
so basically,
both GCR has, and we are fortunate to have
yes.
Arbindo and many others.
Now we have. So
Yeah.
basically, even for EVs, if tumor is resectable R0 with acceptable morbidity, even in axial skeleton, you should resect. If it is not resectable, like you can't remove, I mean, it's in the body of the vertebra, you can't take it out R0, you definitely go for definitive radiotherapy. But like it's in the paraspinal muscle, just involving only a spinous process of the vertebra, which can be taken out without almost no morbidity. Yes, surgery should be considered. And yeah, I mean, if it's resectable with acceptable morbidity, surgery should be considered.
Yeah. But most probably not, right? I mean, very few patients will undergo surgery, as you believe.
Yeah, so obviously we need imaging and everything.
Only if you can ascertain R0
If see R0 is possible, we can take it out one piece R0. Then only surgery should be performed, and that also with acceptable morbidity.
Okay. So what happened was he, after 17 months, he developed a right upper lobe pulmonary mass metastasis with a right atrial thrombus. And he actually came all the way from Indore to UN Mehta Heart Center in the hope of getting the thrombus treated, which is also infiltrating the pulmonary artery. Unfortunately, it didn't happen for whatever reasons. He came back, and then he was with the SVC syndrome. He received anticoagulation. He remained unwell for a while, but ultimately we realized it's a right upper lobe metastasis with a thrombus, which is obviously a tumor thrombus. And so what we actually gave was a second line chemotherapy with irinotecan with vincristine temozolomide. Dr. Rajesh, any comments on this?
No comments. Metastatic disease now, our intent is palliating, and palliating a young person is a very big challenge.
Yeah.
Working and palliation. So palliation is a challenge in this boy. I know him personally, and he is the only worker. And again, he is very hopeful. So palliation challenge in this one.
Yeah. So what I wanted to bring out is it's a huge psychosocial problem, and this particular patient we all know and this thing. So what happened was he remained on the combination of irinotecan with temozolomide and vincristine for a period of 24 months. It was like a metronomic dose or whatever continuously. And he eventually there was a response in the pulmonary lesion. It's not a complete response, but there was a partial response. And of course, the SVC syndrome resolved. Right atrial thrombus over a period of time started getting resolved and getting more and more organized. Pulmonary thrombus remained, the branch of the pulmonary artery. And then, so that's become a state. He's just living with it now. Then when he finished this much chemotherapy, 24 months, we eventually gave him some oral metronomic chemotherapy, again for the reason that he is harboring a high grade Ewing sarcoma. So we gave him a combination of cyclophosphamide, celecoxib, and tamoxifen. Now, without evidence, with evidence and with some unpublished data for the last 25 years, and even I've been part of Tata Memorial in the 90s. What is the current status? Temozolomide, is there, tamoxifen, is there a role? But many oncologists, including me, I would vouch for a metastatic Ewing sarcoma to give tamoxifen. I don't know the answer. Any comments, Dr. Rajesh?
Oral metronomic, there is a role in all chemosensitive tumor. We give in all palliative setting, like in head and neck, and any chemosensitive tumor where we can give IV chemotherapy. The role of tamoxifen, I am not aware.
Yeah.
Since it is a chemosensitive tumor, we can give oral metronomic.
Yeah.
Sir, at present,
That's what we feel, okay, rather than giving oral metronomic, if by NGS or by doing some
Yeah.
genetic test, if some targeted therapy available, then it is much better. At that time, when we used in 1990s.
There was,
2000,
correct,
there was
there was no such thing.
Yeah.
Unfortunately, NGS is not affordable in that scenario, so that's the reason why we've not done it. So he's alive with disease and an organized thrombus and no SVCS now. 81 months have passed, means more than 6 years, and lost marital hopes, broke up with a fiancé, depression, lack of confidence, and also it's a very difficult scene. And this is what we want to bring the young person out of this scenario at some stage, by both by psychosocial interventions and also by effective oncological treatment. Second patient is a 24-year-old male with right pleuropulmonary edema arising from the eighth rib and 11 centimeter into 7 centimeter to 5 centimeter mass. And again, he also got induction chemotherapy and then wide local excision. The histopath showed 25% viable tissue. What did you do, Dr. Rajesh?
In Evans sarcoma also, necrosis is a prognostic factor.
Yeah.
But based on necrosis, we don't
Change the treatment.
We don't change the treatment. We continue with our systemic therapy.
Yeah. He received radiation and continued chemotherapy. And since he had a chemo and surgery, should he actually have a three modality treatment for a high risk pleuropulmonary edema? Because it's a by site. Ma'am, what is the in your DMG? How does it work?
So I would like to confirm, is this a pleuropulmonary blastoma or is it a pleural event?
By imaging, it seemed to be arising from the right eighth rib.
Eighth rib, okay, so it's a chest wall
Yeah,
events, okay. So we continue giving radiation there. Third modality, what you meant is employed surgery.
The surgery has been done.
Done. So that's why.
Yeah.
Sorry.
So yeah.
Third modality as in?
Radiation.
Radiation, yes. So you don't have randomized evidence for giving and not giving radiation in axial living sarcomas with clear margins, but we essentially consider treatment, adjuvant radiation still in those sites because in axial sites you wouldn't get very wide margins.
Yeah.
Because if you employ very wide margins, then you're going to cause a lot of morbidity, especially in cases of rib, because the lie of the rib is not in the way the human mind would kind of contemplate the margin.
Yeah.
So we definitely advise RT, adjuvant RT. Having said that, in America, pretty much they do not give radiation in chest wall livings unless and until margins are positive or there is some amount of fluid diffusion around in the index presentation.
The percentage of necrosis in the post surgical thing you will not consider?
So that is not only for rib living sarcoma. In general, with bone sarcoma, I think Ashwin will also agree. There you could define, kind of predict their prognosis, but radiation to whether to give or not is not completely dependent on the amount of necrosis. It is definitely multifactorial, and the most important, the very prominent, what do you say, factor to decide to give our radiation or not is the presence of extraosseous component. So when there in the index presentation, if there is an extraosseous component, you would pretty much want to give radiation unless the preempted toxicities or the expected toxicities in that particular individual for whatever reason, because there is a prosthesis or there has been bone complications or whatever, is not acceptable, then you may have to inform them and document and then avoid radiation. Otherwise, it is almost like 99% you would give radiation if there is a large extraosseous mass.
Yeah.
It is essentially because there is data. So even in 100% necrosis, there was a benefit of giving adjuvant RT. Now, if you have to quote that trial, it is a retrospective trial from the living sarcoma group only, EWS. So if you look into that data, you would find different flaws, but they also couldn't justify why they got this benefit in 100% necrosis. So we essentially went on to say that it could be because of sectioning in pathology, it was not as fine. And the other thing is the surgery wouldn't have, completely removed the extraosseous component, the extent of the extraosseous component that was there at the beginning, because with chemo it reduces.
Yeah.
So to reduce the morbidity with surgery, they would only address that part. And your response to chemotherapy also could be different. It essentially doesn't need to be central.
Central, yeah.
So there could be
It can be patchy. It may not
Yes,
be.
it can be patchy. So
Yeah.
you are.
So this was discussed in our MDT, but these
Yes,
inside.
got it.
No, this is very vital because this was discussed in our MDT, but these insights were obviously lacking. That if there's an extra osseous element, then definitely radiation might help.
Any comment from Maulik or radiation part?
Yeah, so the third case is a 14-year-old female who presented in last August to us, the right pelvic mass extending all the way from the sacral bone to the almost touching the acetabulum on the same side. So volume was 390 cc, and again it was a histopathology E-wings. This time we were able to do EWS FLI1 fusion positive, but that she received again induction chemo, and then radiologically there was a partial response. She underwent surgery here in GCRI, I think internal hemipelvectomy with the implant, and then poor ambulation and limb shortening. So she is now relatively morbid with a 6-inch short limb. Your comments? I mean, we continued chemo and the things are going on, but yeah, she's currently the big problem because she's not able to ambulate.
Sir, I mean, if that implant was there.
Yeah.
Routinely what we do, even if we have to dissect the acetabulum, means hip joint.
Yes.
We do a pseudo hip arthroplasty.
Yeah.
Creates a pseudo hip joint.
Yeah.
It gives shortening, but most of our patient, the rehabilitation time is comparatively longer, maybe 5, 6, 7 months.
Yeah.
But after that, they catch up, especially once the adjuvant chemotherapy and everything is over. Most of them are ambulatory without any support, can sit cross-legged, and but yeah, when you put in an implant, there are 35% chance that it will get infected or you will have some bone necrosis or whatever. So usually we are not very keen on putting in an implant. But yeah, sometimes when patient is here, you think that will accept that complication rate. Then yeah, we may put in implants. But if you are talking that it's just the 6 months, I think we are hopeful that with the time he or she will be able to catch up, because that rehabilitation after internal hemipelvectomy is, I mean, takes a lot of time, but usually they catch up.
Or consider radiation first, so then you won't have
yes,
these
sir.
problems.
Yeah, so that is.
So until and that stuff the table, like
That's not true. So I would again, emphasize that you could use proton therapy also in this good case.
But it's a
Not
very
huge
large.
images, but yes.
Yeah, as a like post-surgical proton therapy, if there's a R0 resection.
No, sir, it's not that you cannot give radiation, proton therapy, but it's most, beneficial when you have to give a large dose, especially in this case.
Yeah.
Like I was talking about, these are the cases where you have partial response, and they are the ones, if you are expecting bad outcomes with surgery, morbid surgery, then you could consider definitive RT and with escalated doses. So I wouldn't say that overall outcomes with surgery plus or minus adjuvant RT versus definitive RT is similar. But in such cases, if you're going to end up with such morbidity, then I think the trade-off is fine.
Yeah. Thank you. So we quickly. Sorry. Yeah.
Implant was
Hi.
just the sleeve attaching, and hence was the shortening is present.
Yeah.
If the
But the radiologically there's some
there's
element.
a implant inside,
Huh.
because it is the sleeve connecting the exoskeleton to the appendicular skeleton.
Yeah.
So there is not a metal implant in it.
Yeah.
So and that is why there is a lot of shortening in this patient. And of course, as man said, surgery plus RT should be the way to go for pelvis civic. That is what meta-analysis that we are preparing is saying. There are only 14 papers in this world where there is
Not if the patient is not walking after that.
after a hemipelvectomy, there will be definitely a limp, and that we have to counsel to the patient.
I completely understand, but there should be an option. If the patient is,
So I absolutely
yeah,
agree.
it should
If
be discussed.
the morbidity is too much, you should give an option that that the definitive RT is also an option. And result, we don't have any head-to-head comparison, but this is an option, and this is also option that with this morbidity,
you may have a better outcome and let them. That is the.
Yeah. I think, so thank you. I think you made a point and we're running short of time. We are already. Yeah, excellent. So I will not take too much time. Only two paradigms, biology and therapy. So we'll go this thing, intensive therapy, local TBI based and so on. There are so many things I don't want to complete it. But what are the, are we ready to actually examine this issue, whether we should be going from the biology side, from the pathological characteristics of the tumor, or we should go from the treatment efficacy side. And there are many other molecular studies going on, TP53 gene, so low expression in Ewing's and so on. There are many other things known about. So it's a very intriguing tumor, and that's why I think it needs a lot of interdisciplinary discussion. And so in summary, all I'll say is the biology of Ewing sarcoma is poorly understood as of today. Embryonal tumor highly responsive to cytokine, and because I'm restricting myself to Ewing sarcoma because all three cases are that. Role of surgery as the preferred local therapy in the early stage is established, and the biology of relapse disease, irrespective of site, volume, needs investigation. Does the panel agree with this kind of? So thank you very much for the very learned contribution. We really learned something. And it's a passionate subject because it's, as I always say, it's a very typically AY tumors, these ones. And that's the reason why we perhaps should put more organizational interdisciplinary focus on it. Thank you so much.
Thank you, sir, and all the panelists. So now moving forward to the next session of Onco Fertility, I would like to invite Chairperson Dr. Sanjay Shah. Now I would like to request the speaker, Dr. Ava Desai, to talk on the surgeon's role in preserving fertility in young women's cancer.
Good morning. Thank you very much. I'd like to thank Dr. Chitalkar, Dr. Bhavesh, my past fellow and now a very, very successful gynec oncologist, Saili, for this very kind invitation. And I'm going to dive straight in because we have only 10 minutes. Fertility preservation in gynecological cancers is a tricky business because most of the time we are going against the standard of care. So, and it's becoming huge now because more and more women are postponing childbirth and more women are getting cancers. But fortunately, more and more women are being cured of their cancers, and we need to discuss fertility preservation. So, whenever a young woman comes to us with a gynecological cancer, the two main questions we have to ask ourselves: is there really a strong desire of the couple for fertility preservation? Only then do we go for it. And then, is it oncologically safe? And do we have enough solid evidence that we can get a properly informed consent from the patient? Once we've decided this, we have to think in this particular cancer, what are the criteria for fertility preservation? Then what options can we offer her for fertility preservation? And can assisted reproductive techniques or pregnancy influence recurrence in this particular cancer? So we need to provide ample information to the patient. It's not just, this is not the standard of care, there's a slightly higher risk, are you ready to take the risk? No, we have to give them proper information before they give our consent. For example, this is a non-standard treatment, there is a possible compromise to cure, there is a risk of persistence or recurrence. There might be microscopic disease which even a PET CT can't see, and it may remain in the preserved ovary or nodes or even the myometrium. Disease that is curable right now with a simple surgery may progress during our attempts at fertility preservation to advanced incurable disease. You will need to have a very close and very active follow-up. Achievement of live birth may be affected even though you achieve pregnancy, for example, with a radical trachelectomy for cervical cancer. And in many cases, you will need to have completion surgery after fertility goals are achieved. So we need to give them a lot of information, and we are the counselors. We don't have, a separate counseling department, so we need to be very careful about this. Now, for early stage cervical cancer, if it's micro-invasive or pre-invasive, then we know that we can deal very well with a cone, or at least if it's a deeply micro-invasive, we go for bilateral node dissection also. This particular patient of mine was a young unmarried girl, and you can see the entire transformation zone dense aceto-white. Biopsy was a CIM3. I treated her with a wide knife cone, and she's doing very well. This is like 9 months post-op the colposcopy. You can see a beautiful normal transformation zone. She's about to get married and hopefully will have children. When we go to the 1B1 and 1B2, these are the only invasive cervical cancers where we can offer fertility preservation. And the answer, of course, surgically is a radical trachelectomy if the nodes are negative. Some people do think of giving neoadjuvant chemotherapy to reduce the size of the disease before doing the trachelectomy, but there's no data about oncological safety for that. The oncological outcomes for radical trachelectomy in the properly chosen case and in the properly chosen hands is comparable to radical surgery. The pregnancy rates are also pretty good in the series which are available. After abdominal radical trachelectomies, the live birth rates are pretty poor. We can offer, for example, other options such as ovarian transposition, which already Dr. Jyoti spoke about. If we do a cervical cancer, if we do the radical hysterectomy and transpose the ovaries above the field of radiation, the problem with transposing the ovaries is that only 50% of these continue to function, either because of the mechanical problems or because of scattered radiation. So if radiation is required as an adjuvant after hysterectomy, maybe it's better to do the ovum pickup before starting the adjuvant radiation. That would be maybe a better choice. So there are other things we can offer besides a radical trachelectomy. This, of course, is this is the standard of care for 1B1, 1B2, a radical hysterectomy. If we want to do a radical trachelectomy, we remove the cervix along with the parametrium and anastomose the isthmus to the vagina. The lower two pictures are textbook pictures. I have no experience of radical trachelectomy. We don't get such young cases. We did do one in GCRI years and years ago. I did get a patient recently. I phoned my friends at the Tata. I phoned my other friends. Everybody said, no, we don't have experience. So the young oncologists, young gynecological oncologists here, if you get an early case like this is something we can do. Coming to epithelial ovarian cancer, there are very, very, very specific criteria for fertility saving surgery. It can be done only in rare cases, only in stage 1, and that is a proven stage 1, not just inspection and palpation. Unilateral disease, obviously, so it can be 1A or 1C. Negative endometrial biopsy, because many of these young patients have synchronous endometrial and ovarian cancers, and there should obviously be no genetic ovarian cancer syndrome. If they turn out to be high risk, for example, like a clear cell, or if there is disease on the capsule or the cytology is positive, but it is still a 1, then we can give her adjuvant chemotherapy and then proceed then she can try for children after the stipulated time, should be about 2 years after chemotherapy. The of staging. The only thing we won't do is remove the opposite ovary and the uterus. Everything else we have to do, right? So very often we have to counsel the patients and their family that we might have to do a 2-step procedure. We open up, everything looks absolutely normal except the tumor. We will go for fertility saving plus proper staging. If the final histopath shows disease outside the uterus, for example, microscopic or mental mets or a microscopic nodal mets, it becomes a stage 3. We have to go back in and complete the surgery. So we need to counsel for this. This is one of an older series, but it's interesting. 16 cases could have fertility saving. 37% of them required chemotherapy, long follow-up. good results, 8 pregnancies out of 16 patients, but 2 out of 16 patients recurred in the opposite normal looking ovary, and both of these patients died of disease. So this kind of counseling, that this normal appearing ovary might already have microscopic metastasis, or it's very likely in epithelial tumors, especially serous, that it will develop a second recurrence later on, and these are not easily detectable by ultrasound or MRI, and they may proceed to advanced incurable disease. So this is the kind of counseling we need to do in epithelial ovarian cancers. Another small thing, just because they are young and just because we are doing fertility preservation doesn't mean we have to go in with minimally invasive surgery. For example, this huge mucinous tumor, it was a mucinous adenocarcinoma. And we, of course, did a laparotomy, although she was a teenager. She didn't even require chemotherapy and she's fine. If this patient had been done laparoscopically, we all know the problems which would have occurred. This particular patient came to us with this kind of port site metastasis. So just because we're doing fertility saving doesn't mean it has to be laparotomy, laparoscopy only in very selected cases. So rarely possible fertility serving in epithelial ovarian cancer. Dr. Saili has already spoken about germ cell ovarian tumors, which are completely different. Here, even if you have a stage 3C, you can still preserve fertility for several reasons. The most important being they never occur. They are never bilateral except few dysgerminoma, and they never recur in the opposite ovary. And they are exquisitely chemosensitive tumors, and we have very, very sensitive tumor markers for that. So germ cell tumors, almost all cases we can preserve fertility. And granular cell tumors usually are unilateral also. And if stage 1, we can preserve fertility, but we should not forget to rule out endometrial cancer or hyperplasia, because these estrogen producing tumors very often produce endometrial changes. Very quickly, endometrial cancer, it's not a surgery because the surgeon's role, but there are very, very, very strict criteria for fertility sparing, and I still feel very, very afraid when I do this for endometrial cancer patients. It has to be a grade 1 endometrial type, no LVSI, and this all should be on an adequate DNC or preferably a hysteroscopy DNC specimen, not on a papal biopsy. There should be no myometrial invasion on MRI, no metastatic disease, no suspicion adnexal lesions, normal CA1 to 5, because of endometrial cancer, it indicates extrauterine disease, and preferably a strong diffuse expression of progesterone receptors, because we're going to treat with progesterone, and no evidence of Lynch type 2 syndrome. Molecular markers have not been still included in these criteria, but obviously if we have a P53 mutated or a grade 3 tumor, we would be very skeptical about preserving fertility. Again, informed consent for endometrial cancer is so important. This disease is curable. 94% stage 1 are going to be cured with only surgery, but it may progress to advanced disease. Only 70% achieve a response. The others may progress. Microscopic disease, as we discussed, may already be present, and young women often have synchronous ovarian cancers. There is no scientifically proven optimal progestin regimen. What is the dose? What is the drug? What is the duration? Can I have just half a minute more? The potential risks of high estradiol levels in endometrial cancer during assisted reproduction have to be considered. We have to tell the patient for endometrial cancer, this is a temporizing measure. This is not a cure. It's only a temporary thing till you have a kid. And until you're pregnant, you have to have maintenance therapy. And until you have a hysterectomy, you still have to continue with maintenance therapy. A 47% recurrence rate is seen between 7 and 36 months. So, and very close, very active follow-up with endometrial biopsies, hysteroscopies, etc. is required. This is not a no-brainer. Surgical completion must be done after her pregnancy is achieved. So I'll just skip all this. There are other strategies for endometrial cancer, one or the other. If she can't tolerate high dose or continuous progesterone, we can think of a progesterone IUD. Nowadays, people are considering hysteroscopic resection in the 3-step technique. Resect the tumor, resect the myometrium below it, resect the endometrium around it, and then go for the hormonal treatment. So instead of all this, we can still discuss a proper staging surgery with preservation of the ovaries if she's less than 40. I'll just let all this go. We still need to give maintenance hormonal treatment after achieving a CR due to this persistent risk of relapse. We still don't know what to do. Either is it a low dose progesterone? Should we give it continuously, periodically? Should we just put it in IUD? So just to conclude, um, I'm sorry, I'm going over the time. The data is promising but sparse. It is all retrospective and just short, small case series, small events, and these children go away. Once they get married, we don't have a proper reporting of their pregnancy events, live births, etc. It should be offered only as a protocol with the involvement of an institutional review board. Strict selection criteria, extensive counseling is very important. Expertise of not only the oncologists, our radiologists and the reproductive team, very, very important. I wish we had official counseling team too. And of course, ongoing trials are there and future prospective trials will clarify the optimal treatment. Thank you very much.
Thank you, madam. Very nicely. In short time, you have mentioned all the things that in which we can preserve the fertility and there are a lot of issues when the young cancer is there. Then the patient always asks, what about the fertility? And it is very discussing point there in which case we can preserve and how we can preserve, whether by transposition, whether by ovarian position, whether by embryo, if married, then embryo, or by even preservation, egg preservation, we can preserve the fertility. Very nice.
Ma'am. Thank you very much, ma'am, for valuable insights. I would like to request Dr. Sanjay Shah to honor Dr. Ava Desai with the moment. We will now request Dr. Puneet Rana Arora to take us through the session on how to set up an onco fertility clinic. He is not present here, so we will join through a virtual meeting.
Good morning, everybody. I think you'll have to make me a co-host so that I can share my slides.
Welcome, Dr. Puneet Rana Arora. Thank you for joining.
Thank you. Good morning, sir. And thank you for, am I audible?
Yes, you are.
Okay. Thank you. Thank you so much for having me. I'm sorry, I would have loved to join in person, but due to some last minute reasons, I couldn't. But it looks like a great conference going on.
Yes, sir. And this is a session on oncofertility, sir.
Yeah, so
I'm going to
can
speak on
somebody
how to
make me
establish a clinic of oncofertility in the center.
can somebody please make me co-host or so that I can share my slides? I can't see the share slide option yet.
They've already given the permission, ma'am. You can just log in. I mean, you're already online.
I'm already online, but I can't see the options.
Oh yeah, now we can see you.
Okay.
And now you can share the slides again. Now you're visible here.
I don't have the options underneath, so I think I need to be made co-host. I still am not a host or a co-host. Maybe till then I won't be able to share my slides.
Ma'am, permission is already given. You can try again. Click on the green share button.
Shall I log off and
No,
see?
just click on that share button at the bottom.
1 second. I can't see the share button. That's what I was telling. That
Maybe you have minimized the zoom. Zoom is visible on the full screen or it's a small screen.
no, it's a full screen. It is a full screen, but I'm not being able to see the.
There is option of start and stop video at the bottom. You can see the video start stop button at the bottom.
Yeah, I can see now share. Yes. Thank you. Thank you. I can see the share button. Yeah.
Just share your entire screen, it will work fine.
Okay. Can you see my screen now?
No, not yet.
You are being there on the screen. Yeah. So just share your slides.
Just click on that green share button. You will see all the options of the presentations and everything. Just select the presentation and click the share button at the bottom.
Mm-hmm. Sorry, 1 second. Can I just quit and reopen maybe? Can you
You can do that, ma'am, if there is any
yeah,
issue.
just 1 second. Give me just 1 second here.
Okay, ma'am. Ma'am, we can see your slides. Just put it on a slideshow mode.
Yeah, I can see. Is this okay?
Yes, only your video is not turned on yet. Just turn on video and you can start the presentation.
Okay, 1 second.
Ma'am, the screen is stop shared. Yeah.
Is it okay now?
Yeah, good to go, ma'am.
Yeah.
You can
Okay, okay. Thank you. Thank you so much for helping me. So good morning again, and thank you, Professor Chitalkar and the whole organizing team for having me. So it was a wonderful talk on of Dr. Desai on fertility sparing surgeries. So my topic is more on how to set up this program where we can offer fertility preservation program. So we are all talking about it because we know the cancer is increasing. At the same time, survivorship is getting better, but the quality of life issues like reproductive health issues, infertility are being commonly seen right now. So this oncofertility joining these two specialities, subspecialties, this was coined in 2005 by Teresa Woodruff in USA. So basically, we are combining oncofertility, study of cancer, and fertility, which is capacity to produce an offspring, and trying to balance these two by preserving the fertility before they start the cancer treatment or offering them fertility preservation options once they have finished their cancer treatment, in which the options obviously are few, but they are still available. So what is preservation? So basically it is putting fertility on hold. So what we are trying to give to our patients, to our cancer patients, is a hope that the fertility can be preserved once they finish their cancer treatment. It is not something new. The first child born through these preservation strategies was reported in 1996. And since then, it's always been, this obviously was a natural cycle because in cancer patients, we try and avoid the hormones and try to give them a natural cycle options of having fertility. Obviously, the first child was born in 1978, but in natural cycle, it was 1996. And that gave us also the confidence that without affecting the cancer outcomes, because some of them are hormone sensitive, we can offer them a reasonable and an effective pregnancy outcomes. So what are the different ways? I think Dr. Eva, somebody from the previous speakers have mentioned there are options of oocyte preservation, sperm preservation, embryo, ovarian tissue, testicular tissue. Then there are medical methods which are giving GnRH agonist, and surgical methods which Dr. Desai has explained very nicely, giving them sparing surgeries which can preserve their fertility, and ovarian transposition if they are undergoing a radiotherapy. But Oncofertility Clinic, as such, is not just providing these preservation methods. It's a more complex, coordinated, multidisciplinary effort, because all these procedures can be offered by a normal fertility clinics, which are many in India right now. But providing a coordinated, disciplined program is what is all about oncofertility clinic setups or oncofertility program setups. It's a very comprehensive program where I feel that we have been able to do in our clinic in Gurgaon at some of these steps, but there are main 10 steps which are needed when we talk about setting up these clinics. There should be a vision, it should be a teamwork, there should be a proper infrastructure, there should be strict SOPs and clinical pathways. There should be ethical, legal, and stress on the consents taken from these patients. There should be a financial support, education, and support system for our patients. We should constantly look at our training methods, try to train others, and make it accessible to a lot of people, because we know that cancer can happen anywhere in the country. So we should be able to provide those setups. We should also look at learning new things from our overseas partners and constantly try to audit ourselves. So this is a very comprehensive, I like this slide because this is how comprehensive a oncofertility setup can be. There is a clinical core team, care team of oncologists. Then there is a team by fertility specialist or reproductive health specialist. And then we have a survivorship team where we talk about how to have safe pregnancy. And constantly in all these parameters, we talk about supporting our patients and counseling them. So the role of counseling, I would say, is a prime important thing when we talk about setting up these clinics. Patient obviously remains our focus, and then we revolve around that. When we talk about strategic planning and vision is obviously we are trying to increase the fertility preservation access, improve patient counseling and understanding, and integrate into the survivorship care, because preserving fertility is giving them a hope. But they should also be able to use this hope for later when they really want to come and plan pregnancy once they're cured of their cancer. So this should be the main goal of our oncofertility clinics. Obviously, we need to look into who can we cater. Is our clinic up to date with pediatric population, adolescent, adults, because each age group may have their own challenges. And whether we need to have these clinics within the hospital-based setting where the oncology care is being provided, or it should be a separate standalone. The way things work in India, it is, I think, challenging to have a hospital-based oncofertility setups. So we do have fertility setups where we try to have a more stringent referral pathways. Again, this involves a lot of multidisciplinary team efforts. There are again around 10 to 12 people involved: fertility specialists, oncologist, gynecologist, urologist, andrologist, pediatric specialist, nursing staff, psychologist, counselors, ethical team, and administrative and financial coordinators. Though we divide our team into core team, which is reproductive specialist, oncologist, our embryologists in our labs who preserve these tissues, our nurse specialists who are hand-holding our patients, and psychologist counselor. Extended team can be genetic counselor because some of these cancers are genetically linked. So we can offer them genetic counselings like PGT-A and PGT-M, and the urologist also, and the pediatric team. Infrastructure, so we should have an in-house lab, on-site storage system, consultation rooms, operating facilities in case we are retrieving these oocytes and TISA, and we should have an integration with the oncology wards. These are the various equipments we do have when we in our clinics and fertility centers. To have a successful program, I think it's very important to have a referral pathway because we know our fertility centers are not within the oncology units. So, age appropriate, multidisciplinary, integrated referral pathways are important, which should mention the type of cancer, the reproductive history, the treatment timeline, what exactly is being given to our patients, and if patient preferences have been given. So a clear and a referral pathway, I would say, is very, very important. I also feel that there should be a patient navigator, which obviously we don't have yet in India. But I feel that from our challenges, what when we set up our clinic in Gurgaon, we feel that patient navigator at the oncology end should be a good way as a barrier between the oncology and the fertility units. Because oncologists are very important, and understandably, their role is to save the patient's life. These patient navigators can handhold the patients and counsel them about the treatments. And the Western world data has shown good outcomes, good uptake with patient care navigators. And this is something we are trying to explore for our future clinics. So just to summarize that, within 24 to 48 hours of diagnosis, if the treatment plan has been made, patients should be discussed about the long-term effects. One of them is fertility, reproductive health. The patients should come and maybe not come. We can do online consults. We do a lot of online consults with our patients, just telling them not only about uptaking at that point, but just telling them what can be offered now and later once they finish their cancer treatment. So I think talking to patients also give them a security that this can be looked after, if not now, maybe later on. So at fertility center, when they come to us, we look at very detailed way explaining them what will can be offered to them, looking at their consents. Obviously, there is an ART law now. We only practice under ART law, which came in 2021. And we had the final consent forms in 2022. So we try to freeze and preserve the tissues according to that law. Before we do that, obviously, informed consent, psychological support, and enough reading materials we give to our patients to make them understand what they are going through. So, written and digital information to the patient. Also, we now have enough patients where we try to put them into support groups. Not many patients, though, not as extensive as oncology support groups, but we have few of our patients who have undergone this journey and have been successful. So we try to put them into support groups so that they can share their anxieties and apprehensions. So this is just like I said initially also that when the patient come to us, it is the fertility and the psychologist which take over the patient from us as well. And enough recommendations and guidelines to say that psychological input is key to when what we offer in our fertility clinics. R is one aspect. Psychology plays a very, very key role to add. Financial plans, very important because funding, we don't have much funding and insurance doesn't provide much funding. But currently what we are trying to do is give them a subsidy model, give them discounted rates. And also we have started now giving the EMIs. So this still remains a challenge in our country. It cannot be free of cost. Very less, government hospitals, even government hospitals charge a bit of money. So it is not completely free of cost. So just to have what we do is there are three main consent forms, like I said, as per the law. Form number 9, form number 10, form number 11, what we get them signs depending on what they are freezing. If they're freezing embryos, whether they are freezing egg or sperms, or if it's a child where the assent has to be taken from their parents. So it is form number 11. So these consent forms are very important for us. It also says what will happen to their tissue if they don't want to use it or if something happens to them, which is, I think, very important in this subgroup of our patients. So we undergo all these procedures depending on what they decide. The tissues, it can be preserved for 10 years for now as per ART law, but it can always be extended after the permission of medical board, which is a national medical board. So they come back to us and then we extend their consent forms and then we take a permission on their behalf, and then that's how we go beyond 10 years if they want to preserve it. So informed consent form, when the tissue comes to our lab, again, there is a very robust process of identifying, preserving, verification systems to make sure it is their tissue which is preserved, because they're going to come after years to use them, maybe not immediately. So there is a very robust system in our embryology lab which we look after. Follow up and survivorship, I think I firmly believe in that, because the way the Indian scenario is, I'll just take maybe a minute or so. Thank you. That patients may not be able to take up the preservation at that point when they're having cancer treatment. But let's try and discuss them in the survivorship plans, because we can still help them in giving them their own biological child in adequate reproductive health if they are dealt at the right time. Networking, very important, not only ourselves with the advanced centers overseas, but we also try and support the centers who are not being able to offer this setup. So we try and support and handhold them. So it's a very, again, I've just put this last slide to say that how complex this oncofertility care can be, and it's a multidisciplinary teamwork. There are barriers. Again, it's altogether a different topic. I don't want to discuss, even though if we try to build up a clinic, there are barriers. So just to conclude that informed consent and counseling is a key. Infrastructure, definitely yes, but informed consent and counseling, a strict checklist at both oncology and fertility units, patient navigators, maybe think about to increase our uptakes, and every fertility unit involved in oncofertility care should audit their referral uptake systems for effective patient care. So this is our checklist, which we try when we kind of support our clinics which are not yet started oncofertility. This is the checklist we have kept, and let's hope that we get better on it every day. Thank you so much.
Thank you, ma'am. Any questions?
Hello, Dr. Puneet. Dr. Puneet, Savita Goswami here.
Hi, good morning, Dr. Savita. Dr. Savita, I would say, has been our pillar. We really disturb her a lot of times when we have to take effective counseling techniques. Yes.
So the question, Dr. Puneet, that it seems that even preserving the tissues and the material is also expensive. So if survivors want to preserve their material, then are there subsidy available for that?
Yeah. So this is dealt at a very local, every fertility care center or oncofertility unit will have their own subsidy plans. Like what we have done is we do not charge anything for, consults and all that stuff. It's only the procedure and the freezing cost. So there is no standard guidelines. This is more, I would say, an Indian scenario where we don't get support from anywhere else. That's what we try to do at our end to support our patients.
Thank you. Dr. Puneet, Dr. Kurkure here.
Hi, good morning, Dr. Kurkure.
As we all know that fertility is assisted reproduction itself is quite costly for general public also. And the complexity of the either cancer patient or survivors makes it further complicated. We have been trying to work out for survivors unit as to how to coordinate, because these oncofertility centers are situated only in big places like Delhi, Mumbai, and they are also not very well organized. Not all of them are attuned to needs of the cancer patients and survivors. So they are not truly oncofertility centers, but they are mushrooming ARTs, assisted reproductive technology centers. So it's a big challenge, and we are facing that because many of our survivors are now in third decade, reaching third decade, and they look for the marriage, and if this becomes a norm, like really we can help them. then the biggest obstacle which they have to find their life partner gets easier, I would say, because it is unfortunate but the truth that marriage is translated into reproduction in our culture, not only companionship. So that is a big obstacle. So this leads to the next problem of not being able to find the partner. So if we solve this issue and become the standard and a smooth flowing thing, the other problem of finding a partner also will get sorted out. So we are really at that juncture because our survivors have now grown in this third decade of life.
Okay. No, thank you for your comment, and I think it's a very valid point. And these are the barriers, I would say. I would agree, because it's talking about setup of a clinic and the barriers we face. And we are, since we have started this more disciplined oncofertility program, we feel that there are barriers. The financial aid to me and the referral system from the oncology unit we felt were the biggest barriers. And obviously, financially, we have tried to do it at our end. But the referral systems from the oncology unit, again, we have to streamline. And you rightly said there are a lot of centers which can offer these preserving procedures. But it is not only about that, it is the complete comprehensive care with our oncology, with our psychologist, which we need to provide. So we need to justify what we are providing to our patients. So we have reached this far talking about setting up of dedicated oncofertility clinics, and I'm sure it's always a way forward. We will try, and like I discussed with Dr. Vandana and yourself the other day, that what we're trying to do is now to support the centers which are not being able to offer, so that even if the cancer treatment is being given in the remote parts, they don't have necessarily come to the metros areas. So we can just support them. So that's the way forward. We are really hoping that we can progress and provide the care.
Hello, Dr. Arora. This is Mini from Teenage and Young Adult Cancer Foundation, Chandigarh. I just want to ask you, as Dr. Sarita asked you, that this subsidy system, can we collaborate with Health Ministry or the government so that they can provide subsidy to those patients who cannot afford it? Plus, if this can be also discussed with the insurance companies who offer you health insurance, can this be done with them also?
So yeah, that's a very good question. Thank you for bringing that up. Health, I would say, may be a bit challenging because this is not a priority for them. This is a quality of life issue. They do not look after our usual fertility patients as well. So health, again, it's a long task, I think, but we are in discussion with the insurance companies for sure. And we are seeing a little bit more promising effect from that end, because so far it was not covered in any of the insurance companies. But there are three insurance companies we have spoken to who will be able to, I'll be able to share the names. Hopefully, I'll share with Dr. Professor Chitalkar and everybody in the group. So three insurance companies hopefully should be able to help us, not yet. So yes, I think with regards to subsidy, financial planning, insurance would be the way ahead. Government, I think it can be a lot of challenging and a lot of work before we reach there.
Thank you, ma'am. When you deal with insurance, you will have another obstacle that they are cancer patients or survivors. So they don't cover any of that so far. So you may be successful in getting the ART into insurance, but that will be for the normal population. Population at large. But being a cancer survivor will be another block to that. So first and
So
foremost.
no, so we did discuss that. So we have given them the indications, and we have put the indications as undergoing medical treatment like cancer for both in the pre at diagnosis and survivorship. So they are considering that. So they may be able to take that as a medical indication for preserving the fertility. Yes.
That will be great.
Yeah.
Okay, thank you, ma'am. So now I would like to request Dr. Shruti Gandhi to kindly take the stage and speak on position paper on oncofertility in India.
Thank you.
Good morning, one and all. I am Dr. Shruti Gandhi from Dinanath Mangeshkar Hospital. I am deeply grateful to Dr. Chitalkar sir for giving me this opportunity again. He is my continuous inspiration for AYA patients. It is through the vision of Dr. Chitalkar sir and Dr. Bajpai madam that we are at the stand of threshold for publishing the India's first positional statement for oncofertility by the end of this year. Today, I will be giving you the brief overview why this paper was convinced and how has been developed and what it includes. I will not be able to going through into the details of this paper as the available time is 10 minutes. But already Dr. Puneet Arora madam and Dr. Desai madam has covered lots of in detail. So list of authors who has contributed to this paper are as follows. So I will be covering this into the four phases. What is the current scenario of oncofertility in AYA patient in India? Data available from India on oncofertility. Why there is a need of positional statement and what we cover. So what is the current scenario? As we all know, ICMR has said that approximately 1.15 million new cancer patients are registered annually in India. ICMR and NCDIR predicted that by the end of 2025, annual cancer cases will rise to approximately 1.56 million. The cancer incidence in India is on the rise, with the diagnosed new cases in 2022 was 14,61,427. It is expected to increase by 12.8% in 2025 and 57.5% in 2040 compared to 2020, from which a total 9.8% of male and 9.42% of female are of young age who are at risk of developing cancer. Globally, the cure rate of childhood cancer has reached approximately 75%, but the data regarding all AYA patients are not there because of lack of evidence. So as we have discussed through this morning, in the last few decades, life expectancy of the cancer patient has increased tremendously. The incidence of the increased survival rate combined with the increased age for childbearing has led to the occurrence of side effects such as fertility problems. Therefore, preservation of fertility and family planning are crucial issues to be addressed in all AYA patients, especially those with newly diagnosed cancer. Despite of availability of ASCO and ISMO guidelines advocating the fertility preservation for oncological patient, 85% of the childhood cancer survival lack the information about the treatment-induced infertility risk. There are various studies from India found that the primary care physician lack the awareness regarding fertility preservation technique, which causes the major barrier. Understanding the need for increased social awareness and education on oncofertility program. I will be quoting few studies from India. Indian study by Shada et al. Found that around 74% of the oncologists are aware of international guidelines on fertility preservation or at least know about where to access them. But despite of knowing, only 10% of the oncologists consistently referring most of the AYV patient to the fertility preservation services. The discussion and the referral is mainly regarding the male AYV patients due to easier way of fertility preservation techniques. Similar to above survey, another cohort by Bajpai et al. Showed that referral rate for fertility preservation services is only 4%, with general surgeon referring most of the patients, demonstrating that referral rates are even lower than the awareness rates. From this cohort, they have also reported that out of all referred patients, only 8.5% of the patient used fertility preservation services. Another study from Theory et al. Showed that sperm banking is simpler for male in contrast to the complex and uncertain fertility preservation method for women, hindering the discussion. Again, this study also showed the lack of patient and physician awareness as a major barrier, underscoring the need of increased social awareness and education on oncofertility program. Mahajan and et al. Survey identifies that even gynecologists also lack the awareness for fertility preservation technique, emphasizing the need for in-house fertility preservation services and educational initiatives for the long-term patient interaction. As studies have shown, patients often do not receive the adequate information or timely referral to fertility specialists before initiating the cancer-directed therapy. This gap underscores the need for comprehensive clinical practice guidelines to assist the clinician in discussing fertility risk and preservation options for patients with cancer. So, why there is a need of position statement? There is a lack of standardized guideline for fertility preservation, no unified national protocol for fertility preservation in cancer patients, various practice across all the hospitals and those specialities. There is a low awareness among the healthcare providers as we have seen. There is a delayed or misreferral. Patient often miss the opportunity for fertility preservation due to lack of early intervention or guidelines. Equity and access issue. Fertility preservation options are mostly available in urban and private setting. Socioeconomic and geographical disparities in the access of fertility services. Ethical and legal ambiguity, as we all know, absence of clear policy on cryopreserved gametes and consent in minors. There is a need of multidisciplinary collaboration. So this position statement can guide integration between oncology, reproductive medicine physician, and primary care physician. Empowerment of the patient. This national position can mandate that all reproductive age cancer patients receive timely fertility counseling. And this paper also can help in driving inclusion of fertility preservation in cancer care insurance scheme and government programs. So we have decided to publish it as a TYAcon ISMPO position statement on fertility preservation for adolescent and young adults with cancer. This position paper developed by in accordance to the ISMO 2020 and ESCO 2025 guidelines on oncofertility recommendation. There is a group of 23 multidisciplinary AYA care experts from all over the India provided the suggestions based on the applicability in Indian scenario. The experts were contributing authors who looked up to the relevant literature. So this guideline has covered all this topic in detail. We have already discussed most of them. The paper has covered the detail how to do oncofertility counseling, how to structure the oncofertility clinic, what are the various type of cancer who have high to low risk of infertility over the patient, what are the chemotherapeutic agent causes oncofertility, how the radiation therapy can cause infertility, and what are the fertility preservation techniques are available in male as well as in female has been covered in detail in this paper, which has already been covered by the Desai madam and Puneet madam. So these all techniques are covered in detail in this paper. We have also covered post-treatment pregnancy in cancer survival as well as treatment in borderline ovarian tumor patient survival. We have covered the fertility and post-treatment pregnancy in hereditary cancer syndrome, and newer therapies like use of stem cell and uterine transplant has also been covered in detail in this paper. So what is our aim? Our aim is to address that fertility preservation counseling should start at the before the start of treatment and even should continue throughout the treatment. And we should provide timely comprehensive fertility preservation consultation for all the patient embarking for oncological therapy. Patients should be seen by reproductive medicine specialist with expertise in oncofertility counseling. We need to offer patient a range of appropriate state of art of fertility preservation treatment. We should serve as a resource for the patient and healthcare providers who are seeking up-to-date information on fertility preservation information. So what should be the future direction? We need to improve the communication regarding the fertility issue between the healthcare providers and the patient. We need to improve the integration of cancer survivor psychological needs into the fertility preservation treatment plan. And we need to develop broad-based multi-center study for the programs and betterment of oncofertility services. Thank you. These are my references. If there are
Very nicely, you have elaborated all the questions regarding the oncofertility and how to help the oncologist as well as the IRT or a fertility specialist to preserve the fertility.
Very nice.
Thank you. Thank
Suggestions, because if you look at the population at risk, the whole pediatric cancer patients, because they are going to be survivors, 75% of them, plus the young adults, which you can extend up to 30, 35, because the reproductive age is between 30 and 40. So it will amount to almost 40% of the total cancer burden. If you look at which is a huge number. Now, in this guideline, what you write, you should have triaging chart.
Okay.
In the sense, how do you triage the patient for the risk of fertility upfront? And then, see now, I'll just give you an example. In ALL, in one breath, we say that pre-BLL, standard or intermediate risk, you have a 75 to 80% chance of survival, and you will need a normal. That is what is anticipated. In the same breath, you can't say that if you relapse, then you have to undergo BMP, and then you are at a risk for the fertility. So triaging should be such that it should not be bothering the patients, means parents. In pediatric, it will be parents throughout their journey with the fear of relapse. At what stage one should do the counseling and think about oncofertility? And how do you trial the patients at these steps? Is very important. Otherwise, you will be inundated with the numbers, and then nothing will happen.
Definitely, ma'am. We will include this.
Please include triaging and how, but in counseling only, how, as I gave you example, you can't do both things simultaneously. To say that you have 80, in Hodgkin's, for example, 90% cure and very high risk for infertility.
Infertility, yes.
So, if the patient is 14 and you want to, it's a male child, it is good to have the sperm preservation, that time you say. But if you have a child who is mixing Hodgkin's, who are young also, and we treat with the low cost, low risk protocol, where you don't have it. So depends on the oncological situation. And that triaging has to be.
Definitely.
Paragraph.
Paragraph on, definitely. Yes, yes.
You can the pathway.
Yes, okay.
By triaging pathway.
Yeah.
In a more pictorial character.
Okay. Yes, thank you for your suggestion, ma'am. Thank you. Please. Ma'am. Thank you for your valuable talk. And now I request Dr. Sanjay Shah to honor Dr. Shruti Gandhi with the momentum.
Yes. Yeah. Thank you, sir. Thank you.
We are grateful to Dr. Sanjay Shah for his valuable contribution. I would like Chitalkar sir to give memento to Dr. Sanjay Shah.
Thank you, sir. Thank you.
Now comes one of the most inspiring parts of the TYAcon session 9. Survivors Speak. This session will take us through courage and real life experience. I request Chairperson Dr. Savita Goswami and Dr. Kaushal Jadeja to come on stage. We look forward to hearing from Miss Reena and Mr. Dongar Singh on personhood and parenthood.
मैं हिंदी में ही बोलने वाला हूँ, पंजाबी में नहीं। और गुजराती तो आती नहीं है, बस 2-3 दिन में एक शब्द लिखा है। केम छो मजा मजा ये भी मुझे ऑटो वालों ने सिखाया है। फिर मेरे मन में जागा कि नहीं यार, गुजराती सीखना चाहिए।
आप कैसे बोल रहे हो? आप पहले आप बोलने के बाद बोलेंगे।
मैं अपने बारे में थोड़ा सा बताना चाहता हूँ, और सर ने जो विषय मुझे दिया है पैतृत्व का, मतलब कि पहला अपना एक्सपीरियंस क्या होता है मेरा, मतलब अभी छोटी बच्ची है, मैं फादर बना हूँ तो बहुत ज़्यादा एक्साइटमेंट भी है कि मैं अपने बारे में बताऊँ। क्योंकि काफ़ी संघर्ष के बाद में बोलने का मौका मिला है, ऐसा मुझे लगता है और हो भी चुका है। मेरा नाम डोंगर सिंह कुमार है, और मैं के इंदौर संभाग के खंडवा जिले से आता हूँ। वो खंडवा जिले का एक छोटा सा गांव है मेरा, जामनिया करके। तो मैं इंदौर में कॉलेज के दौरान जब मैंने एमएससी किया, उसके बाद में मैंने फार्मा कंपनी में एज ए माइक्रोबायोलॉजिस्ट की पोस्ट पे टेस्टिंग वगैरह करना, मेडिसिन की स्टेरिलिटी टेस्ट, एमिटी टेस्ट, मेडल। तो उस दौरान मुझे कैंसर डिटेक्ट हुआ 2022-23 में। और फिर मैं एक दिन मैडम टेस्ट लगा रहा था डाइक्लो का, डाइक्लो मेडिसिन की टेस्टिंग कर रहा था एमएलटी के। तो अचानक मेरे पेट में पेन हुआ। पेन होने के बाद में फिर मैंने हाफ डे लिया कंपनी से। मैं सिप्ला कंपनी में वर्क करता था। तो वहाँ से मैंने जब रूम पे आया, और मैंने पेन किलर खा के चलो आराम कर लेते, हो सकता है कुछ खाने पीने में आ गया हो। कई बार क्या होता है गैस वगैरह बन जाती है और फिर पता भी नहीं चलता। तो मिड नाइट में अचानक ज़्यादा पेन हुआ, तो मैं गुरुद्वारे के हॉस्टल में रहता था। तो वहाँ के प्रबंधक को मैंने बोला कि बाबा जी, तबीयत तो ज़्यादा खराब हो रही है, अब चलना पड़ेगा हॉस्पिटल। तो कहते नहीं नहीं, आधी रात को कहाँ लेके जा रहे हो यार, इतना कोई टेंशन वाली बात नहीं है, पर नहीं ज़्यादा पेन हो रहा है। फिर हम डॉक्टर बाबा जी के साथ में मैं एक क्लिनिक में गया, गैस्ट्रोलॉजिस्ट के पास में। अ, वहाँ पर सॉरी हॉस्पिटल गया। फिर उन्होंने बोला कि आप सुबह एक यहाँ क्लिनिक में दिखाइए, इंदौर में ही। वहाँ पर दिखाने के बाद में मुझे उन्होंने एंडोस्कोपी वगैरह करी, तो पता चला कि भाई साहब, आपको तो कोलोन कैंसर हो गया है। अच्छा, ये मजे वाली बात है कि डॉक्टर सर जो होते हैं ना, बहुत इंटरेस्टिंग पर्सन होते हैं। वो मरीज को डायरेक्ट बीमारी के बारे में पहले बताते नहीं है, पहले उनके जो साथ में जो आते हैं ना उनको बोलते हैं। तो पापा जी को बोला, बोले टोंगर सिंह आप बाहर बैठो, बोले मैं पापा जी से 2 मिनट बात करना है। जी कर लो, मुझे लगा नॉर्मल ही होगा। पर जब उस मेरे जो गार्जियन थे उनको जब बताया कि भाई साहब इनके तो ऑपरेशन होना है और बीमारी तो गंभीर है, तो बाबा जी के पैर से जमीन खिसक गई, चेहरा पूरा उतर गया। अब वो जैसे वो बाहर आते हैं तो मैंने उनको पूछा, हाँ जी क्यों होया, तो दस नहीं रहे। मैंने दोस्तों से ही क्यों होया, असि बहुत मजबूत बंदे हैं, कोई ना कि जेड़ी भी होगी बीमारी आप लड़ांगे। तो उन्होंने कहा, डोंगर सिंह तेरी गल तो भरावा मैनू बहुत सोहनी लगी, पर मैं तेनू किवें दसा कि तेनू एहो जी बीमारी हुई है कि असि ना भी नहीं लेते होता। तो मैं भी थोड़ा सा सरपटा गया कि यार ऐसी कौन सी बीमारी है। तो उन्होंने बताया कि आपको आंत का कैंसर है। तो मेरे भी चारों धाम के आंसू निकलने लग गए। बाद में फिर मैंने भी अपने आप हौसला रखा, मैं अकेले रहता था, तो पापा जी को बोला कि कोई ना, मैं अभी अपने पेरेंट्स को नहीं बताऊंगा, पहले मैं अपना पूरा जांच करा के ऑपरेशन कराने के टाइम पे बताऊंगा। फिर मैंने अपने पेरेंट्स को बताया। और मेरे पेरेंट्स तो लकीली मुझे बड़ी मिन्नतों से मांगा है, क्योंकि 5-6 बहनों के बाद में मैं अकेला भाई हुआ हूँ। तो उनके लिए तो मैं गॉड गिफ्टेड ही था, और हूँ भी, सॉरी। जब उनको मैंने बताया कि मुझे ऐसा हो गया है, उस समय मेरी इंगेजमेंट हो चुकी थी। और मैंने बोला कि अब किसको बताया जाए, पहले पेरेंट्स को बताने के बाद में फिर उन्होंने कहा कि आपके उधर बताना है कि नहीं। तो मैंने कहा अभी मत बताओ, पहले इलाज जान दो, अगर ठीक हो गए तो हमसे शादी कर लेंगे, अगर वो जाना चाहे तो छोड़ सकते, कोई दिक्कत नहीं है। जब उनको बताया तो मेरा 25 किलो का वजन होता, पूरा डाउन हो गया था वजन मेरा। तो उन्होंने कहा कि नहीं नहीं, हम अपनी छोरी नहीं देंगे अब। और समाज में लिटरली इतनी भ्रांतियां हैं कैंसर पेशेंट्स के लिए कि जैसे कि अगर किसी को कैंसर होगा ना, तो वो तो ये समझ लेते हैं कि ये अब निपटने वाला है, इसकी जीवन की कोई आशा नहीं है। तो जब उनको मैंने बताया अपने जहाँ पर मेरी एंगेजमेंट हुई थी, तो उन्होंने रिश्ता तोड़ दिया। फिर मैंने भी कहा कोई ना, फिर मैंने उनके लड़की के फादर साहब को एक शब्द बोला था जो मुझे आज भी याद है। मैंने कहा था तुसी कुड़ी सानू ना दो कोई गल नहीं, पर मेरी ਇਹੋ जी इच्छा हैगी कि तुसी जिथे भी दो वधिया मुंडा वधिया परिवार लभ के देना। तो ये सुन के कुड़ी रोने लग गई, तो मुझे बड़ा सा रोना आया, मैं भी काफी रोया क्योंकि मैंने बहुत फर्स्ट टाइम किसी को इतना लाइक किया था। के बाद में जब भी मैं अपने बारे में मेरी बैक स्टोरी को जब सोचता हूँ, तो मेरी भी आंखों में थोड़ा से टीयर्स आ जाते हैं कि नहीं यार, पहले की लाइफ बहुत अच्छी थी। बाद में मेरा ऑपरेशन हुआ, ऑपरेशन के बाद में ही, मेरे फादर साहब वो करते हैं ना, साइन करते हैं, भैया हमारी कोई गारंटी नहीं है बचेगा कि नहीं बचेगा ऑपरेशन के दौरान। तो उन्होंने फिर मेरे फादर साहब ने सिग्नेचर किया और रोने लग गए, तो मैंने कहा पापा तुसी रो ना, असि तो ठीक हो जाना है, कोई गल नहीं, अपने लाइफ से जितना भी फेर आया है असि निपटांगे सारा। उसके बाद में मेरा ऑपरेशन हुआ और लकीली मैं कर्नल साहब का बहुत बहुत धन्यवाद करता हूँ कि उनका मेरा केस उनके हाथ में आया। ये विकास सर हैं और जितने भी हमारे हेमेंद्र मिश्रा सर हैं उनका भी धन्यवाद। अभी भी हेमेंद्र सर मुझे डांटते रहते हैं, कुछ भी अगर टाइमिंग होता है ना डिले, तो बोलते हैं क्यों तो आया नहीं यार फॉलोअप के लिए। तो मैं बोलता हूँ सर आ रहा हूँ, थोड़ा सा खेती बाड़ी का काम है निपटा लूँ फिर आ रहा हूँ। तो ऑपरेशन के बाद में जब मैं आईसीयू में था, तो मेरा पेट की हाथ वगैरह काट के उन्होंने ऑपरेशन किया। मैं 15-20 दिन आईसीयू में रहा और मुझे पानी नहीं देते थे, बोले नहीं टाके गीले हैं पानी नहीं पीना है। तो मुझे एक छोटा चाय के कप जितना पानी देते हैं, तो मैंने वहाँ पर नर्सिंग स्टाफ को बोलता रहा हूँ वहाँ पर जब मैं आईसीयू में था कि मैडम मैंने थोड़ा सा पानी दो, नहीं नहीं पानी नहीं, मैंने वो प्यास बड़ी लग रही थी, उसे मेरे तो सहन नहीं हो रहा, तो उसे मैंने चेयर दे के मार डालो, मैं नहीं अब कौन सहन कर सकता है।
जोगी सिंह जी, अ, आपका एक्सपीरियंस
जी जी, मैं वो विषय पे ही पूछने वाला हूँ।
तो क्योंकि हम जानना चाहते हैं, ये सारी जर्नी तो आपने बहुत हौसले के साथ की, लेकिन अब ये जो नई शुरुआत है आपके लाइफ में एज अ पेरेंट, तो उसके बारे में हम जानना चाहेंगे।
जी मैं इसी टॉपिक पे आ रहा हूँ। तो जैसा मैडम ने मुझे विषय दिया है पितृत्व का, तो मैं उसी टॉपिक पे आ रहा हूँ। थोड़ा सा क्या है इमोशनल में थोड़ा लंबा ना हो जाए, इसलिए शॉर्ट में निपटाता हूँ। इलाज के बाद में जैसे मेरी दूसरी जगह एंगेजमेंट लड़की वगैरह देखने गए, तो लिटरली 16-17 जगह तो टूटी गई है जोड़ियाँ। उसके बाद में फाइनली जो परमात्मा ने मेरे नसीब में मेरा संजोग लिखा हुआ था, तो उस लड़की से फिर मेरी ट्यूनिंग हुई, उनके पेरेंट्स से ट्यूनिंग हुई, मेडिकल रिपोर्ट वगैरह हमने दिखाया और दिखाने के बाद में फाइनली इंगेजमेंट हुई, जिसके बाद में उनके कुछ रिश्तेदारों ने मेरी रिसर्च करी, जासूसी टाइप की। तो उन्होंने उनके पेरेंट्स को बताया मेरे सास ससुर को कि नहीं नहीं आप तो कैंसर वाले लड़के को लड़की दे रहे हो, समझ जाओ क्या है क्या नहीं। तो बोलते हैं मेरे ससुर जी बहुत हौसले वाले, उन्होंने बोला कि नहीं नहीं, बोले क्या हुआ, हमने एक बार जो वादा कर दिया, हमने अपना कमिटमेंट दे दिया है, तो देंगे तो डोंगर सिंह को ही लड़की देंगे। उसके बाद में मेरी शादी को 2 वर्ष अभी पूरा होने वाला है, सॉरी 1.5 वर्ष पूरा होने वाला है। तो मेरी 8 महीने की बच्ची है। तो उससे पहले मैं डॉक्टर साहब से पूछने गया था कि सर मुझे ऐसा डाउट है कि जैसे हम इंटीमेट होंगे तो मेरी वाइफ को ये डिसीज ना हो, तो मुझे क्या करना चाहिए। तो उन्होंने बोला कि नहीं नहीं ऐसी कोई प्रॉब्लम नहीं है। फिर मैंने उनसे ये भी पूछा कि सर गांव में या मैंने सुना भी है कि कैंसर पेशेंट के पिता बनने की जो क्षमता होती है वो ये वो रेट वो क्वांटिटी कम हो जाती है। तो फिर उन्होंने बताया, कर्नल साहब से मैंने पूछा था, तो उन्होंने बोले ऐसा कुछ नहीं, आप तो फ्री होके लाइफ जियो, बोले कोई दिक्कत वाली बात नहीं। जब मेरी 24 जनवरी को मेरी बच्ची का बर्थ हुआ 9:05 पे, तो मेरे आंखों से आंसू आने लग गए। और आंसू वो खुशी के आंसू थे जब मैंने अपने दोस्त को फोन किया कि यार मुझे लड़की मेरे वाइफ को लड़की हुई है और मैं बहुत खुश हूँ, क्योंकि कहा मैं मिट्टी में मिलने वाला था, आज मुझे परमात्मा ने पिता बना दिया। तो ये खुशी मेरे लिए बहुत बहुत अच्छा है मैडम। मतलब मैं ना, ये जो अनुभव है वो एक्सप्लेन नहीं कर पा रहा हूँ कि कितनी खुशी थी। फिर 2-3 दोस्तों से भी मैंने बात करी वो नाइट में ही, तो उन्होंने बधाई वगैरह दी, बोले डोगर सिंह बोले काफी जंग जीत गए बोले आप। उसके बाद में फाइनली मुझे टाइकेन से जुड़ने का सर ने मौका भी दिया और फाइनेंशियली भी हेल्प की सर ने, उसके लिए मैं बहुत बहुत धन्यवाद देता हूँ सर को। तो मेरी ये छोटी सी जर्नी है, और कल का भी मैं थोड़ा सा अनुभव एक्सप्रेस करूंगा कि जीवन में हार नहीं मानना चाहिए। उसका एक बहुत बेहतरीन उदाहरण कि ऑटो वाला हमें होटल से यहाँ पर लेके आ रहा था, तो मैं उनसे बातचीत कर रहा था, तो उन्होंने बोला कि मेरा एक पैर नहीं है। अब मैंने उसके पैर की तरफ ध्यान नहीं दिया, जब मैंने देखा तो वास्तव में उसका एक पैर नहीं है और एक पैर से वो ऑटो चलाकर अपना जीवन यापन कर रहा है। तो हमारा तो पूरा शरीर ही अभी स्वस्थ है, तो क्यों हौसला छोड़े फिर। जो व्यक्ति एक पैर से पूरी दुनिया से लड़ रहा है, हमारे पास तो 2 टांगे भी हैं, पूरा शरीर स्वस्थ है। तो दोस्तों मेरा यही कहना है कि बस होप नहीं छोड़ना है, और पिता बनने का जो पहला अनुभव जो होता है वो लिटरली बहुत सुनहरा होता है। और थैंक यू चितालकर सर को मैं जो मुझे मंच दिया, और साथ में पूरी टीम का भी बहुत धन्यवाद करता हूँ। अर्चना मैम का भी धन्यवाद करता हूँ, क्योंकि मेरे साथ में बहुत जुड़ी रहती है, जब भी कोई प्रोग्राम होता है तो मुझे जरूर इनवाइट करती है। अभी वर्तमान में मैं खेती बाड़ी का काम करता हूँ, जो 10 एकड़ है। तो मैडम, मेरे एक प्रिंसिपल मैडम का मेरे पास फोन आया कि सिपला छोड़ के आपने खेती बाड़ी क्यों चुना। तो मैंने उनको बोला कि मैडम सिप्ला में या दूसरी कंपनी में भी जा सकता था, पर वर्किंग के टाइम पे डॉक्टर आप सभी बोलते हो ना कि एक्सरसाइज करना चाहिए, तो मैंने कहा खेती बाड़ी से अच्छा एक्सरसाइज और कुछ हो नहीं सकता। मैंने कहा अब रहेंगे तो खेती बाड़ी और अपने माता पिता के साथ रहेंगे। मैं इतनी वाणी को विराम देते हुए आप सभी का धन्यवाद देता हूँ, जो अपना अमूल्य समय मुझे सुनने के लिए दिया। धन्यवाद सो मच। मैडम इंदौर से है 200 किलोमीटर दूर गाँव। हाँ जी, हाँ जी, पास में टाउन है, मेरा विलेज है। जी जी, पेरेंट्स भी रहते हैं नाल ही। हाँ मेरी एक मैं कल ही हूँ, भैन तो सारा का ब्याह हो गया हूँ। हाँ जी, हाँ हाँ जी, वो लोकल से हुआ खंडवा दिखते से आ रहे हैं। हाँ जी, हुन तो पूरा संसार ही अपना नाल हैगा जी। पहले हमारे टाइम से नहीं सी, हुन है सारे।
ਟਾਈਕਨ ਨਾਲ ਜੁੜੇ ਹੋਏ ਹੋ, ਤੁਸੀਂ ਸਭ ਨੂੰ ਇਹ ਚੀਜ਼ ਦੱਸੋ, ਜਿਹਨੂੰ ਵੀ ਮਿਲੋ ਨਾ, ਇੱਕ ਬੰਦਾ ਅਗਰ 2 ਨਾਲ ਗੱਲ ਕਰੇਗਾ ਔਰ 2 ਤੋਂ 4 ਨਾਲ ਗੱਲ ਕਰੇਗਾ, ਤੇ ਇਹ ਗੱਲ ਸਾਰੀ ਦੁਨੀਆ 'ਚ ਫੈਲ ਜਾਏ, ਹੈ ਨਾ। ਤੇ ਇਹਦੇ ਨਾਲ ਕੀ ਹੋਏਗਾ, ਲੋਕਾਂ ਨੂੰ ਪਤਾ ਚੱਲੇਗਾ ਕਿ ਸਾਡੀ ਫਾਊਂਡੇਸ਼ਨ ਕੀ ਕੰਮ ਕਰ ਰਹੀ ਹੈ, ਤੇ ਅਸੀਂ ਇਸ ਤਰ੍ਹਾਂ ਕਿੰਨੇ ਲੋਕਾਂ ਨੂੰ ਹੈਲਪ ਕਰ ਸਕਦੇ ਹਾਂ। ਦੇਖੋ ਅੱਜ ਸਾਡੀ ਜਿਹੜੀ ਪ੍ਰੈਜ਼ੈਂਸ ਹੈ ਇੰਦੌਰ ਵਿੱਚ ਹੈ, ਮੈਂ ਚੰਡੀਗੜ੍ਹ ਤੋਂ ਆਈ ਹਾਂ, ਸਾਡੀ ਚੰਡੀਗੜ੍ਹ 'ਚ ਹੈਗੀ ਹੈ, ਅਸੀਂ ਚਾਹੁੰਦੇ ਹਾਂ ਇਹ ਸਾਰੀ ਦੁਨੀਆ 'ਚ ਫੈਲ ਜਾਏ, ਹੈ ਨਾ। ਉਹ ਕਿਸ ਤਰ੍ਹਾਂ ਹੋਏਗਾ, ਸਾਡੇ ਵਰਗੇ ਸਰਵਾਈਵਲ ਲੋਕ, ਜਦੋਂ ਤੁਸੀਂ ਸਰਵਾਈਵ ਹੋ ਕੇ 36 ਲੋਕਾਂ ਨੂੰ ਦੱਸੋਗੇ ਕਿ ਮੈਂ ਸਰਵਾਈਵ ਹੋ ਕੇ, ਦੇਖੋ ਅੱਜ ਮੈਂ ਖੇਤੀਬਾੜੀ ਕਰ ਰਿਹਾ, ਮੇਰਾ ਬੱਚਾ ਹੈ, ਮੈਂ ਉਹਨੂੰ ਪਾਲ ਰਿਹਾ, ਮੈਂ ਆਪਣੀ ਬੀਵੀ ਨੂੰ ਪਾਲ ਰਿਹਾ, ਮੈਂ ਆਪਣੇ ਮਾਂ ਪਿਓ ਦਾ ਖਿਆਲ ਰੱਖ ਰਿਹਾ, ਮੇਰੀਆਂ 5 ਭੈਣਾਂ ਨੇ ਜਿਨ੍ਹਾਂ ਨੂੰ ਮੈਂ ਦੇਖਦਾ ਵਾਂ, ਉਹਨਾਂ ਦੇ ਸਹੁਰੇ ਵੀ ਨੇ, ਉਹਨਾਂ ਨੂੰ ਵੀ ਦੇਖਦਾ ਸਾਰੇ, ਹੈ ਨਾ, ਇਕੱਲਾ ਰਹਿ ਕੇ।
ਜੀ
ਕਿਸ ਤਰ੍ਹਾਂ ਹੋਏਗਾ, ਇਸ ਤਰ੍ਹਾਂ ਹੋਏਗਾ ਜਦੋਂ ਤੁਸੀਂ ਲੋਕਾਂ ਨਾਲ ਗੱਲ ਕਰੋ।
जी थोड़ा ਜਿਹੜਾ ਇਹ ਪੁਆਇੰਟ ਹੈ ਨਾ ਮੈਡਮ, ਮੈਂ ਬਹੁਤ ਵਧੀਆ ਨੇ। ਮੈਂ ਪਿਛਲੀ ਵਾਰੀ 12th ਕਾਨਫਰੰਸ ਇੰਦੌਰ 'ਚ ਹੋਇਆ ਸੀ, ਕਰਨਲ ਸਾਹਿਬ ਨੇ ਮੈਨੂੰ ਦੱਸਿਆ ਸੀ ਕਿ ਤੁਸੀਂ ਖੰਡਵਾ 'ਚ ਆਪਣੇ ਕੈਂਸਰ ਅਵੇਅਰਨੈਸ ਕਰਨਾ, ਜਿਹੜੇ ਵੀ ਆਪਣੇ। तो मैं किसान संघ तो जुड़िया हुआ है, जितने भी किसान भरावा 500-600 आते ने मीटिंग 'ਚ ਸਾਰਿਆ। तो मैं अपना भी पॉइंट किसानां ਦੇ ਨਾਲ ਜੇ ਐਮਐਸਪੀ ਵਗੈਰਾ ਹੈਗਾ ਉਹਨਾਂ ਦੇ ਨਾਲ ਮੁੱਦਾ ਮੈਂ ਰੱਖਦਾ, ਉਹਦੇ ਬਾਅਦ 'ਚ ਕੈਂਸਰ ਬਾਰੇ ਵੀ ਦੱਸਦਾ ਕਿ ਮੈਂ ਕੈਂਸਰ ਪੇਸ਼ੈਂਟ ਹੋ ਕੇ ਵੀ ਖੇਤੀਬਾੜੀ ਕਰ ਰਿਹਾ। ਤਾਂ ਤੁਸੀਂ ਵੀ ਜਿਹੜੇ ਆਪਣੇ ਪਿੰਡਾਂ 'ਚ ਹੈਗੇ ਜਿਨ੍ਹਾਂ ਨੂੰ ਲੋੜ ਹੈਗੀ, ਜੋ ਡਰਦੇ ਨੇ, ਜੋ ਇਸ ਟੌਪਿਕ ਬਾਰੇ ਨਹੀਂ ਕਹਿਣਾ ਚਾਹੁੰਦੇ, ਕਿਸੇ ਨੂੰ ਦੱਸਣਾ ਨਹੀਂ ਚਾਹੁੰਦੇ ਕਿ ਮੈਨੂੰ ਇਹੋ ਜਿਹੀ ਬਿਮਾਰੀ ਹੈਗੀ, ਤਾਂ ਮੈਂ ਵੀ ਕਰਦਾ ਵਾਂ ਨਾਲ ਦੇ। ਮੈਂ ਆਪਣੇ ਪੰਚਾਇਤ ਮੀਟਿੰਗ 'ਚ ਵੀ ਇਹ ਕੰਸਰਨ ਰੱਖਦਾ, ਕਰਨਲ ਸਾਹਿਬ ਜਿਹੜਾ ਮੈਨੂੰ ਦੱਸਿਆ ਸੀ ਨਾ ਕਿ ਤੁਸੀਂ ਬਤਾਣਾ ਹੈ, ਤਾਂ ਮੈਂ ਹੁਣ ਖੁੱਲ ਕੇ ਹੀ ਦੱਸਦਾ ਸਾਰਿਆਂ ਨੂੰ। नहीं नहीं शर्म वाली नहीं जी सही है।
थोड़ी बीमारी हुई ਤੁਸੀਂ ਠੀਕ ਹੋ ਗਏ ਤੁਹਾਨੂੰ ਡਾਕਟਰਾਂ ਦਾ ਬੜਾ ਅੱਛਾ ਸਾਥ ਮਿਲਿਆ
ਜੀ ਜੀ
ਇਸ ਕਰਕੇ ਤੁਸੀਂ ਇੱਕ ਨੂੰ ਨਹੀਂ ਰੋਜ਼ਾਨਾ ਨੂੰ ਦੱਸੋ
ਜੀ ਜੀ
ਕਿ ਅਗਰ ਤੁਹਾਨੂੰ ਕੋਈ ਛੋਟੀ ਜਿਹੀ ਪ੍ਰੋਬਲਮ ਹੁੰਦੀ ਹੈ ਤਾਂ ਕੋਈ ਇਗਨੋਰ ਨਾ ਕਰੋ
ਜੀ
ਉਹਨੂੰ ਤੁਸੀਂ ਜਾ ਕੇ ਡਾਕਟਰ ਨੂੰ ਦਿਖਾਓ ਥੈਂਕ ਯੂ ਵੈਰੀ ਮਚ
थैंक यू मैडम थैंक यू सो मच
Thank you.
तो बैटल क्रैश दिया ही नहीं जो बोले तो
जो बोले सो निहाल सत श्री अकाल।
थैंक यू
कल शाम को भावेश सर ने गुजराती सुनाया, अब डोंगर ने पंजाबी सुनाया। बोले और सुनो पंजाबी गाने तुम। सही बात, हम भोजपुरी सुनाए।
हाँ
ठीक है, नेक्स्ट कौन?
Thank you for sharing your journey. I warmly welcome Dr. Kapil Dev to talk on a real world experience of treating adolescents and young adults with cancer.
First of all, good afternoon, everybody, and I'm very thankful to organizers, Bhavesh sir, Talkar sir, to give me opportunity. Basically, I want to discuss something in real world experience with this age group patients, those who have suffered with cancer, underwent treatments and halfly, partly, completely, follow-up, lost follow-up, less follow-up, complete, and with some few sequelae, there was some lacuna in their life and with incomplete life and incomplete journey. Actually, real world is saying that this is not the correct information in those who are in the books and literature is there. This is slightly different in this scenario. First thing is this is very potential age of the life, with a 13 to 29-year age. It's a developing career by the education to work to learn the skills to their future career development and employment also. And in our India, our country, the 41% of population this age group, very young country in the world, is the youngest country in the world. So it's very important to, and but nobody is taking care of this age group patients in our country also. I think this is the lacuna for the policy and everything. Multiple levels is there. So if you think about the incidence in male 22, female 30 females per lakhs, expected more about 2 lakhs in this year. So this is slightly different in our practice. And we are cancer center, HCG Cancer Center Jaipur, fully dedicated cancer, but it's a slightly different is the male is more common. I don't know why it's there, but around in the last 4 years, we have registered around 900 patients with the cancer diagnosis, and this till 29 year of age, not 39. We have taken only 29. Most of the patients have hematological malignancy, lymphoma, leukemia, and fortunately, with this disease, very good treatment policy, with good protocols, good availability of drugs, good response in the current population of the patients. And second is the more common is in the later age, 25, because of some habits, the most common head and neck cancer. And unfortunately, the in our center, out of the 896 patients, only 60% of patients have received complete treatment. It means very less patients are taking the complete treatment. And in our practice in last 5 years, we have registered 106 mortality during treatment or after the treatment with the progression of disease, either local, metastatic, sequelae, complication of treatment, whatever they. So around the 10% of patient, it may be higher, but real world is that they're taking that case of 32% mortality in the adolescent, the mortality is reported in various literature, but our center is only 11%. So this is the main problem is treatment adherence. In this age group, very lacuna is there. The most of the patients are taking the half of the treatment, half in the one center, half of the another center. So always the treatment difference will be there. Sometimes somewhere two doctors, two centers, never comparable, never same in the same patients. So around the 40% of patients have changed the institute, changed the doctor, and then later on, I don't know what happened with them. Fortunately, I hope they will do well with their treatment. So the most of the hematological malignancy is very well known, is a very good protocols, good drugs, they are doing well. But apart from hematological malignancy, solid malignancy and other head and neck cancers, it's quite different results with the various treatments, although available in for the uh, older population or above the 40, 50 year of age, the patients are doing very well in our country. So right now we are seeing that more than 50% of patients are surviving with these current treatments. But in this population, very less surviving because of, I think this is due to first reason is that treatment non-adherence, because the I don't know what is the reason behind that in this population patients are not adherent with the current treatment, and there is no clear-cut guidelines also in that situation. So the things are the around the 520 patients only. This is the real condition in our center also. This is the tertiary care center, corporate hospital, but still there's only 60% of the patients have completed their treatment with our institute. So discuss hematological very well. Bone tumor and Ewing sarcoma, slightly different experience at our center. Bone tumors is very aggressive in our center. Those patients are registered around 33 patients osteosarcoma and 29 Ewing sarcoma. Although bone tumors, in my practice, only 7 patients had completed their treatment with pre-op chemotherapy followed by surgery, and other rest of the patient have received only chemotherapy, incomplete, partial, progressive, metastatic. Either patient is succumb to death or change the treatment. This is a real condition is our country. Only at our center, I have observed that Ewing sarcoma, only the disease has very good survival, very good results, because the patient out of 29, only 23 patient had completed their treatment with disease free at the end of treatment. But some patients have recurrence, relapse, the multiple things are there. So there's a very good response in our practice, our experience with the Ewing sarcoma only disease, and the treatment completion also maximum with these patients. Second is the head and neck cancers. Head and neck cancer is the less than in 8 teenagers, only one patient we had it, oral cancer. Another patients are only the 25, above the 25. Only basically the morphology, the histologically stage-wise presentation are similar to the older age or the 50 and 60 year of age. The maximum patients in localized or locally advanced patients, less patient with metastatic disease, underwent maximum treatment, surgery, and adjuvant either plus minus adjuvant radiotherapy, and they are doing well in their practice. But the most problematic thing in this population only is the unemployment, because the maximum patient 90% of patients are male, and in this age group that they have not able to fulfill their skill employment with these their skills, either due to unavailability of the time, lacking of time, and the loss of some physically and some emotionally and some financially burden. So this is the maximum, the most dreaded complication with the head and neck cancer we felt in our practice, that is the unemployment. Second thing, the thyroid cancer, it's quite a curable disease. It's good. But in our practice, we observed some simple problem, that growth retardation. Those patients have had thyroid cancer in earlier age. They have some growth issue and menstrual and the post the fertility issue will be there in there, and still is a very good disease, good response with the surgical treatment also, but still there is a very minimum follow-up with surveillance. Good small very easy to do surveillance with these patients, but still there people are not coming for the follow-up examinations only. Another thing is a female patient, the breast cancer and ovary cancer. In our practice, we experience that very poor compliance with breast cancer also, because either regarding the diagnosis, either completion of the treatment also, and follow-up also. All the three things, and we advise the multiple patients to give the some home preservation. But I think in my practice, nobody is taking care of that, because the parents and the family members are not agree with that. They are thinking only the uh, making that case the first person, the female patient is the can be survive with the treatment only. They target only the survival, not the fertility. We had in the 13 patient unmarried also, only single patient got married. Unfortunately, she had after married some liver mets, and the she patient already succumbed. Only 4 patients we had experience with the pregnancy associated breast cancers. all 4 patients within a month of the delivery, they were diagnosed. Only one patient I have continued follow-up the last 3 years with the stage 4 patient diagnosis, stage 4 breast cancer, hormone positive, liver mets. Patient received palbociclib, multiple drugs, cleared liver mets, and later on she had only problem with the local breast, multiple blisters, painful, engorged breast. We removed the breast, and now the patient with minimal disease in the liver lesion, and patient still surviving. Our daughter is 3 years old right now. Another is the ovarian. Maximum ovarian patient, our practice also germ cell tumors. One patient I had a very good experience with one patient, Siddiq, somewhere from near Ajmer. So she had germ cell tumor, very advanced, full of abdomen with the multiple disease, the ascites is there. But she initially we did some diversion called ileostomy, then chemotherapy, then surgery, then cholestoma. Now this year she got the selection IIT. So it's very good candidate for that. Well, some patients are very enthusiastic and family also supporting. Those patients are very good. I mean, again, these patients also the main concern the fertility, but still it's very lacuna the practice in our experience also. Patients and patient relatives not taking care about the fertility still. In male patients, they commonly testicular tumor, and they also are facing the problem with the fertility. In our practice, 12 patients, no fertility preservation in the patient. And patient with colorectal cancer also, in our experience, a common 24 patients observed in our practice in last 4 5 years. All of the patients are advanced stage, locally either metastatic, chances of recurrence, high mortality rates is there. So main sequelae in this age group is the in woman is infertility and man is unemployment. So very impactful matter in their life is the in females in infertility and the men is unemployment. So still is that we have to take care of that in this area along with the some multiple from the top to bottom from government, NGOs, social services and the population and itself public also and relatives and attendant also. So my point of discussion, my top point of the towards the in this age group patients cancer is very heterogeneous except lymphoma leukemia. These apart from lymphoma leukemia very heterogeneous presentation. It cannot say like that this is the trend, this is the methods of patient and very poor compliance regarding diagnosis and treatment also and very unpredictable response to the medicine also surgical treatment and radiotherapy also and still in our practice also I am observing that in our center we are working at a good center but still we have still a non-uniformity of the treatment in this age group. So we have to take care about these features, these points in our practice also so we can take forward with this age group also. Thank you. And this is our team. Very thankful to all of you to listening some few important points and important concern in these age groups. This is the real world experience in these groups. Thank you.
Thank you very much for the wonderful presentation. Looking at the data, I could see that a lot of psychosocial concerns brought out from this data. As you said, psychosocial reasons of or socio-economic reasons for not getting employed, or it could be many other disease-related issues. Also, only 4 patients got married.
Yes.
So it would be great to look at the qualitative component of this data, like those who are unemployed, what are the reasons, like all those. So that will, I think, make it very rich data. And we will know many other reasons in this age group why how that psychosocial or socio-economic aspects are impacting their achievements or their time points which they need to fulfill in their life.
Yes, but that's why I'm saying that real world experience is like that only. It is very difficult to get the employment in this population. We have started in last 6 months. We had a discussion, multiple time of discussion, but since the last 6 months, we have a counselor also. We had a discussion with HDFC Irgo also. They are giving insurance, them population peoples also. And we have some one organization also, Kisekawati Cancer Foundation, and we are trying to move these encourage the population to get the employment in various sectors also. So it's very difficult to explain their relatives and the persons because for the families, only the survival is the main factor, still the survival. They are not thinking about the employment, that fertility, they are not thinking. But we have to take care of the thing, we have to explain, we have to start the uh, clinical psychologist counseling from the beginning of the treatment also. Yes. Thank you. Thank you. Yes, sir. Yes, ma'am.
Psychological issues. You know, when you said that there is non-adherence to the treatment, okay? So there must be a reason why there is non-adherence of treatment, why the patient doesn't come back to you for follow-up or for the full treatment. Because that's one thing. And then you talked about the male patients with testicular cancer. And I just had a question that why there was no fertility counseling? If there is a psychologist or a clinical psychologist, maybe if they can counsel them for this so that they can be encouraged to do this.
This is the ongoing process. We are doing the counseling and we encouraging, but still the general population not following the counseling. There, I have seen in my practice also. Sometimes I explain maximum all the things to patients, and the transferring of the patient, the chances of the more with this condition also. If you tell the patients also this is a disease, this is the stage, and this is the treatment, and this is the outcome, then patients will be more chances to adhere that treatment. But in different scenario, if I explain everything, this patient will get good go to the counseling and that the fertilization, then come back, then everything. So they are afraid to delay the treatment. They are afraid to, they might have some bad impact of that procedure also. Still they have the lacking of the knowledge, lacking of education. I think over the time we can improve this one all over the country. I'm not saying that in our center is the condition also. I feeling that all over the country, the slightly it might be 2%, 5% is higher than our lower than, but still the condition our country is very similar in all the centers in there. So this is, but we have to take care of all the things. We will increase, we will all the time people will encourage and people will do the fertility and employment also. Thank you so much.
Thank you for the wonderful talk. We would like to Dr. Savita to honor Dr. Kapil Dev with a memento.
Yes, sir.
For those staying at a Crown Plaza, please note that the checkout time is at 12:30. You may keep your luggage safely at the registration desk. If you have not checked out, please do it early. Now, Dr. Priyanka Shah and Dr. Kaushal Jadeja will present a play on anxiety and depression.
We go down. Speak from them. Again, just begin. क्या बोल रहे हैं?
Hello.
Hello, good morning, everyone. This is the
Hello.
Hello. Yeah, good morning, everyone. This is Dr. Kaushal Hadira and this is Dr. Priyanka Shah. I'm the assistant professor at TYAcon Medical College, Canada, and she is also working over there. We both work together, and today we are gonna address the common myths which are faced in day-to-day life by the cancer survivor patients. What the questions do they have? And we are gonna answer it over here by our play. Yes, ma'am. First myth. Yeah, so we are enacting a short play kind of thing, myth busters, basically. Next one. Yeah, so yes, so myth one, cancer patients not need mental health doctor. Yes, so the people say that only mad people go to a psychiatrist or go for counseling session. So we would like to bust the myth number one. Good morning, madam. I'm the patient over here. And yes, so madam, my daughter is surviving from the is has been diagnosed with stomach cancer and intestine cancer. And she seems तो लगती है कि वो उदास बैठी रहती है पूरे दिन भर. She cries whole day, and she doesn't go out, and पूरे दिन भर में वो अपने में ही रहती है. What should we do, doctor?
Hello, ma'am. Your daughter seems to have symptoms of depression. You can bring her to our clinic once. We will talk to her, and if required, we'll start her on treatment and also do counseling if needful.
इसको थोड़ा बहुत घबराहट बेचैनी के पूरे दिन में रहती है, रोती रहती है. So I'll bring her to you. Can you please do the counseling detailed checkup, and can you, is it so that only those who are unstable or those who are mentally weak go to a psychiatrist or go for counselor? मेरी डॉटर को एक्चुअली मैडम शी इज नॉट अनस्टेबल, उसको कैंसर डिटेक्ट डायग्नोज हुआ.
देखिए मैडम, ये एक बहुत बड़ी मिथ है कि मेंटली अनस्टेबल लोग या पागल लोग साइकियाट्रिस्ट के पास जाते हैं. ऐसा नहीं है. Because of the diagnosis of cancer, people can go into depression or can have anxiety features too. But it is very necessary to address them so that we can help them in recovery faster. Psychiatric medications will help them to recover faster. So it is necessary that you bring your daughter for the consultation and we'll start her on treatment right away if you want.
Thank you so much, doctor. It was पहले सब लोग बोलते हैं कि वो पागल तो क्या आप उसको साइकियाट्रिस्ट के पास क्यों ले जा रहा है. So it was my concern and my position. Thank you, doctor.
Myth two, that cancer patient cannot perform sexual intercourse. Hello, doctor. My husband has been recently diagnosed with colorectal cancer, just 1.5 years ago. So I had one huge query that can he perform sexual intercourse? Is it absolutely normal to perform sexual intercourse after the diagnosis of cancer?
Hello. Yes, I'm very sorry that your husband has been recently diagnosed with cancer. Yes, you can very well perform the sexual intercourse, and it is a myth that sexual intercourse से कैंसर स्प्रेड होगा, बट ये चीज नहीं है. कॉमन लोगों में ये चीज फैली हुई है that कैंसर पेशेंट को sexual intercourse नहीं करना चाहिए. But yes, they can very well perform it, and there is no harm with proper guidance, with proper medication, and to take medication, proper compliance. sexual intercourse is totally safe.
लेकिन सेक्सुअल इंटरकोर्स करने से उनकी रिकवरी पे थोड़ा धीरे नहीं हो जाएगी?
नहीं, बिल्कुल नहीं। एंड ये बिल्कुल ही गलत बात फैली हुई है लोगों में कि उसकी रिकवरी में कोई कोई भी अड़चन होगा या देयर विल बी सम हिंड्रेंस। ऐसा कुछ भी नहीं है। It is with proper time to time medication and proper counseling उनको ये एक कैंसर रिकवरी में भी हेल्प करेगा and with proper support everything is possible.
Okay, thank you so much, doctor. So this is another big myth that cancer patients can't perform normal sexual intercourse. Actually, with proper guidance from the doctor, cancer patients can perform sexual intercourse. In fact, having sexual intimacy will increase the comfort level, reduce the anxiety, and help in recovering from cancer faster.
So the third myth commonly prevalent in all the survivors, all the ongoing treatment patients, and all those who have been recently diagnosed is, and even in elite classes, that psychiatric treatment lasts lifelong. Madam, good morning. My daughter has been diagnosed with breast cancer and she has been recommended the cancer treatment. And also being a female and also she is 21 years old. And so she is of the view that psychiatric medication नहीं लेगी, वो lifelong लेनी पड़ेगी, वो पूरी जिंदगी भर चलेगी। ये बात सच है क्या डॉक्टर?
No, this is not true. This is a myth prevalent here that psychiatric medication once started has to be taken lifelong. ऐसा नहीं है। जब कैंसर का डायग्नोसिस होता है तो पेशेंट को ऑब्वियसली नेगेटिव विचार आएंगे, उदासी लगेगी, शायद बेचैनी घबराहट भी हो जाए, ठीक है? तो थोड़ा वो तब तक ठीक है, लेकिन बहुत ज्यादा हो जाए डिप्रेशन, बातचीत करना बंद कर दे, घूमना फिरना बंद कर दे, लोगों काम पे जाना छोड़ दे, then in such cases treatment is required. And it is not necessary that treatment should last lifelong. We will start treatment for the faster recovery and as per their needs. Once the patient has been recovered, we'll slowly taper down the dose and stop all the medication.
ओके थैंक यू डॉक्टर एंड मैं उसको लेके आऊंगी आपके पास, आप उसको प्रॉपर गाइडेंस दे सकते हो प्लीज?
श्योर,
थैंक यू। So myth number 4, the commonly prevalent myth. Psychiatric medications have lot of side effects and drug interactions with anti-cancer drugs. Yeah, here I would like to say that this is a total myth. Side effects होती है, but side effects prevalent. जो rare side effects होती है वो नहीं गिनना है हमें, and it is we have to see the risk benefit ratio, and then we can start with the medications and also the anti-cancer drugs. What is the interaction of the psychiatric treatment, psychiatric medications with the anti-cancer drugs, and what are the prevalent ones, what are the rare ones, and risk benefit ratio weightage. We can start over.
Hello, doctor. My 15-year-old son has been diagnosed with some kind of blood cancer. So he has been depressed and he also has some features of anxiety since past few days, as told by my psychiatrist. And he has also been started with psychiatric drugs. He has been prescribed some psychiatric drugs. But I'm confused whether to start them or not, because I feel that psychiatric drugs might have very much side effects a huge amount of side effects as compared to other medication. Is it true, doctor?
See, here I would like to explain you this कि हाँ psychiatric medication हम बिल्कुल ले सकते हैं और वो उनकी recovery में भी it will help, it will be beneficial, but we have to see the risk benefit कि कितना उसको risk है कितना benefit है, उनकी कौन सी एंटी कैंसर ड्रग्स चल रही है, कौन से स्टेज में है, वो देख के फिर हम डिसाइड करेंगे एंड वी विल यस। तो ड्रग इंटरेक्शन होता है, आई एम नॉट डिनाइंग, बट उतना नहीं होता जितना कि लोग बाग बोलते हैं। So if at all given with proper guidance, with proper care, and with all the previous documents, we can definitely get this.
So, thank you so much, ma'am. I'll definitely bring her to you.
Sure.
So, this is another myth that psychiatric medications have a lot of side effects, and it also has some drug interaction with anti-cancer drugs. So, there are side effects and there are some common side effects, but it is as common as other medications, right? That patients would be taking paracetamol or antibiotics for treatment, but patients would not take psychiatric medication. Why? Because this is a big myth prevalent that there are a lot of side effects. So, whenever in your consultation, if you see any patient who has symptoms of anxiety, depression, do refer them to psychiatrist. Side effects are present, but they are minimal, and we definitely see drug-drug interaction before prescribing any medication. Thank you.
Thank you all. Thank you for having the patience and listening to them. Thank you.
थैंक यू बोथ द डॉक्टर्स। एक्चुअली यहाँ पे मैं बोलना चाहूंगी कि ये बहुत इम्पोर्टेंट था, ये रोल प्ले जो इन्होंने किया। बहुत सिंपल इंफॉर्मेशन थी, लेकिन ये इंफॉर्मेशन इतनी सिंपल होने के बावजूद भी कई बार इग्नोर हो जाती है। मैं साइको ऑन्कोलॉजिस्ट हूँ और टाटा हॉस्पिटल में एक बिल्कुल सिस्टमेटिक साइको ऑन्कोलॉजी क्लिनिक चलता है, जहाँ पर साइकोलॉजिस्ट जो साइको ऑन्कोलॉजिस्ट होते हैं, जिन्हें पूरी तरीके से कैंसर के ट्रीटमेंट और आने वाले हर एक पड़ाव के बारे में पता होता है, वो और साइकाट्रिस्ट एक साथ काम करते हैं, एक साथ पेशेंट्स देखते हैं। तो ये जो सारी बातें इन्होंने यहाँ पर जो बताई है बहुत इम्पोर्टेंट है। कई बार ट्रीटमेंट के दौरान जो पहले से मेडिसिन चलते रहते हैं, उन्हें रीअसेस करना पड़ता है कीमो के दौरान या दूसरे ट्रीटमेंट के दौरान। कई बार नई ट्रीटमेंट की जरूरत पड़ती है, क्योंकि ट्रीटमेंट के दौरान कुछ मानसिक उलझने हो सकती है जो मानसिक रूप से नहीं होती है, कई बार साइड इफेक्ट्स की वजह से भी हो सकती है, लेकिन साइकियाट्रिस्ट या साइकोलॉजिस्ट उसको बहुत अच्छे से एक दूसरे के साथ मिलकर मैनेज कर सकते हैं। तो अगर आपको कभी भी कोई भी मानसिक तकलीफ हो गई, तो आपको ये समझना जरूरी है कि साइको ऑन्कोलॉजी या फिर साइकियाट्रिक केयर कैंसर के साथ उसके साथ मिलके वो करना बहुत जरूरी है। आई थिंक दिस वाज वेरी वेरी इंपॉर्टेंट। थैंक यू सो मच फॉर प्रेजेंटिंग दिस। और व्हाट इज नेक्स्ट? पैनल डिस्कशन है। पैनल डिस्कशन
Thank you to the performers for this impactful play. We would like to request Dr. Savita Goswami to honor Dr. Priyanka Shah and Dr. Kaushal Jadeja with a memento.
Yes. Thank you. Yes. Thank you.
And I also request Anjali ma'am to give memento to Dr. Savita Goswami.
Yes, ma'am.
This will be followed by a panel discussion on approach to the new normal moderated by Dr. Darshna Thakkar. She is a gynecologist and as well as a motivator. And the panelists, Dr. Priyanka Shah, Mr. British Kanwar, Mr. Shainik Shah, Ms. Sachi Parekh, Mr. Krishna Jat, Mr. Shivam, and Mr. Pranshu. And Mr. Jaimin Patel also.
So I know it's been too difficult to be the last session. અને પછી તમારા ઓળખીતાઓનું performance પતી જાય તો હોલમાંથી બહાર જવાની પણ એટલી ઉતાવળ હોય. I know that there are some other people in the audience who doesn't know Gujarati. How many of you Gujarati કેટલા લોકોને નથી આવડતી? क्या बोला मैंने? बस इतना ही बोलूंगा. हाँ, so be comfortable. हम उनकी पंजाबी में से समझ लेते थे तो आप थोड़ा हमारा गुजराती भी समझ लेते. प्लीज कम. वैसे भी अपने पास समय कम है. So this is exactly like what happens in cancer diagnosis and treatment. अगर डायग्नोसिस में देर हो गई ना तो ट्रीटमेंट में देर हो जाती है, सर्वाइवरशिप बदल जाती है. यही हाल कॉन्फ्रेंसिस में होता है. अगर एक सेशन देर से शुरू हुआ तो सब सेशन देर से शुरू होते हैं एंड द लास्ट सेशन गेट सफर्ड द मोस्ट. एंड वी विल ट्राई कि आप जितने भी लोग बैठे हो उनको उतना वर्थ लगेगा that it's worth sitting inside. So thank you for being here. I'm Dr. Darshana, gynecologist practitioner in Ahmedabad since 30 years. I'm so happy that it has get delayed and it gave me an opportunity कि पिछले करीब 11 बजे से मैं यहाँ हूँ because my session was at 11:10. And I'm at peace for the reason that gynecologist को आदत होती है कि अभी बच्चा आएगा. So it has finally delivered on time. And in this about 2 hours time, ये 2 घंटे में जितना ज्यादा सुनाई दिया इधर बैठ के, because आवा बहन के साथ मैंने रेजिडेंसी में काम किया हुआ है, वहां से लेके जितना भी यहाँ बैठ के सुना, I'm happy that TYAcon is bringing in all the aspect in cancer beyond cancer treatment. So while she was talking about oncopsychology, I think this is the right point where I can pick it up for the next session. And in my practice, gynecology ke saath, I have done a lot of work and I'm working for last 20 years on the emotional health along with perfect medical practice. So ये देख के मेरे को खुशी हो रही है कि we need such more collaborative efforts. That the modern medicine has its own way to deal with disease, but at the same time, the psychology aspect जो है disease का, emotional aspect है, उसको भी अगर हम उतना ही वजन देंगे, तो not only survivorship but the life will change. And that's when we start this panel with 20 minutes. अला आपला માંથી તો timer જ કાઢ નાખ્યું 20 minute. ભાઈ મૂકો અહીંયા 20 minute. I have been using every single minute. वैसे भी have power कि हम 1 घंटा बात करेंगे तो आप कोई उठेंगे नहीं, उतना नहीं कर सकते हो, पर वो करना नहीं है because everybody is hungry. So we have all these amazing people sitting here, -1 doctor. Everybody is a survivor. So a great round of applause for them and to their doctors and to their families. जिनकी वजह से आप सब यहाँ हो, है ना? How many of you can agree that कोई मारी जोड़े ना हो तो भी मैं यहाँ लड़त करी ना की होता है उन जीती जा? एवं कोई थी तो आज नहीं करता है. That is just not possible. All of us need that support, warmth. And अगर सिर्फ मेडिसिन से होता तो किसी को रिकरेंस नहीं होता. अगर सर्जरी ही उसका जवाब था तो किसी को रिकरेंस नहीं होता. रिकरेंस होता क्यों है? वहां से ये बात मैं लेके आ रही हूँ because I see a lot of breast cancer patients being a gynecologist, dealing with uterine cancer and ovarian cancer and preserving fertility and the social aspect of the cancer. At this moment, at this juncture, I sincerely thank Dr. Bhavesh Parekh for this opportunity for me to be here. He's been a dear friend ever since we were having prefix DR. हमारी दोस्ती इतने सालों से है and I'm proud of him having such amazing platform created here in the city of Ahmedabad. So in 20 minutes and having 7 minutes on the mathematics, we have less than 3 minutes for each one. પતા હે ના? તો બધા પોતાના જવાબ 1.5 મિનિટનો રાખવાનો છે. Done? And we'll prove that we can finish it in 20 minutes. કારણ કે 3 મિનિટ મેં લઈ લીધી. અને હમણાં જ ડોક્ટરે કહ્યું આ બધી બીચને ભાંગીને ભૂખો કરી નાખ્યો. So we will start from the youngest first and the ladies first. माइक ले रहा है. जब पहली बार तुम्हें पता चला कि कैंसर हुआ है तो कैसा लगा था?
It was a normal experience because at time I was only 12 or 13 years old, so I had no experience of this. And
A message to take home. Ignorance is bliss. कैंसर की सीवियरिटी पता नहीं है तो चिंता भी नहीं है. And there comes the role of parents की पेरेंट उनके कहाँ है उसको पूछना पड़ेगा कि कैसा लगा था. पहली बार खाओ पड़ी तो કેવું લાગેલું? બહુ દુઃખ લાગેલું ને પછી બહુ દુઃખ તે શબ્દમાં કહેવામાં આવે તો કેવું? ના હું અહીંયાથી બોલી લઈશ વાંધો નહીં બહુ નહીં કરો. બહુ દુઃખ એટલે શું? આપણે બહુ દુઃખ એટલે શું? બહુ દુઃખ એટલે શું? See, we need to have more of emotional literacy to understand how we feel. We are taught only since childhood good, bad and ugly. કોઈને પણ પૂછો ને લોગરે was asking કેમ છો મજામાં. So even if you ask anybody કેમ છો બેસી જાઓ આપણી પાસે એક જ જવાબ છે મજામાં. અને એમ કહો ને કે આપ આજ તો ઉદાસ લગ रहे हो थोड़ा. अरे भी नहीं ऐसा तो कुछ नहीं है. And we try to hide yes or no. So that separation is also an inviting factor to cancer. मैं ऐसे बीच बीच में वन लाइनर देती रहूंगी. ट्रीटमेंट के बाद कैसा लगा? ट्रीटमेंट वाली जर्नी कैसी थी?
मतलब थोड़ी सैड थोड़ी हैप्पी बट
थोड़ी खुशी थोड़ा गम आ गया. हाँ वो गम क्या था?
कुछ नहीं मैं स्कूल नहीं जा पाती थी घर से बाहर नहीं निकल पाती थी.
कैसा लगता था दोस्तों से नहीं मिलके?
वैसे तो मैं हर रोज बात करती थी मोबाइल पे और मेरी दोस्तों
जब सब ठीक हो गया दोस्तों से मिल रहे हो तो व्हाट इज न्यू नॉर्मल इन योर लाइफ?
It was very well when I first go to school after treatment. It was very best. My teachers also give me a good wishes and also they also visit me to home when I was not going to school. So it was very well.
So the warmth that comes up from academic institute also adds on a lot of the recovery. Thank you so much and we wish you all the best. The next man, કેટલા વાગે તારી ઘડિયાળમાં? પોણા એક. હળવદનો છોકરો છે આની જોડે અંગ્રેજીમાં કે હિન્દીમાં વાત કરું તો ગુજરાતીનું એકદમ ઘોર અપમાન થઈ જાય એટલે મેં જોડે ગુજરાતી વાત કરીશ. ના ના એને ડોક્ટર કહેતા હતા કે અમે ઘડિયાળથી ઓળખીએ છીએ કારણ કે મોટા ડાયલની ઘડિયાળ પહેરે છે. અને તને મોટા ડાયલની ઘડિયાળ કેમ ગમે છે? પહેલાથી આ જ પહેરવી પણ આ કેમ ગમે છે? બીજી નથી ગમતી. That you don't know. તને પહેલી વાર તારા ડોક્ટરે કોઈએ કીધું હશે કે બેટા તને આવી બીમારી થઈ છે તો કેવું લાગે? છ વર્ષનો હતો પછી ખબર પડી ત્યારે કેવું લાગ્યું? કેમ પહેલો સવાલ શું ઉઠ્યો જાણી ત્યારે મનમાંથી? આવું કેમ થયું? બીજો સવાલ શું હતો? બીજો કઈ એને મટી ગયું પછી કેવું લાગ્યું? બચી ગયો તો સારું લાગ્યું. હવે બચી ગયા પછી શું કરવું છે? આગળ તો વધવાનું છે. કેલેન્ડરમાં પાના ફાટે એટલે નવી વર્ષગાંઠ તો આવી જાય. તારે શું કરવું આગળ વધીને? બેડમિન્ટન પ્લેયર બનવું છે. કેમ? જિંદગી તાર બધું ગમતું જ કરવું છે. ઘડિયાળ હોય બેગ છોકરી भी गमती लाएंगे. आपने आज जो बात कही ना उसको अच्छा लगेगा कि बीवी तो मिल ही जाएगी. અહીંયા આઈ કેવું લાગે છે? આમ સ્ટેજ પર તને આટલા બધા માણસો સાંભળે છે તો નોર્મલ લાગે છે? યાર આને હજુ નંબર એવું નથી લાગતું. આટલા બધા સામે હોય મજા ના શરમ તો એની થાય એમને થાય આપણે બરોબર નું બોલીએ આપણે એમ કામ થયું ગયું. થેન્ક યુ તો કહી દો બધાને. થેન્ક યુ તાળી તો પાડો યાર. So message for us adult is that when they are children they don't know what C stands for cancer. and that's probably the blessing. So the role comes key. Family has to be little more aware. જેટલી ચિંતા છોકરાઓ નથી એટલું ફેમિલી માથા પર ચડતું હોય. So અગર family can remain strong and they can smile not only on the face but heart, તો એ લોકોની રિકવરી સારી થશે. એમ તો બિચારાને ખબર જ નથી પડતી પણ આજુબાજુવાળા એટલી કાગળોળ કરી મૂકે ને કે હવે આનું શું થશે. એનું એ જ થશે જે એના નસીબમાં લખ્યું છે. પણ તમારા રોવા ધોવાથી એનું નસીબ તમે વાંકું ચૂકું કરશો. So message for relative is that be strong and truly strong. Because if you pretend to be strong, they get the vibes. Am I right? Yes. કોને આપશું હવે ભાઈ તું કેને આપીએ આ ભાઈને આપું છું તને આ ભાઈમાંથી શું પ્રેરણા મળી છે પહેલી વાર મળે એટલે નથી ખબર તો માઈક એમને શું કામ દઈ દીધું તાર બાજુમાં આપું તો તમને આ ગમ્યું એટલે મજા ગમે કરવાનું છે હવે કહું છું મન ગમ્યું એટલે કર નાખ્યું આ કોઈ કશું નહીં કરે સો प्रॉब्लम नहीं. डॉक्टर फहद बशीर who is a physiologist, उन्होंने एक किताब लिखी है साइंस ऑफ इमोशन, जिसके अंदर लिखा है कि हम पहले बोलते थे कि मेरे कुटुंब में है तो मुझे आएगा, उसको कैंसर है, दादा को है तो मुझे हो सकता है कि नहीं, नानी को है तो मुझे हो सकता है कि नहीं. मीथ का लिस्ट तो बहुत लंबा है वैसे. But then Fahad Bashir says in the changing times 95% of the cancers are having epigenetic more than genetics. उसका मतलब ये हो रहा है कि हम आनुवंशिक बोलते हैं, उसके बदले हमारे अंदर और बाहर का जो एनवायरमेंट है उसकी वजह से होना, वो भी एक बहुत बड़ी बात समझने जैसी है. And this child so happy, गमे करवाना. And the more you become adult, हम क्या करते हैं, फिट इन होते हैं, सामने वाले को अच्छा होता है वो करते हैं, है ना. मैं उसको ये नहीं बोलूंगी तो कैसे लगेगा, ये बोलने से उसको खराब तो नहीं लग जाएगा, दूसरों को बुरा न लगे इसलिए हम बहुत बुरा सहन कर लेते हैं. So this is a lesson and a message to be taken. मन की करो, और मन की बात बोलने को प्राइम मिनिस्टर होना जरूरी नहीं है, हम भी कर सकते हैं. So over to you, dashing engineer who is an IT professional, Brijesh, and આ બધાએ કેન્સરને ગુડ બાય કરેલું છે. They are all survivors. આ 5-6-7 વર્ષ ડાયગ્નોસિસ વાળા પણ છે, ટીનેજમાં ડાયગ્નોસિસ વાળા પણ છે, અને લેટેસ્ટ ડાયગ્નોસિસ વાળા પણ છે. So Vijay and all the team who has chosen this amazing people, kudos to the team. A question for you. What was your first thought when you knew that मुझे कैंसर हुआ?
It was a normal day.
हाँ यार बड़ा खराब आंसर छोड़ी लाया है, नॉर्मल है.
મારા ડોક્ટર ભાવેશ પારેખ કે મમ્મીને કેવું બોલ્યું હતું કે તમારે કામ હોય તો મને ફોન કરો, હું તમારી સાસુ ને
हाँ करेंगे, ट्रांसलेट करेंगे, माइक का वॉल्यूम दे.
Yes.
Yes. So thank you भाई, सरस दौड़ो છે તમે. બહુ ઓછા માઇક વાળા આવી સરસ મહેનત કરતા હોય છે.
મને શું થવાનું છે, ભાવેશ સરે મમ્મીને કહી દીધું હતું કે તમે મારા વહુ અને હું તમારી સાસુ, તો પછી મારે શું ટેન્શન લેવાનું.
વાહ, કેટલા વર્ષ થયા મટી ગયા?
2017 માં ડિટેક્ટ થયું તો
So 17 to 25, it is 8 years journey. Yes. Tell me one most memorable event of your life in last 8 years that touched you the most.
તો મેમોરેબલમાં વાત કરીએ તો એક તો રિકવરી તો છે, પણ એનાથી વધારે જે જોયફુલ મોમેન્ટ કહીએ તો કોલેજનું પ્લેસમેન્ટ છે.
નોકરી મિલ ગઈ. લગન થઈ ગયા કે બાકી?
ના, લગન નહીં થયા, બાકી છે.
તે કરના ઇનકે लिए अच्छी
આપણે
मिल जाए.
આવક નથી અત્યારે, અત્યારે આપણું
અને hurtful moment being a cancer patient and survivor.
હું બેઝિકલી નેગેટિવ પોઈન્ટ્સ યાદ રાખતો નથી.
આપણે નથી રાખવા આવતા બેટા, આપણી નર્વસ સિસ્ટમ તો સ્કોર કરી લે છે.
તો મારી પાસે આન્સર મારે વિચારવો પડશે 5 મિનિટ તો બી
વિચારીને ફરી કહેજો. This is how pretend and then comes hiding. Our nervous system keeps the score. हम कितना भी कर ले, it doesn't imprint. पुराने जमाने में वो बर्तन पे नाम लिखा करते थे मशीन से, जिनको अगर याद है. अभी तो डिस्पोजेबल का जमाना है, शायद ये जो लोग डाई नहीं करते उन्होंने देखा नहीं होगा वो. But there had to be a system जिसमें स्टील के बर्तन के ऊपर लिखा जाता था. उसी हिसाब से there is a book, body keeps the score, है ना. 565 पन्ने की किताब है जो बॉडी कीप द स्कोर. छोटा सा भी कुछ होता है ना, हम कहीं ना कहीं हमारी रजिस्टर में रखते हैं. यू आर एन आईटी प्रोफेशनल, अगर उससे बात करूं तो मेरा कंप्यूटर क्रैश हो गया, तो देयर आर 3 थिंग्स. यू कैन फॉर्मेट द हार्ड डिस्क, मेरा सब डेटा चला जाएगा जो मुझे नहीं पोसा, है ना, उसको बदल दो. तो भी डेटा अंदर है नहीं घुस सकता एंड उसको सिर्फ स्कैन में रखो, वायरल स्कैन में। सो अगर वायरल स्कैन में रखो बोलते हो ना, तो मेमोरी लाइन को वायरल स्कैन में रखोगे एंटीवायरस पे, तब भी वो हर्टफुल मोमेंट मिल जाएगा, जॉयफुल मोमेंट भी मिल जाएगा। करेक्ट। पर अगर मदरबोर्ड को भी फॉर्मेट करने के लिए सोचोगे ना, तो भी उसकी कोई प्रिंट तो रहेगी, एंड दैट इज व्हाट द मेमोरी लाइन कीप्स इन द स्कोप। Yes, so it's good to be positive, but at the same time, it is also essential to accept the negative side. Yes or no? है ना? हम हमारे दुख को भी दबा देते हैं, and any suppression has power to bring illness, from acidity to cancer, anything. पर तू याद करेंगे जी करो. I think મારી પાસે છે એનો આન્સર હવે. Here we are. So મોસ્ટ પેઇનફુલ થિંગ હું આઈ થિંક હું કહીશ તો કે હું જોઈન્ટ ફેમિલીમાં મોટો થયો છું, તો જ્યારે સિટી ચેન્જ કરવો પડ્યો, આઈ એમ ફ્રોમ બોમ્બે બેસિકલી, તો મારી કોલેજ બી ગાંધીનગરમાં થઈ છે, હું જોબ બી અમદાવાદમાં કરું છું, so now we have to step to Ahmedabad, right? So that shifting moment was the most painful for why, because I like friends, I have friends, few of them, one or two, but મારા માટે મેઇન પ્રાયોરિટી મારી ફેમિલી, મારા કઝિન્સ, મારા સિબ્લિંગ્સ છે. તો એ જે હવે ફૂલ ફેમિલીની જગ્યાએ હવે અહીં જે 3-4 જણને રહેવાનું છે, એ મારા માટે છે કે ઓકે મિસિંગ પીપલ. યસ, હા, ઓલરાઈટ. સો ધેટ ગિવ્સ અ લોટ ઓફ વાર્મ્થ. જે લોકો આ મેન્ટેનન્સ થેરાપીની વાત કરતા હોય ને, તો મેન્ટેનન્સ થેરાપી ઇઝ નોટ ઓન્લી ધી ટેબ્લેટ ધેટ પુટ્સ યોર cells down. It is also the family love and the warmth is a major maintenance therapy which everyone needs. Hey, sir, आपके लिए mic. So he is Dr. Shivam, a physiotherapist by profession, and he has conquered cancer. क्या करना बेटर, आप वहां वीडियो करें, तब एक बार ऊपर दिखाओ. Behind every successful man there is always a woman, and she is the one. आप कुछ कहना चाहेंगे? How is your journey with his cancer? लेकिन मैं घबराओ जो, this is fear factor. I'm just trying to bring out the emotions out of the journey. याद करवानी શું અનુભવ હોય છે? How do you feel when you recall that? So એ દુઃખને ક્યારે સમજેલી દેવું છે? કેન્સર તો જતું રહ્યું, હવે દુઃખને તો મોકલી દો. See, people get treated, but they keep holding on to the hurt and the fear, and that's even detrimental. So कैंसर गया, अभी सेलिब्रेट करना है, fear क्यों है? किस चीज का fear है और किस चीज का दुख है? तो कि कैंसर आया, झगड़ा किससे है? झगड़ा किससे है? कैंसर आया क्यों? हाँ, नजीक રાખીને બોલો. આ સવાલ કોને પૂછવાનો છે? કેન્સર આયા ક્यों? એટલે એમને કે તમારે તમને બંને એકબીજા ભાઈ, એટલે એમને થયું છે, તમારે શું સવાલ છે? અમારા હાથમાં છે જ નહીં ને. હા, જો એ તો કહે છે અમારા હાથમાં છે જ નહીં, તો સવાલ જ નકામ છે. લો ડિલીટ. ये डिलीट हो
જ્યારે કેન્સર આવે ત્યારે હું તો એવું વિચારતો કે જ્યારે મને પેથોલોજી વાળાએ કીધું કે ભાઈ તમને કેન્સર જેવું લાગે છે, આપણે પેલા બાયોપ્સી કરાવી હતી, મેં કીધું ભાઈ હોય જ નહીં, મેં કીધું મને કેન્સર, મેં કીધું હું તો એકદમ સ્વસ્થ છું, વર્કઆઉટ કરી છું,
One more week.
કરું છું, બરાબર. તો મેં કીધું રેગ્યુલર મેડિટેશન પ્રાણાયામ બધું, મેં કીધું મને કેન્સર થાય જ નહીં, મેં કીધું બીજા કોકનું મેં જોઈ લીધો લાગે છે તમે.
So the first thing comes is a doubt and denial. Diagnosis को digest करना बहुत ही मुश्किल होता है. Thank you. So every journey has a different emotion. हमने हमारा ऑफिस में there was a woman with elderly woman around 66, and when I was breaking the diagnosis कि आपको स्तन का कैंसर है, and her first reaction, हाय हाय मेरे ऐसे कर्म कि मेरे को हुआ. This is how she said. So the myths are many कि मैंने कुछ तो गलत काम जीवन में किया होगा तो मुझे आया. And the next reaction was कि लोग जानेंगे तो क्या कहेंगे. So क्या कहेंगे लोग is the सबसे बड़ा रोग, even that applies to cancer. शिवम, physiotherapist तरीके આ બધી સારવાર લીધા પછી how do you feel and what is the side effect that you are still struggling to overcome?
ફિઝિયોથેરાપી પહેલા તો કેવું કે મને વિઝનનો પ્રોબ્લેમ પહેલેથી જ હતો, જન્મથી રેટિના પિગમેન્ટ પ્રકારનો પ્રોબ્લેમ, અને એમાં પણ કેન્સર આવ્યું. પહેલા તો આપણે એને માનતા જ નતા કે આપણને આવે, બરાબર. અને પછી એ પહેલી વાર જ્યારે ના માન્યું, અને પછી ડોક્ટરે પણ આપણો હિસ્ટોકેમિસ્ટ્રી ટેસ્ટ કર્યો, એમાં પણ ના આવ્યું મારું કેન્સર. એટલે ભાઈ જે ભગવાનની માનતા કરી બધાએ કરી દીધી, બધી પૂરી કરી દીધી. પછી ગાંઠ વધતી ગઈ. મેં સાહેબ ગાંઠ વધે છે, આનું રીઝન શું? મેં કંઈક તો લફડું છે. તો ફરી બધા રીટેસ્ટ કરાયા અને ફરી ગાંઠ બાયોપ્સીમાં આપી, ટાટા મેમોરિયલમાં આપી અને બોર્જીસ મેડમે કીધું કે ભાઈ હા કેન્સર છે. ત્યારે પછી મેં ફાઇનલી માન્યું કે હવે છે તો શું કરવું, હવે આગળ કઈ રીતે આનાથી લડવું. તો અમને ભાવેશ સર જેવા ડોક્ટર એમને આખી ટીમ મળી હતી. અને ભાવેશ સર એ વખતે એવું કીધું, જ્યારે કેન્સરમાં ફર્સ્ટ ટાઈમ જ્યારે અમે ગયા અને વાતચીત કરી સર સાથે, તો મેં કીધું સર આ મટશે ખરું? સર કે મટી જશે, આપણે તારી બેબીના લગ્નમાં આપણે જોડે ડિનર લઈશું.
મને બોલાવો.
ચોક્કસ
હું ડિલિવરી કરીશ.
એટલે ત્યારે મને કોન્ફિડન્સ બેઠો કે ના એ તો સારું જશે, કેમ કે સરે આટલું કોન્ફિડન્સ થી કીધું છે એટલે.
So the message here is that the doctor's confidence matters the most. ડોક્ટર ટીનુ ડાલુ બોલે ભાઈ બહુ હલવું જો તો તકલીફ પડી જશે તો એલો મરી જાય. But when you hear that hey, everything is going to be fine, तब वो आमिर खान याद रख लेने का all is well. That all is well really works. તમને બેન બરાબર દેખાય? એને વિઝનનો પ્રોબ્લેમ હોવા છતાં બરાબર જોઈ શકે ને એવી ધર્મપત્ની મળી શકે છે અને આ સમાજને આપણે બિરદાવવાનો છે. There we need to give big so many myths that we have કે તમને કશું થયું તો તમને સારું લાઈફ પાર્ટનર ના મળે એવું નથી. Thank you. જેવી બી આમ નોર્મલ અટાયરમાં છે એટલે વાંધો નહીં. પાછી બીક લાગે એવા ડિપાર્ટમેન્ટમાં કામ કરો છો હે સારું એ ભરતીમાં નથી આવ્યા.
ભાવેશ સાહેબે આશીર્વાદ એવા આપેલા.
હે હા આમ ગભરાઈ હોય આપણે પોલીસ દેખાય એટલે પહેલા ચલણ દેખાય કે હમણાં આમ ઝાડ પાછળથી આવશે હા આ બધા એફઆઈઆર વાળા ના ના હું તમને બહુ મજા કરાવી શકું એમ છું પણ હું સમયથી પાબંદ માણસ છું એટલે we'll talk in short. So we started with children who got it diagnosed at age 6, 7 and they have been so happily sailing through the normal life which is new normal for them. They may have a little change in the lifestyle. They may have to take some medicine as maintenance therapy. Their families are supporting them with the emotional maintenance therapy. But what if when it gets diagnosed late in age, wherein you are surrounded by a lot of responsibilities? You may be a bread earner, you may have a child who is manageable age, you may have a wife who is ailing through menopause. ऐसी उम्र में अगर कुछ आ गया तो क्या તમારું પહેલું રિએક્શન શું હતું તમને કેન્સર નિદાન મળી ત્યારે?
એકવાર હું બાઇક ચલાવી રહ્યો ત્યારે પડ્યો, ત્યારે અહીંયા દુખાવો પડ્યો. તો આયુર્વેદ ને બધું બહુ કર્યું, ન મળ્યું. મારા ફેમિલીમાં મારા બ્રધરે ભાવેશ સરનો કોન્ટેક્ટ કર્યો. ભાવેશ સરે ડૉક્ટર સૈનિક શાહ પાસે મોકલ્યો સિવિલ હોસ્પિટલ. એમણે મને રિપોર્ટ બાયોપ્સી બધું કરાવડાવ્યું અને કે તારી કિડનીની જોડે ગાંઠ છે, જીવવું હોય તો કિડની કાઢવી પડશે. હું કાઢી દઉં. એમણે કિડની કાઢી દીધી. પછી ભાવેશ સરનો કોન્ટેક્ટ કરાયો. ભાવેશ સરે કેન્સરને ડિટેક્ટ કરીને ઓનલી 18 મંથમાં 90% ઝીરો કર્યું. અને જો એમાં સપોર્ટ મળ્યો હોય ડૉક્ટર વિજય સર, આપણો
વિજયભાઈ ધન્યવાદ.
ડૉક્ટર નિશા મેમ, very proud of him.
કિડની કાઢ નાખવાનું કીધું ત્યારે કેવું લાગે? ભગવાને ત્યાં બહુ ઓફર આપેલી છે. તેના 2 કિડની એટલે એક નીકળી જાય તો ચાલે. હા એ લોકો ના કરો એવી ચિંતા ના કરો. કિડની નીકળી જાય તો પછી બાથરૂમમાં નહીં જવાનું ના એવું નહીં, બીજી કિડની કામ કરે.
દરેક રથયાત્રામાં સરસપુરથી જમાલપુર નિજ મંદિર સુધી રથની સાથે ચાલતો વિથ ક્રાઇમ બ્રાન્ચ જાઉં છું.
So this about religion also puts your immunity high. The way we have two kind of mobile phones, Apple and Android, similarly we have something in our mind and heart. There are two operating systems, fear and love. Fear enhances immunity, fear reduces immunity, love enhances immunity. जितना आप भय से जिंदगी को देखोगे उतना बीमार ज्यादा रहोगे. जितना जिंदगी से प्यार करना सीखोगे उतनी जिंदगी भी तुम्हें प्यार करेगी. So આ રથ સાથે જવું એક રિલિજિયસ ફેથ માત્ર નથી, એ પક્ષી ચાલીને જવાની પ્રક્રિયા નથી. એમાં એનું હૃદય એવું કહે છે કે હું આ કરીશ ને તો હું વધારે સ્વસ્થ રહીશ. So everybody's faith is different and we have to respect them. We the modern medicine practitioners who are hardcore allopathy doctors, we endorse this. એટલે એવું નથી કે તમને જો કોઈ એવી ખોટી માન્યતાઓ ડાક્ટર માટે પણ હોય કે એ લોકો કશું માને નહીં, આવું દીવાબત્તી પૂજા નાળિયેર આપણે કઈ વાંધો નહીં, 50 રૂપિયા ભગવાને ખરીદી લઈએ છીએ. કઈ થશે તો અણીએ રોજ દે બિચારા આટલું ઓછું ભરાય एंड वी हैव फेथ कि ये 5 दिया करने से हो जाएगा, एक नारियल फोड़ने से हो जाएगा, कुछ ना कुछ करने से हो जाएगा और हो जाता है. दैट इज व्हाट वी कॉल इट एज मैनिफेस्टेशन और विजुअलाइजेशन और अफर्मेशन. थैंक यू सो मच. यस એટલે સમયમાં તો એવું જ આ લોકોને પૂછી લો કેટલી મિનિટ બેસવું છે એ પ્રમાણે વાપરીએ.
બસ મારે એટલું જ કહેવું છે કે જ્યારે હું સિમ્સમાં ફર્સ્ટ ટાઈમ ગયો ત્યારે ફર્સ્ટ એન્ડ સેકન્ડ ટાઈમ જ મારા સાથે મારા રિલેટિવ હતા. આફ્ટર ધેન 2 years હું એકલો ત્યાં જઈને મારી ટ્રીટમેન્ટ મેળવું છું અને સંપૂર્ણ મને સપોર્ટ મળ્યો હોય વન્સ અગેન ડોક્ટર વિજય સર, ગીસા મેડમ, જયમીન પટેલ એન્ડ ભાવિશ સર હોલ ટીમ. થેન્ક યુ.
એટલે આવા હિંમતવાન પેશન્ટ હોય તો ફેમિલી પૂરી કરતા કે હું જઈ આવું તમારે આવવાની જરૂર નથી. હું ગાયનેકોલોજીસ્ટ છું એટલે મારા જોડે જુદું થતું હોય ઘણી વાર. बच्चा नहीं हो रहा है, 4 साल शादी के हो गए, ऐसा करके जो मेरी ऑफिस में एक झमेला आता है पूरा थोड़े लोगों का, उसमें वो स्त्री महिला जिसको बच्चा नहीं हो रहा है उसकी माँ होती है, उसकी सास होती है, उसकी बहन होती है, कई बार उसकी ननद भी हो सकती है. खाली एक ही इंसान नहीं है जो सबसे काम का है, हस्बैंड नहीं होता है. एंड व्हेन यू स्टार्ट एक्सप्लेनिंग तो वो सास खुद के बोलेगी मेरे बेटे में तो कोई दिक्कत नहीं है, उसको कोई तकलीफ नहीं हो सकती. आई वुड से तुम्हें कैसे पता? So family fantasy, all good and bad times. But made me radiotherapy આવું એટલા માટે હતાવું છું કે ઊંઘવાનો ટાઈમ છે, ભૂખ્યા થયા છે એટલે વચ્ચે વચ્ચે આવું કરી લો 2-3 મિનિટ. So like as he said that not every time the family has to be on toes and लगे रहो, छुट्टी लेके भागो, घर का काम छोड़ के भागो. They are capable of taking good care of themselves. And now I'll just ask one question to doctor and then the last one is to Shadify. કોઈ પણ ક્રિકેટની મેચ હોય ને તો આમ બે રીતે રમી શકાય. પહેલા તમે સચિનને ઉતારી દો એવું થાય અને યાર છેલ્લો એક બેટ્સમેન બહુ સરસ હોય એટલે we have the last batsman who can be actually 1 equal to 11 એટલે હું એમને હમણાં છેલ્લે વાત કરાવડાવું છું. આપણે બધાએ આ ડોક્ટરને જોયા busting the myth. ચલો આ ખોટું છે ને આવું ના હોય ને આવું કરાય. So many of the questions which I could have asked her here already they have answered. So I have one more question for her. एक सवाल ये पूछना है कि जो साइको ऑन्कोलॉजी का ब्रांच है या तो साइकियाट्री का ब्रांच है, इसको ज्यादा जरूरत पड़ेगी मरीज को या उसके फैमिली को?
See, actually,
चालू है, सिर्फ नजदीक रखना पड़ेगा.
actually, both of them equally require patient as well as family members.
हाँ दोनों को पड़ेगा. ज्यादा किसको पड़ेगा?
ज्यादा I guess family members.
So how many of you agree कि कैंसर मरीज के फैमिली को ज्यादा सपोर्ट की जरूरत रहेगी? हाँ, बिकॉज मरीज को तो सब कोई पूछ रहा है कैसा है भैया, तेरा पट्टी निकल गया, ड्रेसिंग कब है, फॉलो में कब जाना है, तू कैसा है, तेरे लिए फ्रूट लेके आए हैं. कभी हमने जाके अस्पताल में वो केयरटेकर को पूछा कि हाउ आर यू डूइंग, आप क्या महसूस कर रहे हो, आपको कैसा है? वो तो हम करते ही नहीं है. आपको खाना मिला कि नहीं, आपने खिलाया कि नहीं इज द स्टार्ट क्वेश्चन है. सो अगली बार से अगर आप कोई कह देना जरूरी नहीं है, कोई भी मरीज मिलने जाओ ना तो उतना कर लेना कि केयरटेकर से बात करना. ખાલી હવે આદમી એટલું તો પૂછી શકાય કે કેમ છો તમે, તમારે કસે આગા પાછા થવું છે, અડધો કલાક બેસીશ. ये भी एक बहुत बड़ी सेवा है. और हम कैसे जाते हैं, जैसे यहाँ बायोमेट्रिक्स पे लगाना होता है कि मैं आ गया, खबर काढ़ी लीधी, खबर काढ़वा નથી જવાનું, મદદ કરવા જવાનું હોય તો જવાનું, નહીં તો બહાર બજારમાં નહીં જવાનું. Right? And the second question, जब वो लोग आपके पास आते हैं, so what are the common emotions that you see in them?
We have both type of emotions, positive emotions as well as negative emotions. Positive emotions that they have concern for the patient, they feel hard to digest, and when family members don't digest, right? When family members are in denial, इनको तो cancer हो ही नहीं सकता, so it becomes difficult for patients recovery as well, because they will keep on watching के वापस जाके टेस्ट कराओ, वापस कंफर्म करो, दूसरे डॉक्टर के पास जाओ. So that is one of the area which we need to work on. Another thing, some people have negative emotions as well, like in lower socioeconomic class, when some male person is diagnosed with cancer, and family members will be overburdened and they will curse that person कि इनकी वजह से हमको कितनी दिक्कत हो रही है, इसकी वजह से हमको बार बार कीमो सेशन
The bitter truth of the society. And even if it is not male, and even if it is not low socioeconomic, let me give an example. A mother who takes care of everything in the house, every nook and corner of the home, and if she falls sick, forget about cancer, even if she has a fever, it becomes difficult for children or husband to manage the house. So when it comes to breast cancer, even a sequence that runs is मेरे बच्चे को कौन संभालेगा કારણ કે ઘરવાળા મોજા જ ના મળે પહેલા ટુવાલ ના મળે ના મળે તો એટલી બધી ટેવો બહેનોએ પાડી દીધેલી હોય that they cannot manage without them. Correct. So all such small little things pile up in the mind and they go into their offices like this. And most of the time, I guess she will agree to me that कितनी भी बार अगर मरीज के रिलेटिव बोलते हैं ना उनको कुछ हो जाएगा तो that's not concern about them and their life and their death. It's concern about me as caretaker कि उनको कुछ हो गया तो मेरा क्या होगा. But they will not say that. So it comes घुमा फिरा के कि उनको कुछ हो गया तो क्या. So thank you, doctor, for bringing these points. And now, as I said, we have Sachin Tendulkar put last to the match today. And he is Mr. Shrenik Shah from my own city, Ahmedabad, who has been internationally a motivational speaker talking about cancer awareness because he himself is a survivor. આપણે એવું હોય કે બોલવા માટે સૌથી મોંઘી અને મોટી જરૂરિયાત છે તે અવાજ છે. અને the way Mr. Dongre said about कि रिक्शा वाले का एक पैर नहीं है फिर भी वो ऑटो चला के जीवन चला रहा है, तो आवाज नहीं होने से भी उनकी आवाज पूरी दुनिया सुन रही है. So when God took away his natural voice, his will and his doctor's efforts put him to have, जब हम मोबाइल निकाल लेते हैं, जब हम चाबी निकाल लेते हैं, उसी तरह से he brings out from his pocket a simple small device that brings his voice back, and that voice has created noise of positivity across world. So presenting to you Shrenik Shah, no question, 3 minutes. આપણે બંને 33 મિનિટ કરી શકીએ એવા છીએ પણ તો
Today, you guys are not going to witness AI. It's not ChatGPT. It's not Siri at all. It's truly and truly human intelligence.
Absolutely.
Friends, we all are using smartphone every single day. And imagine smartphone is lost. What will happen? Now you have a smartphone, but there is no network. What will happen? And you have a smartphone, everything, but there is no Wi-Fi available. What will be your situation? कितना कुछ आएगा, कितना डिप्रेशन होगा, to the extent कि अगर आपके पास में मोबाइल है, मोबाइल फेंक देंगे. And friends, this is the life I'm living for last 28 years. There is more than 10,000 days. There is no natural voice, and this is I'm speaking all over the world. Okay, Jargon Valley. I'm humbled to create a world record. I was invited to deliver talk at Ames. I addressed over 1,000 attendees for 30 minutes. Got featured on Times Square twice. And for all dear psycho-oncologists, you know, there is one simple terminology that is SEMN. SEMN, that is, for those who do not know, SEMN is short-term memory loss. I redefined, re-engineered, and tested that HTML into an SMN, SMN, that is long-term specific memory loss. I have simply forgotten that I have lost my voice. I have simply forgotten that I had a stage 4 cancer. And believe me, I was struggling. I was struggling for survival before 28 years, as if I was drowning in water. But today, I'm sitting in front of you guys, and believe me, I am 306 category. Yes, 306 category. Blessed, vanquished by countless over 100,000 individuals all over the world as my well-wishers, and they are on my wings, and they are other that support their well-wishes, are helping me to touch the horizon. Women respect, we talked about the role of caregivers. My dear friends, believe me, the life or not a single survivor, whether cancer survivor or whatsoever. The life of cancer survivor is incomplete without caregivers. And I would rather probably love to dedicate this talk to all caregivers on this planet. And this is the best I can do that. Apart from that, when I'm really not here to promote myself because, media was very patronic or many you'll be surprised. I have created one more record, what record rather. I'm the first direct speaker, yes, first direct speaker in world. Until now, I have delivered 6 direct talk and one of my talk, which was in Hyderabad, stored among top 10, yes, top 10 in the world. So this is all about the life. And for me, is every day is a new normal. That is whatever I have achieved, I forget in the evening. And then, I'm getting ready for what is to be done tomorrow. That's it. Thank you so very much. And it is lovely to connect with everyone present here. Thank you so much. And I really want to express my deepest gratitude to all psycho-oncologists. Without you, guys, we are simply incomplete. Thank you so much, and I salute your dedication and timeless contributions. Thank you.
So while he's talking and it comes to you, it sounds like serious. He say an audio version, but all that comes out of such wonderful device, and this device has buttons which you could not have noticed. While he's talking, he's adjusting the space and keep pressing the button, and that's exactly what the children would do while playing PlayStation. And that's exactly what we guys do in laparoscopic surgery of seeing there and using our hands. So it requires a lot of mind-eye coordination to bring this voice out. है ना? So हम कई बार बोल सकते हैं फिर भी नहीं बोलते हैं. And that separation needs to go out. Why am I saying this? Yeah.
Friends, friends, it's all about having the courage, confidence, unwavering determination, and commitment. You know what? The voice which you are listening now, this voice was rejected before 28 years. People, when I started speaking in public, people were scared, people were running away. I mean, they were rather not able to understand what is going on. And you guys say, I have recycled, I have re-engineered, I have manifested that the rejection of my voice before 29 years. And last but not least, I am super, super grateful to all those individuals who have rejected my voice. If they have not rejected my voice, I would have not been sitting in front of you. Thank you.
इतना इम्पोर्टेंट को ऑपरेशन थिएटर में इस्तेमाल करने वाले मशीन्स है, बहुत बड़े महंगे मशीन्स है. उसी तरह से एक छोटी सी चीज भी इतनी ही इम्पोर्टेंट है फॉर द पेशेंट टू सर्वाइव. હવે મજા જ આવતી હશે ને બધા સાથે, પણ અહીંયા એક ભાઈ એવા ઉભા છે જો એમના હાથમાં AK-47 હોય તો હમણાં ટ્રિગર માર સામે લગાવી દેવા તૈયાર છે. Right. So yeah, I know that, and that's the reason I started that the always last session suffers the most, because फिर वो समय की पहचान होती है, तब तक तो चलता है ना, होता है, 5 मिनट ज्यादा दे दो, चलेगा. But I'm not going to take more time because as I said that I'm a gynecologist and to take the child on time and cut the cord is my job. So I can immediately cut the cord. अगर आपको बहुत ज्यादा सुनने की मजा आया तो सैनिक भाई का भी इंस्टा पेज है, इन सबको भी ढूंढ लेना. एंड फॉर मी इट्स बीन द इजीएस्ट थिंग टू फाइंड doconmission.net. आप बहुत कुछ ऐसी बातें सुन पाएंगे. थैंक्स टू एवरीबॉडी हु प्रेजेंट हियर. थैंक यू सो मच. આ ભાઈનો મેં ફોટો પાડો, મને કાયમ યાદ રહેશે. અરે અહીંયા આવી જાવ. અરે અમે બધા ફોટો પડાવે. આવી જાવ સિદ્ધાર્થ. તમે અમને સમયસર પૂરું કરાવી શક્યા. એમાં AK-47 હાથમાં આવવા માટે બી તો લાયકાત જોઈએ છે દોસ્ત. ચાલ આવી જાવ. He is in saying come, let's have a group photo. आओ शरीफ भाई.
Okay, everyone.
आइयो चलो.
આપણને આજે આ મેમ શ્રી ફાલ્ગુની પાઠકની યાદ છે.
અમારે ગાતા સર આ યાદના જલ્દી છે. હા યા.
યસ. વonderful.
Please come.
આજે રૂમમાં
Please come. કેમેરા વાળા હજુ 1 ફૂટ સુધી તમને કવર કરી દેશે. અને નહીં તો પછી ફોટોશોપમાં કાપી ચોટાડ.
Wonderful.
અમે મોટા છે. Yes.
રાજેશ સર વાળાને લંબાઈ બંને
Yes, sir, ફોટો જલ્દી ભાઈ હવે ફોટો જલ્દી નહીં પડા ઉડાડ દઈશ.
Yes. Okay, yes. Very great, yes. Thank you. Thank you. It's absolutely lovely.
A big round of a clap for our moderator who has guided today's session with such clarity, energy, making it smooth and interactive. Now we will request Chitalkar sir to honor Dr. Rajna Thakur with a memento.
તમને મળવાનો લાવો મળે. જસનાને કહે.
हाँ वो कर रहे हैं पर इधर जगह होगा तो करेंगे ना. वो भी नीचे कर.
Yes, sir.
It is my honor to welcome Mrs. Samina Mehboob Belgi from Gunwanti Jagannath Kapoor Foundation, who will speak on empowering journeys, psychosocial intervention for young cancer patients.
Thank you so much. I would like to, I'm sure it was a very wonderful presentation, and we really had a great time for the previous presentation. I promised to keep the presentation short so that, you know, you all can go back soon and have some good food. Yes. So my name is Samina. I'm a psychologist, and I've been working with Gunwati Kapoor Foundation since the last 10 years now. I will not be getting into a lot of details since the time that I have is very short. It's just 10 minutes today. Well, the foundation was established way back in 2001, and we were initially a funding organization. Only in 2013, we started our work at Tata Memorial Hospital, which is, of course, everyone knows it's the premier cancer institute in the country. And we started our work in one OPD, which is the adult hematolymphoid, and gradually we moved to 8 OPDs in the hospital. So we are working in Tata Hospital since the last 11 years now. And we are also working with the Kharghar branch of Tata Hospital, which is at Trek. And we also have a branch in Amritsar. We work in 2 hospitals, that is Sant Guru Ramdas Charitable and Government Medical College. So what's the exact mission of the foundation? The mission of the foundation is to support programs in education, healthcare, and social service. And what is the vision? Strengthening opportunities and improving overall quality of life. So just to give you a glimpse of the programs that we offer, one of the main programs, we offer the patient guidance program, which is to provide psychosocial support to cancer patients. I'll be talking a little about the program in detail in the next slide. We also offer cancer prevention and early detection. As we all know, and we have heard today, how much it is important to do cancer prevention and create awareness, right? We also have a program on Matrutva. Matrutva is nothing but postnatal and antenatal care, which is very important for women. And this program is done in urban slums of Mumbai. We also offer educational assistance for schools for children in the BMC schools. This is the overall graph that you see of the foundation support and work we have done. Approximately 3 lakhs life we have touched over the years with different kind of programs that we offer. I will be dwelling a little on the patient guidance program. So I'm sure the conference aims at AYA, which is the adolescent and young teens and adults. And the patient guidance program also has an important area where we focus on the AYA cancer. So when we started our work at Tata Hospital, we understood that it is very, very important to identify what's the need of patients coming to the hospital. And that's the reason our objective of this program was to help patients access the resources they need. As we know, in our country, we have a lot of philanthropy organizations. We have many resources. We have many people supporting. But if a patient comes to the hospital, where do they go to avail these services? I'm sure the hospital and the healthcare team, their focus is to help patients be compliant in treatment and help them complete treatment, right? That's the focus of the hospital. The patient and caregiver also have two important niche areas that they focus on. First, कि मेरे patient या रिश्तेदार का treatment हो जाए और definitely हमारे जो psychosocial issues हैं वो solve हो जाए. And eventual goal to come to a hospital is कि अच्छे से अच्छा treatment मिले और हम घर वापस जाए. Similarly, Gunmati Kapoor Foundation, when we launched this program, or patient guidance program, our goal was multiple fold. So we wanted to give psychosocial support to patients who are on treatment, and our focus was to help patient decrease the abandonment rate, because we all know cancer. जैसे मैडम ने बहुत अच्छे से बताया कितना dreaded word है cancer, चाहे वो बच्चे हो, चाहे वो teens हो, चाहे वो a geriatric population हो. So, Gunmati Kapoor Foundation, what we do is we provide psychosocial services. What does that mean? Psychosocial services, sorry, it includes the social aspects as well. Like now we were listening to so many people in the day, and we understood that cancer, of course, is a dreaded word, and the population that we cater to at the hospital are people from low to middle income background. Of course, they come with limited resources. Of course, they come with limited financial background. Of course, they come with limited educational background. So that makes it more difficult for them to accept the disease as well as to comply on treatment because of the cost of cancer. I'm sure we have gone to the civil hospital yesterday. We saw so many people running about. We saw so many people in pain. We could see people in distress, right? So then what do we do? Similarly, when we see patients who come to the hospital, the first goal is to provide them psychosocial support. Of course, breaking bad news is extremely difficult. And मैडम जैसे मैडम ने कहा जैसे वो डॉक्टर कॉन्फिडेंस से बोलता है पेशेंट्स का उस तरीके से हौसला बढ़ता है right? So that's the most important thing. So once the doctor breaks the bad news, the next important step comes in. Now, what do we do? What are the social issues? Yeah. So what are the social issues? So the social issues would be finance. So our team at the hospital, we have a staff of about 19 people working on ground. We work in various departments of the hospital, in Tata Hospital, in Punjab as well. And what we do is we guide them for documents, for financial guidance. I would request somebody if you can give me a bottle of water. Sorry. Sorry about that. So what we do is we guide them for finance, we guide them for resources that they need, we guide them for various NGOs, we guide them to various centers which help with financial support. Second important thing is patients, when they come for treatment, they not only have just they need access related to finance, but they also need access related to other facilities. When we talk to a breast cancer patient, when she loses a breast mastectomy, we know she needs a breast prosthesis. We know when people lose hair, they need a hair wig. We know people when they have an amputation, they need a limb, a prosthetic limb. So all these needs are very, very important, especially in young and adolescent population. And of course, the most important need, while all of this was going, like in my previous lecture, madam was saying emotions. Emotions is so high, not just the patient as well as the caregiver. So we do a lot of hand holding in terms of emotional support while they're on treatment. So the first most important thing is the distress screening. What does it mean by distress screening? We identify what is the need of the patient. Where does the background come from? What is the socioeconomic condition of the patient? Where is the patient staying? What are the education requirements that they have? What is the need of the patient? We map all of those. The second most important thing is once we have mapped the resources, once we have mapped or identified their need, the second important thing is we provide them services. most of the areas that we work with the medical oncologist very closely. So as soon as the patient is, the protocol is made for chemotherapy, I'm sure the doctors don't have time to discuss in detail about the side effects of chemotherapy. Sometimes the nurses are busy. So that's where we step in and we do a complete chemo education guide to the patients, because these patients are so scared. We get patients who say like, मैडम मुझे बीमारी से डर नहीं है, मुझे कीमोथेरेपी से डर है. I'm sure no matter how good Dr. Chidalkar sir might look, how good the doctors will be, but the chemotherapy is of course a very, very dreaded thing for them. So breaking the myths and misconception, that is very, very important. Giving them the right information. Second most important thing is when we do mental health support, a lot of times we have also seen patients are abandoned. The husband says, like to the wife, okay, so what good, how good it will be for me to stay with him because we don't have one breast. Sometimes when there are young teen girls who come to us, they're worried about future. They say like, madam, मेरा future क्या, मैं अभी just engage हुई थी, मेरी शादी होने वाली थी, मैं मेरे partner को अभी मैं क्या बताऊं. Sometimes they are at the peak of their career, they have planned to do something and suddenly the disease has come, so there is a stop gap, right? So I'm sure हम सबकी जिंदगी में कहीं ना कहीं थोड़ा भी stop आता है, हम कितना worried रहते हैं, right? So you can imagine this gap of 6 months. First, there is uncertainty about the disease. And second is the gap between the treatment. The treatment would be anywhere between 6 months to 1 year. There is a gap. So that is very important. So what we do is we handhold the patient, we guide them, we be with them while they are taking treatment at every step of the treatment. Say if the treatment is for 6 months, we will first map out what the needs, then we will provide them the assistance that's required, and then we will follow it up with these patients. The peer and family support. So at the hospital, especially with germ cell tumors, with the testicular cancer, we have started an annual support group. So whoever have been our beneficiaries in the last year, we invite them for these meetings so that they come and they share their stories. When you hear successful stories, you're motivated, And the most important thing is once you motivate one person, he or she, most of the times we have seen in the hospital, patients are sitting with others around. कुछ भी गलत खबर होती है, patient पहले एक दूसरे की सुनता है. So it is very important to empower that particular patient with the information, the right information. Educational support and work reintegration. We have survivors at our foundation. Our foundation supports and motivate cancer survivors to come. We have Chetan, we have Dinesh. These both are cancer survivors, So when reintegration into the society is very, very important, especially for young teen and adolescent. And the last but not the least, survivorship and the enhancement of QL, which is so important because most of these time when we talk to young teen and adolescent, we always hear they say, बीमारी अच्छी हो गई ना, अब ठीक है, अभी हमें आना है कि नहीं आना है, अब हम ठीक हो गए मैडम, अब हम आएंगे क्या. But as we all know, for cancer, it's a lifelong, there is a long survival or follow-up that they need to do, and that's very, very important. So these are some interventions that we do with young patients, especially with these cancers. With gynecological cancers, we do a lot of handhold and follow-up with patients with germ cell tumor because these are high curative intent patients. We do with GTN patients again, these are again young women with cancer. Some are married, some are not married. So, to break the myth of the family members. Here, it's not the young girl who's scared, but it's the family who's more concerned. Will she be able to marry? Will she be able to produce? Will she be able to have a reproductive health in place? So all these myths and misconceptions, we work up very closely with Dr. Jaya Ghosh at our hospital. Yes, in urology, we work a lot close with Dr. Amit Joshi and his team. We see testicular cancer patients and we follow it up. So बहुत सारे presentations में हमने सुना, it is very important when should we talk about oncofertility. And sometimes in some cases, it's very important that you start at the beginning of the treatment. Yes, sure. So urology cancers, we deal with the germ cell tumor. In breast, of course, we also talk about the young breast cancer patients. We do handhold, we do follow-up. And in bone and soft tissue, as we know, we deal with the young patients. Like I said, we do support group meetings with especially the bone and soft tissue and the urology. And we organize with Tata Memorial Hospital Women's Cancer Initiative. We organize a lot of support group meeting and we celebrate Women's International Day at the hospital as well. And these are a few survivors, who have been a beneficiary. And he's doing cycling with one leg. And he cycled about 3,000 kilometers himself, just with one leg, And he's really a motivator. He has also done And he's so concerned about the disability that on his cycle he has a donor box, like a donation box. So whichever whoever gives him donation, it goes towards the disability movement that he has started. And these are some survivors relevant.
मैं उत्तर प्रदेश का रहने वाला हूँ 2017 के स्टार्टिंग के मंथ में मैं निकल चुका था एक ऐसे अनजान सफर पर जिसकी कोई न तो मंजिल थी और न ही ठिकाना था। जी हाँ, मैं बात कर रहा हूँ मुंबई टाटा मेमोरियल हॉस्पिटल और अपने कैंसर ट्रीटमेंट जर्नी की। तो मुंबई में पहुंचने के बाद स्टार्टिंग के डेज तो हमने किसी तरह से सरवाइव कर लिए, लेकिन स्टार्टिंग में मैं जिस प्लेस पे रह रहा था वो प्लेस हॉस्पिटल से काफी दूरी पर था, इसलिए मुझे बहुत सारी समस्या का सामना करना पड़ता था। तो ऐसे ही ओपीडी में एक दिन मैंने एक शख्स को देखा जो लगातार एक के बाद अलग अलग पेशेंट की समस्या को सुन रहे थे और उनको प्रॉपर गाइडेंस दे रहे थे। वो शख्स कोई और नहीं, वे थे सभी बीएसटी पेशेंट्स के चहेते गुणवती जगन्नाथ कपूर फाउंडेशन के सोशल वर्कर मिस्टर सुशोभन राहा सर। सर से मिलने के बाद हमारी एक समस्या सॉल्व हो गई, जो थी रहने की समस्या। उनकी गाइडेंस से हमें हॉस्पिटल के पास में एक रूम मिल गया। इसके बाद पूरे ट्रीटमेंट जर्नी के दौरान गुणवती जगन्नाथ कपूर फाउंडेशन मेरे साथ रहा, चाहे वो ट्रीटमेंट कास्ट मैनेज करवाने की बात हो और चाहे इमोशनल ब्रेकडाउन के दौरान मोटिवेट करने की बात हो। कई बार क्या होता है कि ट्रीटमेंट जर्नी के दौरान हम लोग डीमोटिवेट हो जाते हैं। वैसे तो मैं पूरे ट्रीटमेंट जर्नी के दौरान खुद को सेल्फ मोटिवेटेड रखने की कोशिश करता था, लेकिन कई बार ऐसे मुझे इमोशनल ब्रेकडाउन का भी सामना करना पड़ जाता था। ऐसे समय में एक भाई की तरह सर हमारे साथ हमेशा खड़े रहे और जब भी हमें मोटिवेशन की जरूरत पड़ी तब तक उन्होंने हमें मोटिवेट भी किया। ट्रीटमेंट जर्नी के दौरान समय समय पर
So I think yes, thank you so much. I'm sure in short we have got the gist of what the foundation does, especially for the teen and young adolescent cancers. And I would like to thank Chitalkar sir for giving us this opportunity, and also not just patients we see who are young, but we also have a team which is young and vibrant who handles the work at the hospital and other places. Thank you so much once again for everyone for their patient list.
Thank you, ma'am. Thanks a lot. Now, the last, next slide. So I will request Chitalka sir and Bhavesh Parekh sir. So we have a poster presentation, and it was a everyone performed well, but the three winner we have Mrs. Dhruva Trivedi. Do we have her here? Please welcome me. Her topic was next generation sequencing approaches enhanced classification of oligodendroglioma. Next, we have Astha Parmar. Can we have? And one is Ruchi Sharma. She is not there. She had a flight.
Yesterday we announced that you have to be present here, but her flight was there, so we allowed her to go. But Ruchi Sharma is the third winner. So congratulations,
I congratulate both of you, Dhruva, Dhruva, right?
Yeah.
Sorry, Dhruva, Astha, and Ruchi.
So, they will share a prize of rupees 25,000 between the three of them. Is that? Yeah. So congratulations.
वो पैसा सुन के खुश हो गई
Yeah.
गुजराती
What's the Ruchi? You can take.
Yes, I'll take Ruchi then.
Yes, sir, please, sir, photo it. Yes, fine. Ajay, sir. Sir, please come. Please come. Yeah, good, sir. Good, sir. Yes. Wait, sir. Yes. Thank you, sir. Thank you.
So this year there was, unfortunately, we could not get the students here in the early in the morning in right time for the quiz at all. After waiting for sufficient long, so unfortunately there will be no quiz and so no quiz prize. So that's a loss, I can tell you that. It's a fantastic basic quiz created, and all uh, first year medical oncology, radiation oncology students, surgical oncology should actually go through it. It will be this is a basic primer we created through the quiz, and I think it's important that we all participate and benefit. Thank you.
Yeah, so valedictory, this is what valedictory. So I must thank Dr. Bhavesh, Dr. Pankaj Shah, the entire team, Mice Ideas, all the sponsors, um, and of course, all the Dr. Kurkure, everybody for such a wonderful meetings. And it is, I'm sure, as for my experience of 14 years, this has surely been the shortest notice. Was only maybe you should not count the month of June because I was not there. I did not have a single conversation with him. I was abroad. So and then there's actually just when we made the first conversation, there was an unfortunate incident of the air crash in Ahmedabad. So I actually made a radio silence for the next 10 days, and then I gradually started talking to Dr. Bhavesh. That too only WhatsApp messages. So actually only between July and September it has been put together. So that reminds us of the first ever TYAcon meeting in Faridabad was exactly done in 62 days between February 5th to April 11th. And the reason was February 5th was the day Yuvraj Singh's cancer was diagnosed. So they just took us to the TV studios and there were all kind of interviews going on. So that is, and the next day morning, we sat together, me and my resident in medicine, who's now the Major General in the Nepal Army. Last year he came. He's been coming for every TYAcon, but he could not come this year for the obvious reasons what are happening in Nepal. So, but otherwise he comes for every TYAcon. And him and us together, we put together the first meeting in 62 days. So I think it is close to that. It's as close as that. So thank you, Bhavesh Bhai, for a fantastic hospitality, fantastic scientific program. And I knew it will be like this. So that is the reason we approached you. So thank you very much. And I'm sure not far from today, we would like to come to this joyous city once again. At some, I mean, for some excuse or the other, it's actually fantastic. Thank you very much. Uh, and all your team, all the youngsters in your team, they are not only competent, they're very capable communicators, all of them. So I congratulate everyone, each one of the youngsters who have been behind this wonderful. And it's, as Dr. Pankaj said, it's a very homely place. And I think it's fantastic. So thank you very much.
Thank you everyone, especially Purna Kurkure madam and Dr. Chitalkar sir, Madam Chitalkar, for giving me opportunity. And I thank you, my young team. Can you please come on the dais? Please, Vijay bhai,
All of you.
please. Aniska, आजा, Arudanti, आजा. Yes, sir.
Come, come. You come.
That's, I cannot miss Rajesh Sharma of Mice Ideas. Please. Please.
Take the rules on this.
Sir.
I'll be in
the
middle.
Yes, yes. So thank you pharma company also for giving me so much help and so much put trust on me. Thank you everyone. And we had a delicious lunch also is waiting for us.
फोटो लेते हैं प्लीज सर ग्रुप फोटो प्लीज
आजा आजा
प्लीज प्लीज कम प्लीज कम प्लीज कम क्विक डन आइए सर आइए मैम आ जाओ दोनों आजा आजा पूर्ण फैकल्टी
You are the founder.
she's a founder president.
Yes.
Nice. And actually the inspiration there. Much
madam.
પેલું છે ને એટલા માટે
She's very SOP. Ajo. Savita, come. Ajo. अरे you don't इधर आ जाओ थोड़ा इस साइड
नहीं नहीं
कुर्सी लगा दे के आगे
नहीं आई got it.
खड़ी ना होता
आगे बेसिक
તમને વહી દેજો
છોકરા આગળ બેસી જાઓ
આવી જશે સર આવી જશે સર આવી જશે
હા અર્ચના जी आ जाओ इधर आओ
ભાઈ થોડા વધારે આવી જાઓ
हां कम बेस जाओ
ये अब तो और आज और दोनों हाँ हाँ बस बस बोले सही आ जाओ यहाँ पे जगह देखो आप पहले 3 लोगों को नीचे बिठाया मैंने
Thank you. Wait, please, sir. Yes. 3 cheers for TYAcon 25. Hip hip. Hip hip. Hip hip. Thank you, sir. Thank you.
Thank you.
National. Yes.
नीचे जाके
Please stand up for national anthem. हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जय गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय जय हे
भारत माता की भारत माता की
जय
भारत माता की
जय
वंदे
अर्चना मैडम की जय हो.
भावेश पालिक पंछी
Uh,